while playing. On examination, his best corrected visual acuity was finger counting at 3 meters with 360-degree limbal ischemia, with total macular corneal haze and rest anterior segment details were not appreciable. So what we did, we harvested the healthy conjunctival stem cell from the other healthy eye, as you can see in this picture. So gradually and slowly, we dissected it at the presumed stem cell site at 2 o'clock hour position. Then it was sutured again with the help of 8-0 Vicryl suture. Then we started the 360-degree conjunctival peritomy of the unhealthy alkali burn eye, as you can see, with the help of Vanna's scissor, using blunt and sharp dissection all around the 360-degree, because there was 360-degree limbal ischemia. So this conjunctival pannus was removed along with the tenons and the fibrous tissue. Then corneal debulking was done and the unhealthy epithelium that was removed very gently and finally to avoid any buttonholing and any perforation of the remaining cornea. Then a freshly prepared human amniotic membrane was prepared and was placed over the cornea with the basement side up, as you can see. So it was placed all over. Then the folds were removed and it was cut all around his degree to get the shape, round shape. Then this fibrin glue was placed in the superior quadrant to adhere this human amniotic membrane with the help of non-traumatic forceps. Same was repeated on the inferior side also, and then it was tucked. Now this conjunctival stem cell, this was removed from the basal salt solution to prevent it from dry, and it was cut into 8 to 10 pieces, very fine pieces, and were placed in the paracentral area, avoiding the pupillary axis or the visual axis. With the epithelial side up, that can be judged by its pigmented part. Now you can see it has been placed in the paracentral part. Again, fibrin glue was put at all the pieces. Then this B cell was placed over the cornea and it was kept there for 10 days. And it was removed after 10 days. So, for surgical pulse for a successful slat, preoperatively evaluation of the donor cornea, because we need to know the harvesting site, that should be the superior lumbus and it should be healthy. And recipient cornea, that should also be evaluated because it should be wet and no existing adnexal pathologies, and presence of underlying stromal scarring and corneal thickness, that should be adjusted using anterior segment OCT. Intraoperatively, the blade needs to be kept parallel to dissecting plane to avoid a buttonholing or deep dissection, which may include corneal stroma. Any sembliferon should be excised first and ensure that the grafts are placed in the correct orientation with the epithelial setup and allow sufficient time for the glue to polymerize. So it is a novel technique, the simple limbal epithelial transplant for the treatment of limbal stem cell deficiency, and it is very cheap, economical, and very good for the Indian ocular setup, because it takes 5 lakh lesser as compared to the this conjunctival limbal epithelial transplant, that is the ex vivo making of this graft. So it is very superior as compared to the clad So as we compare CLAT versus SLAT, this is an in vivo expansion, single sitting surgery, anatomical success rate very high. It is 77.8% in children. And overall healing of cornea takes lesser time, so visual rehabilitation is faster. Surgical cost is only 5 to 10% of CLAT. It is more accessible and financially attractive surgical technique to treat limbal stem cell deficiency. And my references are economic and clinical and social impact of SLAT for limbal stem cell deficiency. So after the surgery, the patient visual acuity improved to 6/24. As you can see, the patient visual acuity increased to 6/24. Thank you so very much.
Thank you so much, Dr. Arvind. Now, may I please invite Dr. Bharat Gurnani for the next video.
Yes, sir. Can I share my screen, sir? Good morning, everyone.
Yes, sir. Dr. Bharat, I request you to start screen sharing.
Yes, sir. Is the slide visible, sir?
Visible.
Yes.
In this video, we will depict how respirators are sterilized using an innovative idea of UH. As we all know, due to growing coronavirus pandemic, the daily demand and utilization of masks has increased exponentially. This has contributed for acute shortage of PPE worldwide. The need to safely secure PPE has been highlighted and is already in practice at higher centers like AIIMS and Nebraska Medical Center, Oman. A number of innovative ideas for reuse of respirators have been practiced across the globe. At Nebraska Medical Center, ultraviolet lights have been installed in a closed room and is used for decontamination of respirators. Keeping this in mind, we thought of replicating this concept by using an airtight container and ultraviolet lights. So, here we propose a jugaad idea of UH by using UV light and an old condemned refrigerator. With the help of our medical team, we arranged for old refrigerators and freezer boxes. Subsequently, UVC light and reflective mirrors were installed in the refrigerators. The mirror increases the efficiency of the decontamination processes. So, we should understand the mechanism of sterilization. When UVC light comes in contact of hydrogen peroxide droplets, free hydroxyl radicals are generated. These radicals in turn destroy microbes, viruses and bacteria on the surface. During the whole process, guidelines recommended by Center of Disease Control for reuse of respirators were. This video highlights how masks are handed over by the doctors to mid-level ophthalmic personnel after use. The MLOP notes down the details and keeps the masks aside for sterilization. These masks can be used for 6 to 8 hours at a stretch. This video shows how respirators are taken out of the paper bag and kept in UH by trained MLOP. These masks are then hanged with the help of copper hangers inside the UH. Similarly, the Ziploc bags are taken out of the boxes and sterilized with the help of UH and hydrogen peroxide. The Ziploc bags with respirators are then kept in sterile boxes dedicated for these purposes. The respirators as well as Ziploc bags have name of the doctors written over it to avoid confusion. So, the doctors for duty in the morning collect their respirators from the MLOP. We also have a separate area dedicated for the decontamination of respirators. Hence, this effective technique of decontamination of respirators is economical, reusable, and will also prevent shortage of respirators and masks in near future. Thank you.
Doctor, are we done with the video?
Yes, sir. It is over, sir.
Okay, thank you so much for finishing very much prior to the given time.
Thank you.
For the next video, may I please call upon Dr. Mary John. Dr. Mary John.
Good morning.
Good morning, doctor.
Good morning, sir. Am I audible?
Yes, doctor, you are audible. I would request you to start screen sharing.
I'm going to present my video title A Stitch in Time Saves Sight. I'm Dr. Mary Esther from Drishti Eye Institute. Sound కొంచెం తగ్గి. Sound.
Doctor, we are not able to hear anything. Could you just check with the audio?
Am I audible, sir?
Doctor, you are audible. The video that is being played.
It's not audible. Okay,
Yes.
sir.
I request
Video,
you to.
audio, it's not on. Video okay, audio रालेगा.
मैम जब शेयर किया हुआ तो स्क्रीन का शेयर ऑडियो करना होता है, ऑप्शन होता है उसमें. जब शेयरिंग करेंगे तो उसमें वहां पर नीचे ऑप्शन आएगा शेयरिंग द ऑडियो.
मेरा म्यूट कर देना नहीं हो तो. नादि म्यूट. Hello, is it audible, sir?
नो मैम.
Doctor, still no audio.
मैम एक बार शेयरिंग स्टॉप कीजिए इसको.
Please stop sharing. Please stop sharing. Dr. Mary, you are on mute. Please unmute yourself. Yes. I would request you to please stop sharing now.
Stop sharing.
Yes.
Okay, sir.
And when you start sharing again, there will be an option to share audio with the video. Please make sure when you start sharing the screen, you click on share audio as well.
Share audio. Screen share के साथ share audio.
मैम ग्रीन सा होगा ना.
Up to 1/3 of open cloak injuries.
We are able to hear it now.
Huh?
We were able to hear an audio now.
Okay, on. Mute చేయండి, on చేయండి audio. Okay, run చేయండి.
मैम स्क्रीन को शेयर करेंगे ना तो नीचे ऑप्शन आता है शेयरिंग द ऑडियो, तो उस पर क्लिक करना होता है. उस पर शेयरिंग कीजिए उसको. हाँ नीचे नीचे देखिए साइड में कहीं पे शेयरिंग ऑडियो होगा.
On చేయండి. Corneal tear of 4 clock hours. Is it audible, sir? Iris prolapse and sphincter tear close to 4 o'clock position. The initial visual acuity was 6/60. Third of open cloak injuries. Up to 1/3 of open cloak injuries result in blindness. Blindness can be avoided by correct diagnosis, prompt management, and regular follow-up. In this case study, we present a 22-year-old man who had injury to the right eye with wooden stick. He had a circumferential corneal tear of 4 clock hours with iris prolapse and sphincter tear close to 4 o'clock position. The initial visual acuity was 6 by 60. And so he was taken up for the primary surgical procedure. A localized peritomy was done as the first step to rule out any extensions of the tear and to identify the edges of the tear. The exposed iris was abscissed. And the corneal tear was sutured.
Is it audible, sir? Is it audible, sir?
Yes, doctor. Audible.
Audible, but we should have kept the sound of the music should be at the low. Increase the sound of the music.
Increase the sound of the music. Increase the drastic.
Volume.
The conjunctiva was closed with fibrin glue.
Is it audible, sir?
He started on systemic and topical antibiotics, topical steroids, and topical mydriatics. In course of time, he developed clear and blurring of vision. What is the cause? 1. Corneal scar causing significant regular astigmatism. 2. Iris deficiency. And 3. Rosette cataract. And so he was planned for secondary surgical procedure. As a first step, a continuous curvilinear capsulorhexis was made. The lens matter was aspirated. And a toric intraocular lens was implanted. A customized coloboma ring segment was placed. The segment overlapped the area of the iris deficiency. Postoperatively, he was started on topical antibiotics, topical steroids, and topical mydriatics. The patient was kept on close follow-up. After 1 month following surgery, refraction was done. He had excellent visual prognosis. The best corrected visual acuity was 6 by 6. Prompt treatment and regular follow-up of open globe injuries result in good visual prognosis. Thank you.
Thank you so much, doctor. I would request you to stop Thank you. Next, may I please invite
Thank you, sir.
Dr. Amrita Bajaj to share the screen.
Yes, I'll do that. I have a video voiceover too. Kindly let me know if it's visible and the sound is audible. I'll just start my video.
Yes, doctor.
Is the voiceover there?
No, doctor, not yet.
Voiceover isn't there?
No, ma'am.
So I'm supposed to
Ma'am,
share
Doctor, I'll
sound.
request you.
Yeah, I think now it should be.
I'll request you to please play the video.
We think.
Is it
Yes.
What
now?
do we do when we have a challenge
Fine?
It is
Is
okay
it
now.
yes, ma'am.
Yes,
It
doctor.
is okay now.
in case lined up for the next day? We think and we make a plan. But will the machine be able to read our mind? Let's find out. A 35-year young female underwent uneventful phakic lens in both eyes in September 2012. The patient was a high myope with a high axial length of both eyes. She was implanted with star V4B model of phakic lens without any central hole. Patient's vision deteriorated to 6 by 36 as she was diagnosed with anterior subcapsular cataract in 2021 with a decreased vault. We planned for left eye cataract surgery in August 2021, followed by right eye cataract surgery. Variability of the capsule and unpredictability of the capsulorhexis was noted during left eye cataract surgery, and that is when, for a better control of capsule, a femtosecond laser assisted cataract surgery for right eye was planned. Without losing any time, we started with preoperative planning on our femtosecond catalyst platform, keeping the capsulorhexis diameter as 5 mm, nucleus fragmentation to sextants, along with the planned limbal relaxing incisions. As per our concerned apprehension, the OCT caught the plane of capsulorhexis all wrong. It mistook the anterior capsular plane as that of the vault of the phakic lens. We adjusted the planes manually to mark the structures of the posterior corneal curvature, anterior and posterior surfaces of the lens. And wishing for the bullseye, we fired the laser. Starting with phacoemulsification, side ports were made. Phenocaine was injected through the side port. The incision was made at 135 degree. The phakic lens was disengaged. The lens was explanted using the hand-on-hand technique, but unfortunately, the heptic gave away and tore. The lens was re-rotated and incision was enlarged to 3.5 mm. The phakic lens was re-grasped and finally it slid out through the main incision. We felt a sense of momentary victory, but yet we have another hurdle. we are yet to find out how well the machine has read our directions. So we get back to work, only to celebrate our next success. As we see a circular, centered, regular capsular axis with no tags. It was so fulfilling to note not only the capsular axis but also the nucleus fragmentation and the limbal relaxing incisions were rightly done. Everything just hit the right planes, just as we wanted it to be. The cataract was aspirated. Finally, with the sense of achievement, a 3-piece lens was implanted into the bag and we had a good post-operative outcome. In the end, it's important for us to know our machines well, and we are so much more powerful when we empower each other. In challenging cases, judicious use of machines can be a boon for our outcomes. What do we do?
Yes, so I'm done with my video.
Thank you so much, Doctor. Now may I please invite Dr. Ruchika Patnaik for the next video.
Yeah. Good morning, everyone.
Good morning, Dr.
I-
Ruchika. Yes. May I request you to please start screen sharing?
Yes, I'm going to do that. Please do let me know if my audio is clear.
Yes, Doctor. Please start the video. Could you please make sure that the volume is full?
Yeah, just a minute. But can you hear the audio?
No, not yet. Where you have the screen sharing option, please make sure that you start screen sharing with audio on.
मैम जब स्क्रीन शेयर करेंगे तो नीचे ना कंप्यूटर ऑडियो शेयरिंग का ऑप्शन होगा, उसको क्लिक कर दीजिए.
I don't see it. Just a minute.
शेयरिंग स्टॉप कीजिए, इसके बाद में दोबारा शेयरिंग कीजिए, उसमें ऑप्शन आएगा.
Yeah.
अब आप शेयर कीजिए स्क्रीन को.
Yes.
और नीचे देखिए.
Yes, yes. Okay. Yes, got it.
ओके.
Yeah.
This is the case of a 13-year-old male who presented with progressive diminution of vision in the right eye. At presentation, uncorrected visual acuity in the right eye was 1/60, not improving with glasses. Slit lamp examination of right eye showed advanced corneal ectasia with Fleischer's ring and apical scarring. Left eye showed early signs of ectasia. Pentacam showed a steep K of 72 diopters, thinnest pachymetry of 255 microns and Kmax of around 78 diopters. OCT cornea showed anterior stromal scarring with thinnest pachymetry of 284 microns. Based on the clinical examination and investigations, a diagnosis of right eye advanced keratoconus was made and DALC was planned. Graft size was measured, making sure to include the cone completely demarcated by the Fleischer's ring. A partial thickness trephination was done with a guarded trephine. A groove was deepened all around with the help of a crescent blade, and a plane was created for anterior stromal dissection. Anterior stromal debulking was done, maintaining a single plane. Once this was complete, a small stromal pocket was created with a crescent blade.
and a tract was created with a pointed dissector for air injection. Air was then injected in a deep stromal plane with a 5 ml syringe. Type 2 bubble was successfully achieved, seen expanding from center to periphery. A paracentesis was made to release aqueous. Then comes the brave strike. My first strike was brave and the type 2 bubble was released. Thereafter, I made multiple attempts of not so brave hesitant strikes in an attempt to extend the incision and landed up perforating the Descemet's membrane. AC was reformed with air injection. I now had to proceed more carefully with a layer by layer stromal dissection. The slightest traction opens up the perforation and the AC collapses, making dissection more challenging. AC is reformed with multiple attempts at air injection. I somehow manage to proceed with the stromal dissection and bear the predesmetic layer. Just as I thought everything was going smoothly, I land up perforating the Descemet's membrane yet again. But the AC is formed with air injection and perforation sealed. Now comes the donor preparation. The Descemet's membrane on the donor button is steamed with trypan glue. Now the Descemet's membrane is completely stripped meticulously, making sure there are no tags or remnants. Once the DM is completely stripped, the donor button is placed on the host and 4 cardinal sutures are placed, followed by the remaining sutures. I now close the eye, praying for a good outcome the next day. My prayers are answered and the uncorrected visual acuity is 6/24. Graft and interface is clear with a quiet eye. At 1 month post-operatively, the uncorrected visual acuity is 6/18 with a clear graft and interface. The Kmax has reduced from 80 to 50 diopters with a central small astigmatism of around 3 diopters. To conclude, DM perforation is a complication unique to DALC. Not all perforations need conversion to PK. A good visual outcome can be achieved even with multiple perforations. Thank you.
Thank you. My video is done.
Thank you so much, doctor. Next, may I please invite Dr. Kirandeep Kaur to start with her screen sharing. Make sure if the audio is audible and then begin with the video. Dr. Kirandeep Kaur?
Yes, sir. Just give me 1 minute. I'll show, sir.
Yes.
माइक को थोड़ा सा पास में लेके बोलिए, आवाज आपको थोड़ा बहुत कम आ रहा है.
I would request you, if possible, please make sure that you remove the earphones and
Okay, sir. Sure.
yeah. Can we start with the screen
Is it
sharing?
audible, sir?
Yes, doctor.
Of social distancing. Myopic pandemic during the COVID-19 pandemic. In the era of social distancing and lockdown, having no choice to go out to play with neighbors during this COVID-19 crisis.
मैम आपने जब शेयरिंग किया तो ऑडियो पे क्लिक कर लिया ना, नहीं तो फिर बाद में ऑडियो नहीं आएगी.
Sir, is my video visible, sir?
Yes, sir. Yes, doctor, you are audible. I would request you to start screen sharing and start the video.
Okay, sure. Just a minute. Share my एक second. यहाँ से
Digital distancing in the era of social distancing. Are we seeing a myopic pandemic during the COVID-19 pandemic? In the era of social distancing and lockdown, having no choice to go out or play with neighbors during this COVID-19 crisis, the average screen time of children is on the rise. School authorities have chosen online classes as a strategy for continuing the education at home, and children are also inclined towards digital devices as a source of entertainment. Research shows that prolonged use of digital devices increases problems like computer vision syndrome and myopia in growing children. Myopia or short-sightedness is a problem that limits the ability to see distant objects clearly without glasses. 1 out of 6 children are suffering from myopia, and by 2050, close to 50% of the population would be myopic. Attention deficits and communication issues are also more common in these children. Even 2 hours of gadget or television viewing every day can increase the glass power. Children with prolonged screen time can develop frequent rubbing and squeezing of eyes, tiredness while reading for long hours, headache, going close to screen or books while reading, squinting of eyes, blurred vision, and occasional swelling of lids. What are the preventive measures? A. Adjust your monitor. B. Blink. C. Change habits. D. Drink. E. Exercise. F. Food and family. G. Glasses. Ambient lighting in the computer workspace should be half of the screen brightness. Position your screen to the side of the windows. Ensure that table is at elbow height and the screen should be 1 arm distance away with the center of the screen 4 to 5 inches below the eye level. Avoid smaller screens. Blink voluntarily 15 times per minute for proper eye health. Every 20 to 30 minutes, move or stand or stretch and take a short walk. Follow the 20-20-20 rule. Take your eyes off the digital screen every 20 minutes to look at something 20 feet away for at least 20 seconds. Add repetitive reminders on the screen to take a break. Avoid digital screen usage at least 2 hours before bedtime. Drink 8 to 10 glasses of liquids like soups, fruit juices, milk or buttermilk per day to ensure proper hydration. Engage in physical activities. If you can't go outdoor, try to use your terrace for playing safely. Eat healthy food rich in vitamins, especially spinach, green leafy vegetables and fruits of this season. Keep your digital items away in your dining hall and spend some quality time with family. Progression of myopia is high in digital users, so consult an ophthalmologist or optometrist to check your present refractive error and if needed, go for a new or change of glasses. This is the time we should wake up and be proactive instead of regretting later, because our children are the rock on which our future will be built and they are the greatest asset of our nation. It is our responsibility to ensure that our kid enters into adulthood with good eye health. Let's avoid digital eye strain to break the myopic chain. Thank you.
Thank you so much, Doctor,
Thank you,
for
sir.
finishing before time. Next, may I please invite Dr. Gitanjali Sud for her video presentation. I would request Dr. Gitanjali to turn on the camera, unmute herself, and then start screen sharing.
Good morning, everyone.
Good morning, Doctor.
Please let me know if my voiceover is audible.
Hello everyone, myself Dr.
Yes, Doctor, we are
Gitanjali
able
Sud
to
will
hear
be
the
presenting a
voiceover,
video
so I
titled
would
Trimming the
request
Lily in the
to
Eye.
our
The
AVP
surgery
to
is
start
done
with
at
the timer.
SMI Institute, Kandra. This was a case of 60-year-old female with uncontrolled diabetes from past 30 years, who presented with drop in vision in left eye for past 3 months. She had never undergone eye screening before that. At present, eye and left eye vision was perception of light with immature cataract and pterygium. Dilated fundus examination revealed advanced proliferative diabetic retinopathy with the fibrovascular proliferation resembling a flower in a pool of blood-filled vitreous cavity. Right eye had high-risk proliferative diabetic retinopathy and received pan-retinal photocoagulation. She received left eye injection antivascular endothelial growth factor followed by 23-gauge pars plana vitrectomy. During surgery, we noted the vascular component had markedly decreased and the flower was white looking. After core vitrectomy, we identified the hyaloid plate 60 degree around the proliferation. On doing that, the petals of the lily flower collapsed over the optic disc. The flower was attached through a fibrous stalk to the disc. Cutter was used to trim the flower at low cut rate and vacuum. The stalk was vascular and bled. We identified a second flat membrane along the superior arcades that was causing traction on underlying retina. The membrane edge was lifted using forceps without causing undue traction on retina. The bleeding stalk over the disc was cauterized and the bleeding vessel adherent to membrane was also cauterized before dissection. Then we did one hand scissor dissection of the membrane. Subsequently, cutter was used to segment the membrane and trim it to extent possible. The flat diffusely adherent membrane over the posterior pole was that lifted again using forceps and vacuum-assisted dissection. The bleeders were cauterized intermittently. And retinal photocoagulation was done, followed by fluid gas exchange and silicone oil. This case presented two unique presentations of the fibrovascular membrane in a diabetic patient. The elevated stalk was flower-looking and the second scaffold of adherent membrane over the posterior pole. The highly vascular proliferation with stalk gave a unique appearance in this case. The greatest rescue in this case was preoperative use of antivascular endothelial growth factor that reduced the vascularity dramatically. Post-operatively, patient did well with best corrected visual acuity 6/3/6 with cataract.
Thank you, everyone.
Thank you so much, doctor, for finishing before time.
My pleasure.
Thank you so much. Next, I would like to invite Dr. Vipul Arora.
Yeah, I'll just share
Hello,
this.
doctor. We are able to see you. Also, the audio is audible. I would request you to start screen sharing and let's check if we can hear the audio of the screen that you've shared.
Dear friends, I am presenting
Amazing.
a case of IOL exchange in presence of an open posterior capsule. This patient is a 60-year-old female who came to us with dimness of vision in her left eye. She had an opaque intraocular lens with open posterior capsule. After creating paracentesis and deepening the anterior chamber with dispersive viscoelastic, IOL is dissected carefully using repositor and dialer from capsular bag with intermittent use of viscoelastic. This maneuver is done from both sides by changing hands. The aim is to remove adhesions between haptic of IOL and capsular bag. There are places where anterior and posterior capsule are fused together. Dissection of this space is done by viscoelastic and iris repositor. This lens was implanted 5 years back elsewhere and lens was hydrophilic IOL. Sometimes we have to cut the IOL from optic haptic junction because haptics are so fused together that removal of haptic may lead to zonular dehiscence. Then slowly and gradually IOL is dialed and rotated so that adhesions are removed and IOL is free in the bag and can be brought in anterior chamber. One should be very careful as any extra force can lead to zonular dehiscence. Incision for lens exchange is done by 2.2 mm keratome with slight extension of the incision internally. Move IOL at this stage, there is high probability of vitreous coming into anterior chamber. So, to avoid this, viscodissection is done and dispersive viscoelastic is injected beneath the IOL. The main purpose of doing this is to tamponade the vitreous. Viscoelastic is also injected above the IOL to protect the endothelium. New hydrophilic single-piece acrylic intraocular lens is carefully and slowly injected underneath the existing IOL. We have to make sure that this IOL goes in the bag. Direction of IOL placement is at the level of iris plane. So, for a moment, there are two IOLs in the eye. To make sure the IOL is in the bag, the leading haptic is inspected and then trailing haptic is inserted in the bag. We have to be careful to not put any pressure on posterior capsule which may lead to extension of an already existing posterior rent. The aim of placing this new IOL at this stage is that it will act as a scaffold to explant the opaque IOL, as sometimes explanting IOL may lead to posterior capsular stress and eventual rupture. Then to remove the opaque lens, haptics are slowly brought above the iris plane. We have to make sure that anterior chamber is sufficiently deepened to protect the endothelium. IOL optic is cut using Osher's micro scissor up till half of the optic with other end of the optic stabilized with dialer or a repositor. We have to make sure that micro scissors are sharp before using them intraocularly. Scissors are then released with the support of dialer as scissor tends to stick to the cut end of the optic. Similar cut is made on the other side of optic. This cut is also up till half of the optic so that there is no pushing or pulling of lens. Viscoelastic is injected in between to protect the endothelium. IOL is rotated on the other side. This movement should be very slow and gentle in nature. Then the IOL is cut from the other side so as to complete the first cut. Overall, the optic of IOL is trisected, resulting in 3 IOL optic segments. This helps in removing the IOL through regular 2.8 mm incision. 1/3 of the IOL is removed from the eye with the help of microforceps. The other IOL segment are similarly cut in 2 parts and are removed with microforceps. Explanted IOL is put together over the cornea to recheck for any missing IOL segment. 0.1 ml of triamcinolone is injected to check for any vitreous. It serves a dual role. First is to identify the vitreous and second is to minimize post-operative inflammation. AC wash is given and there are no vitreous strands noticed in anterior chamber. So in this method of IOL explantation, new IOL acts as a scaffold to protect the posterior capsule and also acts as a tamponade to vitreous so that there is no vitreous prolapse. Patient had a clear cornea next post-operative day and had a vision of 6/9. Thank you so much for your kind attention.
Thank you, sir.
Thank you so much, doctor, for finishing exactly on time. And then may I please invite Dr. Jeevan Ladi for the presentation.
I would like to thank the office bearers of Uttarakhand. Is my screen seen?
Doctor, could you please be a bit more loud?
Can you see my screen?
Yes, sir, doctor, we can. Yes, doctor, we can see the screen.
I just would like to know whether sound is heard.
No,
Is
doctor.
it heard?
No audio.
Audio is there?
No.
Now?
No, doctor. I would request you to stop screen sharing, again start screen sharing, and when you start screen sharing, you have an option to share audio. Please make sure you tick on that.
Sorry, where is the button? Is my screen share gone or not? It's there?
Yes, sir. Sir, the screen share is gone. I request you to start screen share again.
No, if I start the screen share, where is the sound? Sound is where?
Sir,
you
नीचे
will,
नीचे
get a
नीचे हो.
notification.
Here? Now?
Sir, एक minute. Sir, from website.
Yeah.
Sir,
Got it. Got it.
Okay, sir.
Tell me again whether the sound is heard or not. Is it heard? Is sound heard now?
No, sir, not yet.
I'm so sorry.
No, you can give commentary.
You can voice over from here and you can keep the video on.
Video run and give your commentary. You speak.
This is an innovative technique which you have developed.
Great.
For a smile. You can start the timing now.
Yes.
Is my screen seen?
Yeah.
Yes, doctor, everything is perfect.
Yeah. Please go ahead.
Start.
Sound is not there, but?
No, sir. No. The
okay.
Video
Fine.
To speak.
So this is the sharing applied lenticle by wow factor. So wow factor was missing into the LASIK surgery compared to LASIK surgery, and we are trying to get it into this, a new technique by which we reverse spool the lenticule. The first cut is basically made at the periphery. This is the third cut, which goes beyond the posterior cut and does the dissection. We take the incision at 110 degree. What you can see now is a posterior cut. This is the second cut which goes beyond the first cut for a better dissection. These are the different references, and we are presenting an innovative new technique. So basically what we need is basically early visual recovery. So these are the initial pockets anterior and posterior to the lenticule. This is where anterior to the lenticule. While going posterior to the lenticule, we do a swiping motion so that this part is separated. So we go opposite end and start dissecting. So we dissect right and left half. Now this movement brings the lenticule towards the incision. So we keep only one quadrant attached and separate everything else. And this has been pulled reverse direction, which is called as a SAFE, that is sharing applied force extraction. As you can see, the dissection becomes very smooth. since the stroma around is not manipulated much, there is no much of inflammation. As you can see that we go to the opposite end of the wound. Now we dissect to the, now we are above the ventricle. So we are left pocket is dissected now. Now we go to the right side and dissect the right side. Now while going posterior, we press it down. Now what we done, so once this is done, the lenticle starts coming towards the incision. So it is never lost in any case, irrespective of the thickness of the lenticle. Now you can see only right paracentral area is attached. And that we keep attached, and now it is removed by safe technology. That is, it is coming in the reverse direction. Now you check the lenticle 360 degree, see any tear is there or not. Now, how do you get the wow factor? So you use a lenticular pressurized dissection. So we press onto the lenticle when we are dissecting. As you can see, we are pressing above and below. Now we do the stomal massage that milks out the fluid from. We have to operate under high magnification so the dissection is very easier. This is on table, cornea is absolutely clear. More than 95% of the patient get 6/9 or 6/9 on the first post-op day. In a complicated cases, what you can see, opaque air bubble here, you can see opaque air bubble in this area. So what you do, you dissect everything else and only the part where opaque air bubble is there, you remove last. Now this is the missing energy. You can see black spots surrounding the central part. So this is because of inadequate energy. So you be careful when you are dissecting in that area. And once you do that, now you can see that carefully that this is a safe technology. We are removing the lenticle. So all lenticles are removed exactly. So in conclusion, use safe technology, use lenticular pressurized dissection, high magnification, adequate hydration, and stomal massage. So in relax, now you can relax because this gives a very easy dissection and gives a wow factor. You have a good vision on the same day of the surgery within 2 hours. And you have to smile. That is small lenticle dissection because it gives a wow factor. It's a sharing applied for section of lenticle by reverse pull. And thank you. This is our references. Thanks a lot.
Thank you so much, Doctor, for finishing our time. Next, may I please invite Dr. Kamaljeet Singh to start with the audio, video, and then start screen sharing so that we can start with the...
My video is with you.
Yes, Doctor.
Okay.
AV team, can we just have Dr. Kamaljeet Singh's video?
सर स्क्रीन सेट कीजिए और नीचे सर स्क्रीन जब शेयर करेंगे होंगे तो नीचे ना आपको शेयरिंग साउंड लिखा होगा तो उसको क्लिक करना होगा तो ऑडियो आएगा आपका।
कहाँ पे लिखा है? फिर से वापस जाएं?
जी 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 सर, फिर से वापस जाइए।
ये न्यू शेयर है?
नहीं सर, अब इसको स्टॉप कीजिए, मैं कर देता हूँ। आप अब शेयरिंग, अब एक बार शेयरिंग कीजिए और नीचे ना आपका ऑप्शन आएगा शेयरिंग साउंड।
शेयरिंग साउंड तो इसमें नहीं आ रहा।
आएगा सर, नीचे जो आपको शेयरिंग, यहाँ पे क्लिक करेंगे शेयरिंग करने के,
इसको क्लिक करें।
हाँ साइड में आप शेयरिंग साउंड लिखा होगा, शेयर साउंड।
हाँ शेयर साउंड लिखा है,
उसको क्लिक कर दीजिए।
दिया, शेयर करें अब?
जी सर, शेयर कीजिए अब।
ठीक है।
डॉक्टर, अभी आपकी जो स्क्रीन है वो दिखाई दे रही है। आपको रिक्वेस्ट करूंगा कि आप वीडियो प्ले करें वहां से, तो फिर हमें पता चलेगा शेयर हो रहा है या नहीं।
वीडियो तो आपके उसमें है ना? वीडियो तो आपके पास है, हमारे पास नहीं है वीडियो, हमने भेज दिया था आपको।
ओके
वीडियो आपके पास यही तो हम कह रहे थे
सर,
कि
आप उधर ही सब आप पता करो।
आप कर रहे हैं ना शेयर?
सर एक मिनट, एवी टीम कैन यू जस्ट चेक?
सर मैं चेक कर रहा हूँ
जी।
यार ये तो बहुत पहले भेजा गया था।
सर आप एक काम करिए, आप 2 मिनट रुक जाइए।
नेक्स्ट कर लेते हैं।
Till then, we have Dr. Priya Desai. Dr. Priya, I request you to please turn on your camera, unmute yourselves. Dr. Priya Desai.
Okay, can you hear me now?
Yes, doctor. Yes, doctor.
Okay, so I'm going to basically share my screen from my phone. I just need you to tell me if everything is okay, right?
Yes, doctor.
Just give me a minute.
Yes.
Okay, can you see my screen?
Yes, doctor. We are able to share the screen and the audio is
Can you hear it?
Yes. Thank you.
We have been doing slit lamp and fundus examination since ages. Then why now? It's the need of time for patient counseling, for documentation, medical legal aspect and telemedicine. So what are we looking for? We're looking for a device which is portable, which has got a minimum learning curve, a good telemedicine tool which has got good slit lamp compatibility, with minimum maintenance, durability, which gets recharged easily, with an inbuilt light source, compatible with all mobiles, and good value for money. Imaging devices have evolved time and through, but they all come with their disadvantages of having a long learning curve, the need of a 20D lens, their non-compatibility with all mobile phones, a plastic body, use of mobile flashlight, and being expensive too. There also have been devices which have got all facilities like an inbuilt lens, a slit lamp mount, light source, rechargeable, but they're expensive. So what does a subspecialist who is not a retina surgeon do to take retina images? ERS light or Easy Retinal Screening Light, as the name suggests, is a device designed by us to easily take retinal images. Its advantages over other devices is that it's portable, minimum learning curve, it's a good telemedicine tool with good slit lamp compatibility, minimum maintenance, durable, rechargeable, with a good inbuilt light source, compatible with all phones, and it's pennyworth. It comes in a compact, easy to carry box with excellent slit lamp adaptability. The unboxing and assembly is a do-it-yourself process and does not require any professional help. Sharing a few images taken by the ERS light. Along with this, we have also designed AIM 1.0, which is an anterior segment imaging module. These are the images taken by the AIM 1.0. Is good imaging important? No. A good reporting also is a very important segment. For this, we have designed an application which is Android compatible, known as ophthalmic capture reporting, which will generate reports with these kind of images and a personalization where you can have the name of your institute with the patient details. It is very quick to generate and very easy to share. With this little innovation, we intend to save the time and money of the surgeon and give the patient a good report in hand. Thank you for your patient hearing.
Thank you so much, doctor, for finishing exactly on time. A gentle reminder
I
to doctor.
couldn't hear the video. Was everything okay? Could you
Yes,
hear
doctor,
it properly?
everything was amazing.
Okay. Thank you
so
very
much,
much.
Dr. Priya. A gentle reminder to Dr. Kamaljeet Singh. Doctor, we do not have the video.
क्या यार तुम्हारे यहाँ इतनी बार भेजा गया तो फिर भी नहीं है, तो अब हम कैसे इसको करें कनेक्ट, बताइए शेयर कैसे करें?
जी
सर आपका लैपटॉप में वीडियो है अभी?
हाँ लैपटॉप में है
सर, ठीक है सर, उसको शेयरिंग कीजिए सर।
शेयरिंग कैसे करें? शेयर तो कर रहे हैं लेकिन
हाँ, शेयर कीजिए और नीचे जो ऑप्शन आ रहा था ना शेयर साउंड, उसको क्लिक कर दीजिए तो आपको वीडियो का ऑडियो भी आ जाएगा, चल जाएगा।
नहीं तो वो उस पे है ना, ये देखिए हम शेयर करेंगे इसको।
जी सर।
तो ये आ जा रहा है।
हाँ सर, इसको मिनिमाइज कर दीजिए, ये जो आपका जूम का जो एप्लीकेशन है ना उसको मिनिमाइज कीजिए।
ओके
जी सर।
वीडियो जो है उसे प्ले कीजिए।
वीडियो भी आ गया सर, लेकिन
We are going to demonstrate you a hybrid technique.
Timer.
There are several pre-choppers available in which we do it in the back, and that lead to stress on the back. Femtosecond laser is also done in the back, which is expensive. In our technique, we do it out of the back, so therefore there is no stress on the zonules. No additional instruments are required, and is cost effective. The surgery is done in the usual way. After doing the staining of the anterior capsule, we make two side ports, and with the help of capsular access forces, we make a slightly larger capsular access, which is about 0.5 to 1 millimeter larger than the usual. It helps in tilting the nucleus out of the bag while doing hydrodissection. Once the tilting is achieved, we take two instruments. On left hand, we take the Sinski, and then on the right hand, we take the chopper. The Sinski simply stabilizes the nucleus, and with the chopper, we chop it into two fragments easily. This is a grade 3 nucleus which has been chopped so nicely in this case. Once this is achieved, we proceed to the usual phacoemulsification. You can use any phacoemulsification with high vacuum. You don't require to have a very expensive phaco machine, so your surgery becomes much cheaper. And after chopping it and consuming the nucleus, you have to do a irrigation aspiration. So you can see the chopping is so easily being done, and all is being done in the pipary plane, but only thing is that it is out of the bag. So it is so easily achieved, and thereafter you do a bimanual irrigation and aspiration. Thorough cleaning is done. All cortical matter is removed and a foldable lens is implanted. You can do it even through a smaller incision. Then we will be showing you a multiple pre-chops. You can see we are doing hydrodissection here. The nucleus is tilted by doing ample hydrodissection. The catch here is that you simply keep on depressing the tunnel so that there is egress of the fluid. Otherwise, it might lead to posterior capsular rupture. Once the tilting is achieved, you again take 2 instruments. So you have to assure that your tilting is proper, and even a part of nucleus, if it is tilted, it's good enough. And then you further tilt it with your Sinski or a chopper, and then again the same step is repeated. You can see that nucleus is divided into 2. It is further divided into smaller fragments with the same 2 instruments, a Sinski and a chopper. All steps are being done out of the bag, so there are no stress on the sinews. And you can see the chamber is also there. So the injury to the corneal endothelial cells is not much. And then you do phacoemulsification in the usual way. Once it is achieved, then you implant the lens after doing the bimanual irrigation and aspiration. And the results are so good. You can see all the things are fine here. And in the third video that we are going to show, it's a much softer cataract, and easily it is, after doing hydrodissection, it comes out of the bag and you can chop it easily. A softer cataract is slightly difficult to chop, so it might shift from one place to other, may go towards cornea, but that we have to prevent somehow by using the other instrument, that is a Sinski dialer. You further chop it into a smaller segment, as many segments as you want, and then we do the usual phacoemulsification. So in all these 3 videos that I have shown is that all the things are being done out of the bag. No additional instrument is required, so it becomes much cheaper and the surgery becomes much easier. All the residents can do it without any problem because the chop is not required in the bag. So the difficulty is not there, and you can easily complete the surgery without any difficulty. Thank you so much.
Thank you so much, Dr. Kamaljeet Singh, for finishing on time. Next
you.
up, may I please invite Dr. Abhinav Dhami. Dr. Abhinav, I request you to unmute yourself. We can see you, but you are on.
Yeah, hi.
Hi.
Can you see me now? Yeah,
Yes,
I'll just
yes,
share my
doctor.
screen.
Now, let's start with the video. EV team, can we have the timer up?
Can you is it visible? Yeah. Oh, sorry.
Yeah, it is visible, but I am not sure about the audio.
Let me just, the audio will just come in a second. Let's see.
तो एक बार शेयरिंग स्टॉप कीजिए सर। अब दोबारा शेयरिंग करेंगे तो नीचे ना ऑप्शन होगा शेयर साउंड करके होगा, उसको क्लिक कर दीजिए तो ऑडियो आ जाएगा।
What happened?
सर शेयरिंग
Hello?
कीजिए, सर शेयर कीजिए।
दोबारा शेयर करूं?
जी जी जी, शेयर
अच्छा,
करेंगे तो
okay.
नीचे ना ऑप्शन होगा शेयर साउंड करके, उसको क्लिक कर दीजिए बटन पे।
शेयर साउंड, हाँ ठीक है
जी, क्लिक कर दीजिए।
ओके। ओके, ठीक है, अब करूँ शुरू?
Yes, doctor.
ओके, ठीक है।
EV team timer.
Hi, I'm Dr. Abhinav Dhami. I'm going to present a unique case of triple trouble. Managing an anterior chamber Kelman intraocular lens, posterior dislocated foldable intraocular lens, total retinal detachment. Here we present a case of 54-year-old female, who presented with decreased vision since 3 months. There was a history of cataract surgery, followed by 2 retinal procedures done elsewhere. On examination we observed an anterior chamber IOL with one edge, touching the endothelial surface of cornea, and on retinal examination there was posteriorly dislocated IOL with a total retinal detachment. There are 2 ways to approach this case. First one is a 2-step approach, wherein we remove the ACIOL in one sitting and then plan a secondary procedure at a later date with removal of posteriorly dislocated IOL and retinal detachment management. Other one is the single-step approach, removing the ACIOL plus posteriorly dislocated IOL and managing the retinal detachment. In this video we present a single-step approach to our case. We start by making a limbal gutter, followed by 3-port pars plana vitrectomy. It is intraoperatively, we realize that a partial core vitrectomy has already been done previously elsewhere and vitreous is attached to the intraocular lens. We induce posterior vitreous detachment with active suction using a 23-gauge vitrectomy cutter, so as to analyze the vitreous attachments to the IOL, for maximum debulking of peripheral vitreous cut and to mobilize the IOL. We inject intravitreal tricot to trim the peripheral vitreous along the retinal breaks. A fluorocarbon is injected over the optic nerve head, as it helps in 2 ways. It elevates the posteriorly dislocated IOL anteriorly up to the pupillary edge and also stabilizes the detached retina and provides a temporary internal tamponade. As both the IOLs are pupillary edge, we open the previously made limbal gutter incision with corneoscleral scissors and with the use of McPherson forceps, deliver the anterior chamber and posterior IOL out of the eye. The incision is closed with 10-0 nylon sutures, and with PFCL in situ, we perform peripheral laser retinopexy 360 degree in 2-3 rows. We perform direct silicone oil infusion by connecting to the infusion cannula port, and with silicone tip assistance fluorocarbon is passively removed and gets replaced with silicone oil. In the end the retina is well settled with silicone oil in situ. At 1 month, post-operatively the best corrected visual acuity is 6/68 with plus 10D FA cut correction.
Thank you. Hello.
Yes, sir. Yes, sir.
Do we have Dr. Gopal Agarwal? Dr. Abhinav?
Yes, tell me. Hello.
Yes, done with the video, right?
Yeah, I'm done with the video.
Yeah. Thank you.
Thank
Do we
you.
have Dr. Gopal Agarwal, the last presenter? Dr. Gopal Agarwal? Okay, so I would request
join है नहीं गोपाल अग्रवाल sir.
Ji, I would request our chairpersons and our moderators to make a note. The last presenter, Dr. Gopal Agarwal, is not there with us. And here we end the session exactly 6 minutes before time. Next session will start exactly at 10:30. I request you to please take a break, keep hydrated, hydrate yourself, and be back on the screens by 10:30. So as I can see, we have no, Dr. Amrita. We do not know when the results will be announced. I request you to contact the organizing committee for the same. As we can see that from the next session, we have 3 doctors with us, Dr. Priyanka Agarwal, Dr. Bharat Gurnani, and Dr. Astha Rawat present over here. I would request if anyone would like to, go through a dry run by checking their screen, if it is working or not. The video is audible to us or not, they can go ahead with that. If anyone wants to have a
So
check.
can the other participants leave?
Yes, doctor. I think the other participants can leave because we are about to start with the second session.
Okay,
And,
okay, fine. Thank you very much for all your help and support.
Thank you so much, Dr. Priya. Our judges for this session would be Dr. Mayank Pankti, Dr. Nishant Nawani, and Dr. Sufyan Ahmed. Our moderator would be Dr. Vipul Arora. I would request our judges and moderator to please turn on their cameras and unmute themselves. Thank you so much. I can see Dr. Priyanka Agarwal, Dr. Bharat Gurnani, and Dr. Astha Rawat are already over here. If we want, we can cross-check for the technical things. If you want to play your video, we can check for that. If not, then we'll be starting exactly at 10:30. Thank you.
Hello, sir. I'm my presentation
Sir,
one.
is it visible?
ठीक है, उसको फुल स्क्रीन कीजिए एक बार.
One second, sir. Yes, sir. Sir, is it visible?
इसमें कोई ऑडियो तो नहीं है ना मैम?
No, sir. No, sir. No audio. Yes, sir.
Well, a very good morning, and I am your MOC Purnesh Paliwala. Welcome to session 2 for Hall Gangotri, and we are about to begin with our judges, Dr. Mayank Pankti, Dr. Nishant Nawani, and Dr. Sufyan Ahmed. A moderator would be Dr. Vipul Arora. I request Dr. Vipul Arora to take over.
Good morning, everybody. So we'll start with the first case by Dr. Priyanka Agarwal. So start.
Hello. Hello.
Yeah.
Am I audible?
Yes, yes.
Good morning, sir. Good morning, everyone.
Good morning.
मैम सेलेक्ट तो कर लीजिए.
Yeah, I'm doing it. Good morning, everyone. My today's topic of free paper presentation is to study correlation between excellence of glaucomatous and non-glaucomatous patients. It's a prospective cross-sectional study. Under introduction, glaucoma is a chronic progressive optic neuropathy and is the second leading cause of blindness all over the world after cataract blindness. Many risk factors predisposes patient to glaucoma. One of them is excellence. Glaucoma patients are generally asymptomatic and unaware about the disease until advanced visual loss has occurred. Hence, identification of risk factors is essential for early detection of POAG and PACG, so that timely intervention can be done to prevent irreversible visual impairment. This study is aimed to determine association of excellence with POAG and PACG so that risk factors can be identified and patients with these risk factors can be treated on priority basis for prevention of fatal outcomes of the disease. In our study, we took a sample size of 120 subjects attending glaucoma clinic of Department of Ophthalmology, JRMC Gwalior. It was a prospective cross-sectional study with study period of 6 months from Jan 2021 to June 2021. The patient 120 subjects were divided into 3 groups, group A, B, and C. Group A having 40 cases of POAG, group B having 40 cases of PACG, and group C having 40 age-matched healthy volunteers. After their proper consent, patient underwent glaucoma workup and their excellence were recorded. Excellence of these 3 groups were compared and then evaluated. Data analysis was done by SPSS software, and the p-value of less than 0.05 was considered as statistically significant. The result and discussion. Age distribution of our participants were mean age of participants were 58 plus minus 12 years, with the youngest participant being 30-year-old and oldest being 85-year-old. Sex distribution, females were constituting majority of PACG patients compared to control and POAG group, and data was not at statistically significant. Similar findings were reported in studies by J.W. Cheng et al. And Divya B. et al., where PACG prevalence in women was approximately 1.5 times more than men. This was the graph where female predominate in PACG patients and males predominate in POAG patients. Now, excellent distribution. When we compared the excellence in POAG and normal, mean excellence among POAG group was significantly higher compared to control group, as patients having higher excellence are more prone to have POAG. Similar results were found in Singapore Malaya eye study and Metkila eye study, which showed that longer excellence were associated with POAG. When we compared excellence of PACG with normal, we found that mean excellence among PACG group is significantly lower compared to control group, hence patients having lower excellence are more prone to have PACG. Similar results were found in Bhaktapur glaucoma eye study and R. George et al. Study, which showed that shorter excellence and shallow anterior chamber are predisposed patient to PACG. These findings are consistent with our present study, and our study shows significantly shorter excellence in PACG group compared to normal group, which is consistent with other studies. A study by Sharpa D. et al. Showed that patients with excellence of less than 23 mm are at risk to develop PACG. Similar results were found in our study also, with maximum PACG patients are having excellence less than 23 mm. This is a table showing comparison of mean excellence, minimum, maximum excellence of normal patient with POAG and PACG, showing POAG patient having higher excellence compared to normal and PACG. And when sex distribution of excellence was seen, we found that mean excellence among males was significantly more than mean excellence among females. And similar results were found in studies by Tomilson et al. And R. George et al., which showed that females are having significantly shorter excellence compared to males. The graph shows the same results, where females are having significantly shorter excellence compared to males. So, conclusion of our study was, this study shows that eyes with PACG have shorter excellence compared to normal eyes. Eyes with POAG have longer excellence compared to normal eyes, and patients with less than excellence of less than 23 mm are more at risk of developing PACG than normal subjects. Hence, excellence can be used as a risk factor for both PACG and POAG, and patients having excellence lower or higher than normal should be properly investigated for glaucoma and follow up timely for development of glaucoma. Thank you.
Thank you, Dr. Priyanka.
Thank you, sir.
Dr. Bharat, are you there?
Yes, sir, I am here.
Please start. Yes.
Good morning.
Good morning.
The screen is visible, sir.
Yeah. Okay. You can start.
Okay. I'll be presenting my paper on our experience of pythium insidiosum keratitis, a clinical diagnostic dilemma and challenges in management. We have no financial disclosures to make. So before coming on to the study, we should know what are the existing challenges in pythium keratitis. It's a rare entity as a clinically and microbiologically mimics fungus, and the diagnosis is delayed. The specific diagnostic method is the DNA zoo spore identification, resistant to conventional antifungal, and the poor outcome with TPK. Coming to the introduction, is the pythium insidiosum is a oomycete, also called as parafungus, closely resemble fungal keratitis. The purpose of our study was to analyze the demographic profile, the clinical diagnostic features, challenges in management, and treatment outcome. It was a retrospective study design done during the period of October 2018 to December 2019. 30 pythium keratitis subjects were recruited from the cornea clinic of our tertiary eye care center. In the study period, we analyzed total of 2,039 ulcers, out of which 1,003 were culture negative, 847 were fungal, 161 were bacterial, and 30 were pythium. In the inclusion criteria, we had clinically pythium keratitis cases who were culture positive, clinically appearing fungal keratitis cases who were culture positive for pythium, and button culture cases positive for post-therapeutic keratoplasty. In the exclusion criteria, all clinically appearing pythium keratitis cases but culture negative were excluded, and all other infective and non-infective keratitis cases were excluded. For this study, we designed a diagnostic algorithm. All the clinical cases of pythium keratitis were subject to smearing in culture, and before culture results, antifungal were given to all patients. In the culture positive arm, if the ulcer size was less than 4/4, they were treated with linezolid monotherapy of 0.2%. And the ulcer size was more than 4/4, they were treated with a dual therapy of linezolid and azithromycin hourly. In case of good response, same treatment would continue. In case of poor response for 2 weeks, they were subject to therapeutic keratoplasty. In the culture negative arm, if the ulcer size was less than 4/4, they were treated with natamycin monotherapy. And the ulcer size was more than 4/4, they were treated with natamycin plus itraconazole or voriconazole hourly. In case of good response, same treatment would continue. And in case of poor response, they were subject to TPK. And the button culture were positive of pythium, they were treated with anti-pythium drugs. Coming to the demographic, 11 patients were less than 25 years, 10 patients were within 26 to 58 age group, and 9 patients were within the age of 51 to 70 years. And there were the male is to female ratio was 3:2. Coming to demographics and clinical patient, in the occupation, there were 14 farmers, 8 students, and 8 housewives. The most common risk factor was injury in 24. The presenting visual acuity was less than 1/60 in 15 patients, 5/60 to 1/60 in 7, and 6/6 to 6/60 in 8. And there was a presentation lag of less than 10 days in 16 patients. Coming to the clinical features, stromal infiltrated with hyphated edges were present in 11 patients, corneal melt in 4, subepithelial infiltrate spreading to limbus in 7, peripheral furrowing and tentacular projection in 5 and 4 patients respectively. There were hypopene and anterior chamber exudate in 14 patients and endothelial plaque in 8 patients. The first image shows the tentacular projection, ulcer margin, a hallmark of pythium. The second shows the peripheral furrowing and gutter, again a hallmark. The third image shows the early tendency to spread toward limb, and fourth image shows the whitish plaque infiltrated with a hypobium. Coming to treatment result, before culture result, 15 patients were treated with natamycin and voriconazole, and 7 were given natamycin and itraconazole. And after the culture result, once the pythium was concluded, all patients were given linezolid, and 19 patients were added with azithromycin. Coming to treatment outcome, we had 7 patients who healed with medical treatment, 19 required a therapeutic keratoplasty, 6 patients required a repeat TPK, 4 were lost to follow. Average time to TPK was 11 days, and glue plus BCL and tarsorrhaphy required in 4 patients each. The first image shows the recurrence of peripheral exudate in the host margin. The second shows a clump of exudates in the entry chamber, suggesting a high virulence and recurrence of this infection. Coming to complication, choroidal detachment was seen in 30%, secondary glaucoma and graft infection in 23.3%, retinal detachment 10, end of in 10%, and there was no case of evisceration. We had a good high salvage rate of gross salvage in 90%. HISIS was seen in 10%. Visual outcome, there were 7 patients who had a good visual acuity greater than 6/60, 5 were within 1/60 to 6/60 range. 15 patients had a PL positive and 3 were PL negative. The average healing time was 18 days. Comparing the two groups, in the surgical group, there was a presentation lag in days, and compared the average infiltrate size was more, 40.12, and the healing time was also more, and there was no statistically significant difference between the two groups. So poor presenting visual acuity, early therapeutic keratoplasty requirement, and recurrence and graft reinfection are the predictors of poor prognosis in our case. So coming to the review of literature, our study had 30 subjects, which is the third largest sample size. 63.3% required 3PK, 20% healed with medical treatments, comparatively larger compared to other studies. Repeat TPK requirement was also less compared to other studies. There was no evisceration, which stands out studies out from other studies. There was a high rate of glove salvage, and there were 10% only HISIS cases. So take home message, pythium keratitis is more prevalent in younger patients less than 50 years of age. Most common clinical finding is stromal infiltrated hyphated edges, and specific clinical findings include peripheral furrowing and tentacles. TPK is the treatment choice, as in our study, around 65% patient needed therapeutic keratoplasty and 20% healed with medical treatment. If managed aggressively and timely, glove salvage rate is high. As seen in our study, 90% of the patient had a good outcome, and there was no evisceration. Early diagnosis, targeted meticulous management, regular follow-up are the key for managing these cases successfully. Thank you, Vanan.
Thank you, Dr. Bharat. Can you stop? Yeah. So Dr. Astha is there? Dr. Astha Rawat, you can start your paper. Still not shared, ma'am.
It will take some time.
So can we take the next presenter then?
Yes,
If-
sir. Yes, sir. Yes, sir. Please.
Huh?
Yes, sir. Please.
Okay, Dr. Shrishti Sharma is there? Dr. Shrishti? Dr. T. Samita? Dr. T. Samita?
ओके
सीताराम?
Yes, sir.
मैं घर पे हूँ अभी और उसके बाद क्लिनिक में सेटअप लगा रहे हैं 11 बजे पेटी लगाई है।
Can you start your case?
अभी अभी घर पे आओ फिर नीचे चलते हैं वहां 10 मिनट बाद। पहले घर आ जाओ। गाड़ी तो वहां मेरे।
Dr. Samita?
Yes, sir.
Yeah, please start your case.
Sir, Dr. Shrishti is present.
She is not, she is taking some time, so you can start the case.
So is it my slide visible?
Yeah. Please start.
Good morning, everyone. I'm Dr. Samita, presenting a free paper on the autologous Tenon's patch graft for the corneal perforation management, which is a simple and inexpensive technique. As we know, the corneal perforation is an ocular emergency. It requires urgent treatment so as to maintain the globe integrity. Otherwise, it can lead to the loss of vision and the loss of eye. For the management of the corneal perforation, if the size is small, then we can do glue vessel application, amniotic membrane graft, corneal patch graft, Tenon's patch graft, and DALC. And if the size is very large, then we can use either penetrating keratoplasty or keratoplasty. Recently, the Tenon's patch graft has been described for the management of the corneal perforation of size 3 mm to 6 mm with successful outcome. And it is also seen to be used in cases of failed adhesive applications and also done in cases when the donor corneal tissues are not available. Herein, I am presenting a retrospective case series of 7 patients who underwent a Tenon's patch graft from the March 2020 to May 2021 at AIIMS Rishikesh during the COVID period. Here, the medical records of all the patients were evaluated for the demographic data, primary diagnosis of the eye, and the associated systemic disease, base corrected visual acuity, size and site of the perforation, posterior segment evaluation, and the intraocular pressure measurement. And the size of the perforation were measured in the greatest dimension and along an axis that is perpendicular to it. And the site of the perforation were categorized into central, which is about 4 mm from the center of the cornea, paracentral, which is around 4 to 8 mm, and the peripheral, which is around 8 mm from the center of the cornea to the limbus. In all the cases, the surgery was done under peribulbar block. Here, the Tenon's grafts are harvested from the supratemporal quadrant, and the size was taken somewhat slightly larger than that of the defect, and the graft was sutured by using 10-ethanol monofilament, either by of the 2 techniques. First one is the interrupted suture, and the second one is the figure of 8 suturing technique. In all the cases, the AC is formed with the air bubble, and the sinoacrylate glue plus BCL was placed over the graft, and there was no intraoperative complication. And the glue that we used was removed after 2 weeks of the surgery, and the patient was advised to follow up until there is complete epithelializations and the subsequent scar formations. The average age of the presentation was from 35 to 67 years, and there were 4 female and the 3 male. Etiology of the corneal perforation includes there was 4 cases of necrotizing stromal keratitis, 2 cases of dry eye, and 1 cases of neurotrophic keratitis. Right eye was involved in 2 cases and left eye in 5 cases. Base corrected visual acuity initially was at the time of presentation was from hand movement close to face to the finger counting at 2 meters. And the perforation site was paracentrally in all of the cases except in the 1 cases where the perforation is located centrally. The perforation size ranges from 2 to 3.7 mm, and the final best corrected visual acuity was somewhat improved in all of the cases. And this is the slit lamp picture showing preoperative, postoperative day 1 and the final outcome of the patient. Here we can see in the postoperative period, the graft was well adhered to the corneal tissues, and finally there is formation of the scar. In 6 cases, there is formation of leukomatous scar formation with the preservation of normal anterior chamber depth. And in 1 cases only, there was adherent leukoma formation. This is seen in case of the case number 3. And this are other of the preoperative, postoperative day 1 and the final outcome pictures. And also in the anterior segment, we can easily see that the tenon stretch grafts was incorporated into the host corneal tissue, maintaining somewhat a normal contour of the cornea, and the epithelium is masking whatever the irregularity was there. And we compare our study with other 2 of the studies, which was conducted by the Sanita Kora et al. In 2015 and Namrata Sharma et al. In 2018. Here the final outcome was compared. Final outcomes, which is the percentage of the eyes that healed with scarring and well-formed central AC. It was 100% in our study and 74% in the Sanita Kora et al. Study and 82.7% in the Namrata Sharma et al. Study that was conducted in 2018. So we can easily conclude that the tenon stretch graft is an autologous tissue that is readily available and inexpensive with no risk of resection or transmission of diseases, and does not preclude or increase the risks of the future corneal transplantation surgery and if required for the visual rehabilitation. So this tenon stretch graft is a valuable tissue in the time of the COVID crisis situation where there is a paucity of donor corneal tissue. Thank you.
Thank you, Dr. Samita. Judges, kindly note that this was free paper 14 by Dr. Samita. So, Dr. Asta, are you ready with your paper? Dr. Asta?
Yes, sir. Yes, sir.
Kindly start the presentation. It will be free paper 12.
Yes, sir.
Yeah. Please start.
Good morning, everyone. I'm going to present a case series of orbital cysticercosis at Tertiary Care Center of Kumaon, Nainital. So my first case is of an 8-year-old male who presented with painless swelling in his right eye for 15 days and diminution of vision for 15 days. Patient was non-vegetarian by diet and belonged to a poor socioeconomic group. There was no history of trauma, double vision, seizures, loss of weight, fever, palpitation, heat intolerance, and cold. On right eye examination, there was proptosis of around 22 millimeter and RAPD was found in right eye. On fundus examination, disc edema was found in right eye and extraocular movement, abduction was deficit in right side. Left eye examination was within normal limit. On investigation, all routine blood investigations were within normal limit. MRI was done. MRI shows a cystic lesion near orbital apex and well-defined lesion in right parieto-occipital lobe with perilesional edema. Ultrasonography was done. UST B scan was showing a cystic lesion with low equireflectivity with high interreflective area, which was suggestive of scolex. So on the basis of all these findings, diagnosis of myocystic was made. So treatment started. Oral steroid was given in tapering fashion, followed by tablet albendazole, 15 milligram per kg body weight for 21 days. In my second case, a 12-year-old male presented with whitish lesion in his left eye for 2 months and painless diminution of vision for 2 months. There was no history of trauma, double vision, seizures, loss of weight, fever, non-vegetarian by diet and belonged to a low socioeconomic status. On examination, subconjunctival cyst with marked congestion was noted in left eye. Rest ocular and systemic examination was within normal limits. Investigation, ESR was raised and AC was raised. Rest blood profile was within normal limit. On CT scan, tiny calcified lesion was found in left temporal area, left temporal region. On treatment, spontaneous extrusion of cyst was done, followed by which was sent for histopathological examination. On histopathological examination, larva of Taenius oleum was found. Oral steroid was given. Around 1 milligram per kg body weight started in tapering manner, followed by tablet albendazole 15 milligram per kg body weight. Topical antibiotics and topical steroid was started in tapering fashion. In case 3, this is a case of a 53-year-old male who presented to a OPD with chief complaint of drooping of right eye upper lid for 25 days. According to patient, this drooping was sudden on onset and it was non-progressive. Patient was farmer by occupation and he belonged to a poor socioeconomic status. He was non-vegetarian. On examination, moderate grade of ptosis was found. Rest ocular and systemic examination was within normal limit. On investigation, absolute eosinophil count were raised. Rest blood profile was within normal limit. Ultrasonography was done in left eye, in right eye. It was showing well-defined cystic lesion with an echoogenic focus with most likely suggestive of scolex. MRI was done, MRI orbit with brain, which was suggestive of well-defined cystic lesion in superior rectus and LPS muscle complex. So the diagnosis of myocystic was made. On treatment, tablet albendazole was given for 1 month and tablet prednisolone 1 milligram per kg body weight, tapered over 4 weeks. Patient was kept on regular follow-up. This is a post-op picture of follow-up picture of the same patient, which was showing marked improvement in his ptosis. This is my case number 4, which was showing a 42-year-old male presented with whitish mass floating inside left eye since 15 days and painless diminution of vision in left eye since 15 days. There was no history of trauma, double vision, seizures, loss of weight, and the patient was non-vegetarian and alcoholic, belonged to a poor socioeconomic status. On the examination, visual acuity was reduced, which was 618 in left eye. Conjunctiva was congested in left eye and transparent in right eye. On cornea, KPs were found, kinetic precipitates were found. Anterior chamber live scolex was showing, which was showing undulating movement. Fundus was not visible because pupil were undilated. Extraocular movement were full in all gazes. IOP, intraocular pressure was 25 millimeter of mercury in affected eye. Routine investigation was within normal limit. So patient investigate tiny on CT scan, tiny calcified lesion in parietal and frontal lobe was seen. Oral steroid started with 1 milligram per kg body weight, followed by visco expression of cyst was done and sent for histopathological examination. On histopathological examination, larval stage was found. We started tablet albendazole 400 milligram twice a day for 28 days. Topical steroid and antibiotic were started. Regular follow-up advised and with radio imaging. So cystic sarcosis, it is a preventable and eradicable cause of blindness. Human cystic sarcosis occur when human act as intermediate host by ingesting the egg via fecal-oral route. In contrast to Western literature, Indian studies have reported ocular adnexa is the most common site of involvement, while the most common site reported in Western studies is posterior segment. Orbital imaging is the mainstay of diagnosis in orbital myocystic sarcosis. Serial ultrasonography is done to monitor a patient on medical management. Posterior segment of eye vitreous cyst is seen more commonly than retinal and subretinal cyst. Diagnosis of posterior segment is made with clinical findings, serological tests, ultrasonography, CT, and MRI scan. Prevention and control to prevent tinea solium, proper public health intervention with approach spanning veterinary, human health, and environmental sectors are required. Appropriate surveillance mechanism is needed. Treatment of human teniasis, intervention in pigs like vaccination plus anti-helminthic treatment, community health education, including hygiene and food safety, improper sanitation, improved pig husbandry, improved meat inspection and processing of meat products. Thank you.
Oh, thank you, Dr. Asta. Dr. Shrishti is there? Dr. Shrishti?
Yes, doctor,
yes,
I
sir.
can see her in the participants. Yes, she's here.
Yes, sir. Sir, actually, my video is not working. So can I present?
Yeah, it's okay. Dr. Siddharam, are you there, sir?
Yes, sir.
Yeah, please start your presentation.
1 minute. Sharing.
So this is free paper 15, right?
15, sir.
Yeah. Okay.
Okay. So good morning. I'm going to talk about presenting
Slide show
on
sir, slide show कर दीजिए.
Okay. Okay, to study the various ophthalmic manifestations in intracranial space occupying lesions and visual field defects caused by intracranial lesions. Materials and methods. Here we included all patients with radiologically proven intracranial tumors and gave consent for the study. And exclusion criteria: uncooperative patients with deteriorating gender conditions or marked behavioral disorders. And all patients are clinically evaluated after obtaining the clinical history and examination in central nervous system, which include examination of higher functions, cranial nerves, motor system, sensory system, and cerebellar lesions were made. Ophthalmic examination include visual acuity, color vision, RAPD, and extraocular movements, corneal sensation, and slit lamp examination. Followed by visual field defects recorded by the amplified test. Total we are included 78 patients, and in that most common age group, the included age group is 11 to 60 years of the age. Most common age group in our study is 31 to 40 years of the age. Females are preferred around 46 patients. Most common presentation of these patients is headache, followed by the blurred vision, and diplopia 9% of the patients. Other complaints like vertigo, Alzheimer's disease, and others. The most common, this patient presented to the medicine department, followed by ophthalmology and neurological departments. The visual acuity recorded in these patients around 20% will be 6 by 60, and 6 by 12 to 6 by 16, 34% of the patients, and less than 16 patients will have vision less than 6 by 60. And on examination, there was 2 patients ptosis and 2 patients internuclear ophthalmoplegia and nystagmus in 6% of the 6 patients. And 27% of the patients presented with 6 nerve palsy and 20% with facial nerve palsy. When you check the pupillary reaction, 28% of the patients presented with relative apparent pupillary defect. And on fundus examination with the direct and indirect scope, most common presentation of papilledema around correspond to 38% and 20% with optic atrophy in cases of pituitary tumors. Most common tumors come across in our study is pituitary adenoma, followed by meningiomas and craniopharyngiomas. This is the CT pictures of macroadenoma. This is a picture of glioma, meningiomas, CP angle tumors. And this is MRI picture of trigeminal neuralgia. And depending on the location, most common tumor come across in our studies perichiasmal tumors, that is mostly is pituitary adenoma, followed by CP angle tumor. The visual field defects recorded by the Humphrey visualizer, most common visual field defect come across is bitemporal hemianopia around 20%, and enlargement of blind spot is 15%, and peripheral visual defects correspond to the 6% of the patients. And summary of our study is most common age group was 30 to 40 years of the age. Presenting complaint was headache. Follow on entry segment examination, there will be 6 nerve palsy and 7 nerve palsy and pupillary defects. Fundus examination was papilledema, and most common tumor come across is pituitary adenoma. Location was perichiasmal tumors and CP angle, and field defects was bitemporal hemianopia. Conclusion is ophthalmic signs and symptoms of form a major part of the presentation in patients with intracranial tumors. All these simple signs should not be missed out, as it may be missing out a big diagnosis which will be life-threatening of the person. Health education and complete ophthalmic evaluation is essential in patients with brain tumors, as it may lead to permanent blindness. Thank you.
Thank you. Thank you so much, sir. Dr. Shishti, are you ready with your presentation?
Yes, sir.
Yeah, kindly start your presentation. It's free paper 13, right?
Yes, sir.
Yeah, please start.
Good morning, everyone. My name is Dr. Srishti Sharma. I'm junior resident of AIMS Rishikesh. The topic for my presentation will be association of refractive errors with strabismus in children and adolescents. Strabismus is a very common condition in childhood with a variable prevalence ranging from 0.8% to 5.6%. The prevalence of visual impairment due to refractive errors alone varies from 0.4% to 42%. Both these refractive errors and strabismus are considered significant contributors of visual impairment and treatable blindness in general population. But there is insufficient literature on the relationship between these different types of strabismus with refractive errors, especially in India. So what was the purpose of our study? The aim was to study the association between refractive errors and different types of concomitant strabismus in children and adolescents. And the objectives were to determine the proportion of different types of concomitant strabismus, to determine the proportion of different types of refractive errors, to determine the association between these refractive errors and concomitant strabismus. The study population were the patients visiting ophthalmology OPD of AIIMS Rishikesh, and participants were selected according to the following inclusion and exclusion criteria. Those who were willing to provide written informed consent, and children between age of 4 to 19 years of age, and with deviation of greater than equal to 15 prism diopters on prism bar cover test were included, and the patients who had previous history of squint surgery and concomitant strabismus were excluded from the study. The study was conducted between July 2017 to June 2020, and the study design was a hospital-based cross-sectional observational study. The sample size was calculated based on a study in Manipur on the pattern of concomitant strabismus, where the prevalence of concomitant strabismus was 83.3, and the patients included in the final analysis was 178. Now, in the methodology, there was written informed consent was taken, and assent was taken wherever applicable. Then a relevant history was taken, and the data were collected using a pre-designed and pre-tested questionnaire. Hirschberg corneal reflex test, cover uncover test, prism bar cover test, and Primsky test were performed. Visual acuity was tested using Snellen's chart or its equivalent, and dry retinoscopy and cycloplegic refraction were performed under cyclopentolate 1% or atropine 1% eye drops wherever applicable. The results of the study were the mean age group was between the range was 4 to 19 years of age, and the mean age was 11.2 plus minus 5.49 years. The mean deviation was found to be 39.22 plus minus 11.74 prism diopters. Out of the 178 patients, 97 were male and 81 were female. And according to our study, the most commonly found type of deviation was exotropia with 49%, followed by esotropia, which was 42%, and then combined type of deviation, which was 9%. Then also the type of refractive errors, the most common type was hypermetropia with 47%, followed by myopia, then emetropia, and then 7% were combined refractive error, and 3% were astigmatism. Among the hypermetropes, 52 patients had esotropia and 29 had exotropia, and in the myopic group, 25 patients had exotropia and 8 patients had esotropia. But further, 52 of the esotropes had hypermetropia, but there was no such trend noticed among the exotropes. 87.5% patients were having deviation within the range of 15 to 35 prism diopters had best corrected visual acuity of 6/12 to 6/6 in the worst eye, and amblyopia was found in 39.32% patients of this study population. Out of these, 50% had esotropia, and 53.3% of the esotropes had amblyopia. And 56.3% of the patients having history of onset of deviation within 6 months of age had deviation between 36 to 55 prism diopters. So coming to the discussion part, the uncorrected refractive errors are the leading cause of moderate to severe vision impairment globally, and this leads to abnormal binocular interaction, which can lead to strabismus. Infants with hypermetropia are more likely to develop strabismus, and if it is left uncorrected, then it can lead to refractive accommodative esotropia also. In our study, hypermetropia was found to be the most common type of refractive error, followed by myopia, combined refractive error, and astigmatism. Then there is a statistically significant bidirectional association between hypermetropia and esotropia. This is because there is increased demand of accommodation in hypermetropes, leading to more accommodative convergence. Thus, there is increased risk of developing esotropia in these patients. And there was a unidirectional association noticed between myopia and exotropia. So only ensuring good best corrected visual acuity with glasses cannot prevent the development of strabismus, but it can lead to less amount of deviation. And there was also statistically significant association between amblyopia and esotropia. And also, if the onset of strabismus was within 6 months of age, then it led to a greater amount of deviation as compared to onset at a later age. So concluding, the most common type of refractive error associated with concomitant strabismus in our study was hypermetropia, and the most common type of deviation found was exotropia. Hypermetropes were more likely to have esotropia, and myopes were more likely to have exotropia. But and esotropia had a more common association with hypermetropia, but there was no such trend noticed among the exotropes. And also esotropia and hypermetropia were more common among amblyopes. And if there is onset of strabismus within 6 months of age, then it leads to a greater amount of deviation as compared to onset at a later age. Thank you.
Thank you. Dr. Mehak, are you there?
Yes, sir.
Yeah, please start.
So my paper presentation is comparison.
We are not able to see your presentation. Dr. Mehak, we are not. Yeah, now it is. Yeah. Now start.
Yes, sir. Retinal vein occlusion is the second most common retinal vascular disease after diabetic retinopathy. The greatest sources of visual loss associated with CRVO or branch retinal vein occlusion are macular edema, macular ischemia, and sequelae of neovascularization. Cystoid macular edema in retinal vein occlusion has a complex multifactorial pathophysiology. Increased hydrostatic pressure distal to the occlusion causes damage to tight junctions of capillary endothelial cells, which deteriorates the integrity of the blood-retinal barrier. This leads to an efflux of vascular fluid and protein in the macula, causing visual loss. Hypoxia from retinal vein occlusion is associated with upregulation of vascular endothelial growth factors and interleukin-6, both of which contribute to blood-retinal barrier breakdown, increased vascular permeability, and worsening of macular edema. Corticosteroids are gaining popularity in managing macular edema of retinal vein occlusion, as its effects span over controlling and limiting angiogenesis by downregulating VEGF production, re-establishing retinal fluid homeostasis, and reducing edema, additionally having anti-inflammatory, anti-apoptotic, and anti-proliferative properties. My aim was to compare the efficacy and side effects of the intravitreal triamcinolone and intravitreal dexamethasone implant in patients with macular edema secondary to retinal vein occlusion. Materials and methods that we used were preoperatively the best corrected visual acuity was noted. Intraocular pressure was measured by the Goldman applanation tonometer, and central macular thickness was measured by OCT. After preoperative evaluation, patients were subjected to receive either intravitreal triamcinolone acetonide injection of 4 mg per 0.1 ml or intravitreal dexamethasone implant, that is Ozurdex. The follow-up was done at 7th day, first month, followed by monthly evaluations for a minimum duration of 6 months. At all follow-up, best corrected visual acuity, intraocular pressure, and OCT was measured, and comparison was done between the two. Other side effects like cataract progression was also noted. Exclusion criteria was existence of other retinal vascular diseases, existence of macular edema due to other causes, patients having glaucoma, which was either previously diagnosed or was diagnosed at the time of evaluation, patient who has had previous treatment for retinal vein occlusion, any iris neovascularization, or any active ocular infection. My result was the baseline parameters were out in the Ozurdex group. 8 patients were there, out of which 5 were males and 3 were females. In the IVTA group, 10 patients were there, out of which 8 males and 2 were females. The group was around 58.75, plus minus 12.13 standard deviation in Ozurdex group, and 0.30 plus minus 0.60 standard deviation in IVTA group. Hypertension, 5 patients were hypertensive in the Ozurdex group and 6 patients were hypertensive out of the 10 in the group. Graph and table is comparison between the logMAR best corrected visual acuity between Ozurdex and IVTA group. It shows the significant improvement in best corrected visual acuity at all at as early as the first week after injection. Further significant improvement was noted at all in the group. The effect was at the end of the second month in the Ozurdex group, following which the effect in best corrected visual acuity started to wane off. But at follow-up visits, there was no significant difference noted between the Ozurdex and the IVTA group, indicating equal efficacy. The following graph and table depicts comparison of the central macular thickness between Ozurdex and IVTA group. The decline in central macular vision thickness was noted earliest at the first week, and significant improvement occurred at all follow-up visits. As seen in the visual acuity, effect central macular thickness in Ozurdex group, whereas it was noted after the third month in the IVTA group. However, no statistically significant difference was seen between Ozurdex and IVTA group at injection. This is similarly the central macular image showing the OCT of the pre-op first month, second month, and sixth month in the Ozurdex group. The following graph and table shows a statistically but the effect is seen at second month in Ozurdex group and at the third month in the IVTA group. IVTA and Ozurdex 75% efficacy in the Ozurdex group, 60% in the IVTA group. Hence, intravitreal steroids help in reducing macular edema. The rise in intraocular pressure was seen both the higher in IVTA anti-glaucoma medications. None of the groups reported any post-injection endophthalmitis. Cataract formation was seen only in one patient in IVTA group and none in the Ozurdex group. The lower incidence of cataract can be due to smaller size, sample size, and the shorter follow-up period. Intravitreal steroids are thus effective treatment modality in improving visual acuity and reducing macular edema in cases of retinal vein occlusion. But the only concern following aseptic administration of intravitreal steroids is the rise in intraocular pressure, which can be managed by anti-glaucoma medication and surgical interventions. Intravitreal triamcinolone acetonide is cost effective as compared to Ozurdex. Thank you.
Okay, thank you, Dr. Mac. Dr. Anjali, are you ready?
Yes, sir.
Yeah, start your presentation.
Sir, is my screen visible?
Yes,
ma'am.
yes.
Ma'am, please camera on.
So can I start?
Yeah, please start, please.
Okay. So good morning, everyone. Today I'll be presenting a paper on monoostrotic orbital fibrous dysplasia leading to proptosis in an 11-year-old boy. So I, Dr. Anjali Rana, is presenting the paper along the co-author is Dr. Nisha along with me. Also, there is Dr. Jitendra Chaturvedi, who is assistant professor in Department of Neurosurgery, and also Dr. Anupam Singh ma'am, who is additional professor in our department. So, an 11-year-old boy who is the resident of Sambal district of Uttar Pradesh presented to us with the chief complaint of outward bulging of right eye, which was noticed by his mother for a period of 1 year. This outward bulging was insidious in onset, painless, gradually progressive, and was associated with limitation of eye movement, as you can see in the below diagram. He consulted some local hospital but was referred to our institute. There was no history of any decreased vision, double vision, any trauma, any recurrent cold or cough of the patient, any loss of smell, any weight loss, or any similar swellings in the other parts of his body. There was also no complaint of any headache, vomiting, seizures, any focal neurological deficit, or any personality changes. So on examination, we found out that the affected eye had unaided vision of 6/6 pars. So we did a cycloplegic refraction for the child. So the acceptance came out to be of -0.5 diopter spherical. The head posture was maintained. The facial contour was seen to be asymmetrical. The pupil reaction of the affected eye was also normal. There was slight restriction in the upgaze movement of the right eye with -1 and -2, as you can see. The anterior segment examination of the affected eye was also normal, and the posterior segment examination was also seen to be as normal. Also, we did color vision and contrast sensitivity for the child, and we found out that they were both normal.
We did hurdles for the child and we found out that the proptosis was 22 mm for the affected eye at base diameter of 98 and the normal eye being at 14 mm. So the local examination of proptosis that was non-axial, non-tender, non-retropulsive, non-pulsatile, and it did not increase in size by valsalva or cuffing. We did some blood investigations for the child and we found out that the CBC, LFT and KFT were within normal limits. We went forward with USG B scan and it showed normal posterior segment and normal intracoronal compartment. We also did non-contrast CT scan for the patient, which somewhat took us to the diagnosis, which showed a well-defined lytic expansile lesion, as you can see in the first figure, which was bulging into the superior medial part of the orbit. It had some ground glass matrix, as you can see in the second diagram below with the yellow arrow. It was compressing the right superior rectus, superior oblique, and it was lying just near to the medial rectus. So all these features from CT scan were suggestive of fibrous dysplasia with no periosteal reaction. We also went forward with contrast enhanced MRI, which was basically done to rule out any invasion of the brain parenchyma or any optic nerve involvement. We found to be both as negative. This also, the lesion showed enhancement with the contrast as seen by the green arrows. So we went forward with the surgical intervention for the 11-year-old child, and it was done by right pterygoid craniotomy by the neurosurgery department. And the lesion was taken out and sent for histopath. The histopath report also showed to be suggestive of fibrous dysplasia only. As you can see in the diagram with the black arrow, that there was this black arrow shows the osseous material with nearby fibrous cells. We followed the patient post-operatively. The patient was completely normal with 15/15 GCS. The affected eye has visual acuity as previously as 6/6 parts. The pupillary reaction was within normal limits. The change was that extraocular movement restriction had reduced in the affected eye. The anterior segment and posterior segment examination was also normal. The color vision and contrast sensitivity as previously was normal, and importantly, the exophthalmometry by Hertz had reduced from 22 to 16 mm at a base diameter of 98 only. This is the post-operative 9-gaze photograph of the child. As you can see, there is slight restriction in the up-gaze movement of the child. Rest appears to be within normal limit. So the take-home message will be that the fibrous dysplasia is, although a rare cause of gradual painless proptosis in young children, but it should be considered in the bucket list of differentials, because if we undertake any prophylactic measure of surgical decompression of the lesion, the vision can be salvaged in appropriate time, and it could be very beneficial for, especially for young children, to have a long life ahead of them. Thank you so much.
Thank you, Dr. Anjali.
Yes, sir.
Dr. Anshika, are you ready?
Yes, sir. Yes, sir.
Yeah, please start.
Yes, sir. Okay. Good morning, everyone. I'm presenting my paper on clinical and demographic profile of mechanical ocular trauma during COVID-19 pandemic.
AV team, can we restart the timer for 6 minutes? AV team.
So ocular trauma is a leading cause of monocular vision loss and blindness, especially in young individuals. Vision loss caused by ocular trauma impacts the quality of life of the patient and also socioeconomical and psychological impact on patient and the families. Global data shows it to be an emergency where timely intervention is imperative for visual outcome. Demography influences the nature and cause of trauma in both developed as well as developing countries. So COVID was a highly contagious respiratory tract infection, which was declared a pandemic on March 11, 2020. Indian government implemented an early and strict nationwide lockdown as a preventive measure, and this had 4 phases followed by some unlock phases. So we are a tertiary care center in the capital of Uttarakhand that catered to a majority of ocular emergencies in our area during this lockdown period. And owing to the conversion of other tertiary centers to COVID dedicated hospitals along with restricted functioning of smaller setups. This study aims to assess the trend of ocular trauma during the lockdown period and COVID pandemic in inpatient department of ophthalmology in a tertiary healthcare center. So this was an analytical, observational, retrospective hospital-based study. 60 cases presented during the months from March to August, the years 2019 and 2020. The patients were divided into two comparison groups based on their period of presentation. Group 1 had pre-COVID era patients that were admitted in 2019, and Group 2 had COVID era patients that were admitted in 2020. We chose an inclusion criteria for all patients presenting with mechanical ocular trauma requiring hospitalization for medical or surgical intervention to our tertiary care hospital. Standard protocol was followed for examination and admission of these patients based on guidelines issued by MOHFW, Government of India, and AIOS. And all the mechanical eye injuries were divided into open and closed globe injuries as per Birmingham Trauma Terminology classification, and further classified into anatomical zones as well. So what were the results? Age and gender distribution, we saw that the male to female ratio was 2:1 in the pre-COVID group, and it was 9:2 in the COVID group. Maximum patient turnover in the pre-COVID group was in the month of August, while in the COVID group, this was in the months of May and June. The monthly distribution was statistically significant for the months of March as well as June, and the overall monthly distribution was also statistically significant with a p-value of less than 0.005. Type of injury in the pre-COVID group, we saw that 77.8 patients presented with open globe injury, while 22.2 patients presented with closed globe injuries. Apart from this, 52.3% of open globe injuries and 33% of closed globe injuries belong to the adult age group. In the COVID group, 63.6% of patients presented with open globe injury, while 36.4% presented with closed globe, and 52.3% of open globe and 75% of closed globe were in the adult age group. Place of injury in both pre-COVID and COVID groups, there was a majority of outdoor injuries. It was 67% in pre-COVID group, and it was 57.6% in the COVID group. So thus an overall decrease in outdoor injuries was observed. Grading of injury, it was graded into anatomical zones. In the pre-COVID group, we can see that maximum involvement was of zone 1. And in the open globe injuries, while in closed globe injuries, zone 3 was majorly involved at 50%. While in the COVID group, both open and closed globe injuries showed maximum involvement of zone 1, indicating a decrease in severity of the injury. Visual status, the low visual status group from less than 6/62, no PL was documented in 66.67% of patients in the pre-COVID times, but only in 45% of patients in COVID times. So male dominance was witnessed in both groups. A male preponderance in ocular trauma is well established as they are frequently exposed to outdoor work and known to indulge more in rash driving, resulting in RTAs as compared to females. However, this trend experienced an ascent in the COVID group despite lockdown conditions, as the fraction of males increased from 66.67% to 81.8%. This is in concordance with Pellegrini et al., a study conducted in Bologna, Italy, where proportion of males increased from 66.7% to 75%, and Samia Ali et al., which displayed an increase from 62 to 79%. Thus, we can hypothesize that outdoor sustentative activities were largely done by males during lockdown period, and this, in conjunction with a relative decrease in outdoor activities for females, resulted in an ascent in this trend. The difference in number of patients presenting was statistically significant for the months of March and June, with a pre-COVID to COVID ratio of 8:1 in March and 1:10 in June. This can be attributed to the fact that the nation was under complete lockdown in March, which was then eased into a partial lockdown during the months of May and June. This is in concurrence with Agarwal et al., who observed a gradual increase in patients presenting with ocular trauma in the months of May, June, and July. While a similar percentage of zone 1 for open globe injuries was observed in both groups, it increased from 33.34% to 75% in closed globe. This indicates a decrease in the severity of injuries during COVID times. However, no correlational data was available for the same, as none of the previously conducted studies classified injuries based on their anatomical zones. The fraction of closed globe injuries increased from 22.2% to 36.3% in the COVID group, owing to a surge in closed globe injuries in adult age group from 15 to 45%. This again is in concurrence with Agarwal et al., where fraction of closed globe injuries did increase from 16.9% to 33.8%. Lower visual status was documented in 66.67% patients in pre-COVID. This decreased to 45% in COVID. This correlates with the observed decrease in severity of injury in COVID times. However, it is in contrast with the study done by Samia Ali et al. That documented a considerably lower median visual status during COVID times than in pre-COVID times. The limitations of this study were that it was performed in a single institution, it was retrospective. We did not explore the barriers to accessing eye care services in patients who were visiting the hospital, and duration between patient incurring the injury and presenting to emergency was not accounted for. Apart from this, post-op visual acuity was not documented. In conclusion, ocular injury is a quotidian antecedent to ocular morbidity in children as well as adults. An increase in male preponderance was seen, which may be attributed to males largely performing daily sustentative activities. A decrease in severity of injuries was observed, which corroborated with better visual acuity at presentation in COVID era. And apart from this, a surge in closed lobe injuries was witnessed in COVID era. How such a propensity towards closed lobe trauma as a trend would continue in post-COVID times of new normal is yet to be seen. These are my references.
Thank you, Dr. Anushka. So I think we are finished with the papers of this session.
Yes, doctor. We have finished exactly 4 minutes before time, so I think we can have rest. We can give our eyes a bit of rest, and then we'll begin with the next session exactly at 11:30.
Yeah. Thank you.
Thank you so much, doctor. In the meanwhile, before we start with the next session, well, I believe the next session is at 11:30. So I think it is not at 11:30 and it is at 12:30. So I think we have a break for 1 hour now.
ये सेशन होगा उसमें 4 मिनट टाइम रहेगा.
हाँ सर.
4 मिनट रहेगा.
सर अभी
मुझे लगता है कि जो नेक्स्ट सेशन हमारे शेड्यूल में जो दिख रहा है ना, वो तो 12:30 का दिख रहा है. एक बार आप चेक करेंगे कि 12:30 का है कि 11:30 का. कभी कभी मिस्टेक हो जाता है. तो नेक्स्ट सेशन जो डॉक्टर चारू मित्तल जो जज हैं, डॉक्टर मोहित खत्री, डॉक्टर प्रशांत नैथानी, डॉक्टर सुमी गुप्ता और डॉक्टर रोहन मेहता. करेक्ट?
मेहरा.
डॉक्टर रोहन मेहरा. वही सेशन है ना अभी इसके बाद तो.
हाँ. So it is at 12:30.
इस सेशन में भी टाइम सर 6 मिनट रहेगा या 4 मिनट रहेगा?
हाँ, इसमें भी अभी तक तो हम लोग टाइम पे चला रहे थे, तो उसी हिसाब से दे दो. 4 मिनट ही दे दो, कोई टेंशन नहीं है. बट एक बार आने दो उनको. तो सब लोग एक बार आ जाएंगे, नहीं तो बाद में गुस्सा भी करते हैं कि इतना क्यों टाइम कम दिया, है ना? ठीक है, मुझे लगता है 12:10 में मिलते हैं, 20 मिनट पहले. ठीक है.
ओके सर.
Hello.
Yes, sir. Hello. Dr. Gopal Agarwal. Dr. Gopal Agarwal.
Hello, sir. We shall be going live in the next 10 minutes. Can we request all the speakers to check their presentation videos right now? Hello, Dr. Anirudh.
Sir, I'm here.
Hello. Yes. So just wanted to check, you are going to be presenting yourself, correct? The video or the presentation?
Yes, sir. Yes, sir.
So would you like to take a stab at it? Would you like to try your screen sharing and see if it's working?
Yes, sir. I'm trying that. Just a sec.
Are you using your mobile phone? No, right? You're using a laptop.
Yeah, sir. Sir, is it visible? Is my PowerPoint presentation
Yes,
visible?
it is visible. Could you just put it in the presentation mode?
Yes, sir. Just a second.
You're
Is
going to
it
be
visible
going,
now, sir?
yes, you're going to be going in first. So
Yeah, sir.
be
Sure.
on standby.
Ji, sir.
So there are a total of 10 speakers in a matter of 60 minutes. So that's approximately, we're going to be giving 4 minutes each, plus 2 minutes to change over and so on. So please, it has to be fast. I kindly request you to keep all your presentations open in a separate window so that you can start your screen sharing. The moment the first speaker or the speaker which is before you stops his screen sharing, you can start your screen sharing. I'm just sharing the agenda in the chat right now for everyone. That's the lineup. Dr. Anirudh, we are only able to see the screen sharing, that you are screen sharing. We're not able to see a presentation. Yeah, now we are able to see the presentation coming in. They just put it in the presentation mode and hold.
Is it visible now, sir?
Yes, perfect.
Okay, sir.
Do we have Dr. Mohit with us? Are we aware of any cancellations? Please do let me know. Dr. Priyanshi, I believe you will be going in next because no other speakers are there. Is your presentation ready? You're on mute. Dr. Priyanshi, I believe you're using two devices at the same time, and that's the reason why there's an echo. So just keep one device for your audio and video. Keep the other devices switched off and log out from the other device. In the meanwhile, you need to be ready with your presentation. You would be going in next after Dr. Anirudh. I believe we also have Dr. Amrita. Again, there is a echo in your sound, so please unmute yourself. Let us check your audio. Dr. Priyanshi?
Yes, sir.
Are you using two devices, my dear?
No, sir.
There is an echo that is coming from your end.
Okay, sir, I'll check.
We also have Dr. Amrita. I believe Dr. Amrita, you're also going to be presenting. Am I right?
Yes, I have a presentation too.
Would you like to just try your screen sharing?
Okay, sure. We'll just try that.
Yeah. In the meanwhile, you could also switch on the camera to check that.
Okay.
Your audio is clear. That's good. And I believe you would be going third in line then, because we are trying.
Okay.
We're trying to keep it on. Yes, the presentation is seen. Could you just put it on the presentation mode, please, ma'am?
So it's fine.
Yes, perfect. Sounds good. Sounds good. Looks good.
Okay, I want to check one more thing.
Sure,
I
please
want
go
to check one more thing. I have a video in it, so I just want to see if that plays off well. Okay, just a second, please. Yeah. So, one sec.
Does it also have audio?
So does the video? No,
The
it
video is
doesn't have
playing?
an audio.
Wonderful. All right. So the video is playing, ma'am.
Okay, fine. So it's coming all right, right? No
Yes,
lags. Yeah. Okay, fine. Thank you so much.
We have Dr. Kirandeep Kaur as well. Can we request Dr. Kirandeep Kaur to please check the presentation?
Yes, sir. Sure, sir. Just a minute. How much slides visible, sir, clearly?
You just started. Give it a couple of seconds because I believe the internet. Yes, the sites are visible.
Okay, sir.
Okay, so you can stop your screen sharing. Audio is also good.
Thank you.
So we're just going to be waiting for the chairpersons and we'll get started. So after Anirudh, we would have Amrita because Priyanshi has not yet checked it. After that, we would have Kirandeep Kaur and then we'll follow the rest. We've got Dr. Mohit Khatri also joined in. So I believe now we can get started.
Yes, yes.
So let's get started because we have been given instructions to get started on time. We're going to be following strict timelines. So we've got a total of 4 plus 1 minute that is to be given, plus 1 minute for the changeover. So
It's
we've got
4 plus 1 or it's 5 plus 1 total?
5 plus 1 total. So even after immediately 4 minutes, we're going to wait for a couple of seconds for your timer to switch off, and only then we're going to stop your screen sharing. In case I just wanted to speak to Dr. Mohit, if you would like, we could just keep 5 minutes and make sure that exactly at 5 minutes we stop the screen sharing. What would be your option, sir?
That's okay. No issues. Whatever in the organizers and the timekeepers feel comfortable, that's okay.
Okay, so we can give it 5 minutes. Timer change kar de 5 minutes ke liye. And exactly at 5 minutes, we will stop the screen sharing. So kindly be before time. You will
Yeah,
not be allowed to
that's okay.
speak after 5 minutes. Exactly, total 5 minutes is going to be given. So we
Just stop
have the
screen share after 5 minutes.
yes, exactly. We shall be getting started. We've got Dr. Anirudh going in first, followed by Dr. Amrita, and then Dr. Kirandeep Kaur, and then the next, because these people have already checked their presentations and they're ready to go live. So I'll just introduce the judges and we shall go live, sir. To get started with the session, I request the judges to please switch on the camera and unmute themselves, starting with Dr. Charu Mittal, Dr. Mohit Khatri, Dr. Prashant Naithani, and Dr. Somi Gupta. Our moderator for today is Dr. Rohan Mehra. I request our first speaker, Dr. Anirudh, to please switch on his camera, unmute himself, and start his screen sharing. Dr. Anirudh Sharma, we can see you. Dr. Mohit, can we get started?
Sir, is my screen visible?
Yes, your screen is visible. Dr. Mohit? Dr. Rohan, I believe you are also there. Dr. Rohan Mehra? Dr. Rohan, can you hear us? Dr. Rohan, can you hear us?
Good afternoon.
Yes, sir.
Welcome
So
to
we are
the
all ready.
paper 3 session.
Yes, sir. We are all ready. We were just waiting for your go ahead to get started. With your
right.
permission, can I request the first speaker to get started, sir?
Yes, absolutely. Dr. Anirudh Sharma.
Yes,
Yes,
sir.
sir.
Sir, am I
Dr.
audible?
Anirudh, your time starts now. You can go ahead.
Good afternoon, everyone. My topic is evaluation of role of baseline parameters affecting development and outcome of appropriate therapeutic measures in refractive amblyopia, a prospective school and hospital-based study. Amblyopia is an important public health problem and may produce a lifelong disability, especially in children. Among all the amblyopes, refractive amblyopia is fairly common, apart from strabismic and visual deprivation. It is beyond dispute that if most simple therapeutic measures, such as appropriate optical correction, are instituted earlier, the development of amblyopia can be prevented and its depth minimized. More or less, some part of binocular function may also be retained. The diagnosis of such cases is usually delayed, hence the role of early diagnosis through screening increases many folds. The objective of the study was to evaluate the impact of the following baseline parameters in influencing prognosis and the role of early optical correction and occlusion, if required, in visual recovery in patients with refractive amblyopia. That is, age of the patient at the start of treatment, type of refractive error, best corrected visual acuity at the first visit, that is baseline BCVA, and the degree of anisometropia. This was a prospective interventional school and hospital-based study conducted in children aged 5 to 15 years having refractive errors with straight eyes. Cases were taken from school screenings and from the outpatient department of Regional Institute of Ophthalmology, Prayagraj. The following criteria were used to include cases: school-going children aged 5 to 15 years, children having an interocular acuity difference of 2 or more Snellen lines on best corrected visual acuity, or 6/12 or less in the affected eye. Children already prescribed glasses for poor visual acuity. Exclusion criteria was children having strabismus, presence of any organic lesion in the fundus or efferent visual pathways, and children having stimulus deprivation amblyopia. Additional data were also obtained, that is age, sex, address, and education status of the child, history of previous spectacle wear, age at which eyeglasses were first worn, history of any previous occlusion therapy and compliance with it, history of any learning difficulties or delayed milestones. Total 42 eyes of 21 patients were included in this study, and the patients were subjected to a complete mediculous ophthalmological examination. The depth of amblyopia was graded based on baseline BCVA of the amblyopic eye on the first visit as mild, moderate, severe, and profound. and the degree of anisometropia was graded as mild, moderate, and severe in terms of spherical equivalent. After prescribing appropriate optical correction at the first visit, patients were followed up at 4th, 6th, 8th, 12th, and 24th weeks. Improvement in vision was recorded and was correlated with the considered baseline parameters. If required, occlusion was also given for 16 weeks. At each follow-up visit, the same darkroom equipments and examiner were used to record the following: visual acuity with prescribed glasses, best corrected visual acuity through trial of glasses, and an assessment in the change in depth of amblyopia as a function of change in the number of lines read on the Snellen's chart. Also, the compliance was also checked. Mean age at the presentation of our patients was at 10.24 years, and at the age of onset of the mean age of onset of amblyopia was 9.09 years. The mean difference between the spherical errors, that is the degree of anisometropia, was around 3.99 diopters, and the most common type of refractive error was found to be hyperopia. The mean BCVA at the baseline, that is first visit, of amblyopic eye was 0.774 logmar units. At 24th week, it was 0.442 logmar units. That is practically, it showed a significant improvement of 2 to 3 Snellen lines. There was no significant correlation between age at starting treatment and the amount of improvement in BCVA, but there was a significant reduction in the depth of amblyopia in cases having better baseline BCVA, as we can see in this chart. As the baseline BCVA was better, there was more improvement after 24 weeks. No correlation was found between the type of anisometropia and the amount of improvement, but a significant improvement in BCVA was seen in cases having mild to moderate amblyopia, anisometropia. Maximum improvement was seen in cases of mild anisometropia. The time course of improvement varied greatly among cases. Marked improvement from previous readings was seen at almost every visit. Better initial visual acuity and BCVA and a lower level of anisometropia were found to be good prognostic factors. The results in this study were similar to previous PEDIC trials and studies conducted by Steele et al. And Chen et al., where similar parameters were seen to affect improvements in BCVA. Despite significant improvements, the resolution of amblyopia was not seen in many cases in our study, probably because most patients in our study had moderate amblyopia. Along with this, a short follow-up period of only 6 months and use of no other treatment modality except glasses could also be other reasons. Occlusion was given at 16 weeks in one patient. 6-hourly patching was prescribed, whose BCVA did not improve even after 4 months of receiving optical correction. Children with significant ametropia and anisometropia require early detection through school screenings, as these usually remain undetected, especially in young children. Disadvantages of various baseline parameters, such as those discussed in this study, may be overcome by earliest institution of appropriate optical correction, followed by occlusion if required. Early institution of treatment measures, such as optical correction alone, may relieve the burden on pediatric ophthalmologists of childhood amblyopia. More or less, the compliance with optical correction is much more as compared to occlusion. The relationship between age at commencement of treatment and prognosis still remains unpredictable. Thus, as per the observations of our study, it is always better to diagnose amblyopia with straight eyes at the earliest and institute most simple and acceptable mode of treatment. There were certain limitations. There was a small sample size, a short follow-up period, and a lack of comparison with other treatment modalities.
Sorry to interrupt, doctor, but we would have to stop the presentation as it is past the given time. Thank you so much.
Sure.
Next, may I please invite Dr. Amrita Bajaj for her presentation.
Yes. Is my screen share visible?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Yeah. I'll start.
Yes, doctor, yes.
Yes, good afternoon, everyone. So my topic is smiling through the frowns. Small incision lenticle extraction is a newer laser refractive procedure, and it forms a small peripheral corneal incision for refractive lenticle extraction. It avoids any flap creation and provides a better biomechanical stability. The technique involves the docking, application of the laser, lenticle dissection, and the refractive lenticle extraction. It's more predictable, gives earlier visual rehabilitation, uses a lesser suction and lesser incidence of the dry eye. It minimizes any flap-related complications, gives lesser biomechanical weakening to the cornea, and lesser higher order aberrations. However, an anxious patient, difficult ocular anatomy, and lack of cyclotorsion control can lead to unforeseen challenges during the surgery. These challenges can either be machine-related, patient-related, or surgeon-related. So possible scenarios that we can face are difficulty in the docking, suction loss, appearance of the dark spots, cap tear, difficult dissection, wrong plane of dissection, and lastly, maybe a retained lenticule.
The causes which can lead to all of these is that there can be anxious patients who can make sudden eye rotation movements and who poorly follow our instructions, and a wet cornea and a strong Bell's phenomenon. So let us see some challenges that we encounter by the mode of videos of some smile surgeries that I have. So in this particular video, if we can see something trapped while docking, but I think the surgeon just ignored that. So eventually the laser has started and we actually see that there's an eyelash that's been entrapped. So this has to be made note of before we start the laser ablations. In this next we have an anxious patient who's been guided by the surgeon for not to make any movements, but yet the patient has been moving these movements. So you can actually check the movement while the laser is going on. So this is the third case. In this again, till now everything's been going fine. The patient is not to be seen to be moving or anything, but yet just at the end when we're about to reach the end of our ablation, so that is when we see subtle movements that the patient's been making. So in these subtle movements, we see that while we are making the side cut, the patient moves. So this is really important to not the patient should not move during these movements. Next we have, so the docking should be proper. We can see a fluid ring around and see inferiorly, if you can see the whole of the conjunctiva has been ballooning out. So this should be made sure. This can lead to a suction loss. And obviously this patient did not have a side cut made. So we had to actually struggle through that during the excision of the lenticule. Next, in this particular case, when we see, so the laser has started, we can already see some of these black spots that have been around. So at the end of the laser completion, we see that there have been significant dark spots in just one place that we've seen. When we progress towards the dissection, exactly where we had these dark spots, we are actually facing an inadequate laser in that particular area. So we should always watch out for these dark spots on the laser ablation when we start. So next, see here when we've started doing the surgery, so the surgeon is having a little bit of struggle trying to find out the adequate dissection plane. So he's been very gentle and he's just trying to figure out where the exact plane of dissection is. So he's taking his enough time for it, which is actually right. But once eventually we find out that we've gone into the right plane, so the dissection becomes very smooth for the surgeon. So this is what we're supposed to learn, that we should give it a time before we actually jump onto our next steps. This is a borrowed video. So in this particular video, we can see how the lenticule is being extracted. But yet on the side by side, if we actually see, we can see there's a tear of the cap that we can see. So in these cases, we have to really watch out for the cap tears. And if in case we have a cap tear, then we should wait and actually put a BCL for the patient, which can be removed the very next day. So what all of these things can lead to, there's a risk of abortion of the procedure, there's a rougher plane of dissection, there can be a wrong plane of dissection, difficult lenticule separation, and potentially poor visual outcomes. And finally, at the end of everything, we can have a dissatisfied patient. So SMILE has significant advantages over femto LASIK, and obviously now we've seen that more and more patients are opting for SMILE. This gives surgeons more peace because there are no flap-related complications, and the patient being counseled and leading the patient with every steps ensures a better patient cooperation. So good patient selection and familiarity of the surgeon with the machine is important, which helps surgeon guide his patient with more conviction for better available treatments. So initial learning curve is to be addressed. There should be meticulous approach to the learning techniques, no shortcuts, and we are all learning from our mistakes. So each challenge should be taken as an opportunity to learn. And finally, I would conclude with a good patient selection, better preparedness for the challenges, helps cruise through the achievements for more predictable outcomes in the SMILE surgery. So thank you so much. That's my time.
Thank you so much, Dr. Amrita, for finishing exactly in the given time. Next, we have Dr. Kirandeep Kaur. Doctor, may I request you to please start screen sharing and then begin with the presentation.
Yes, sir. Is my screen visible, sir?
No, doctor, not. Yes, it is visible.
It's visible. Am I clear, sir? Voice is clear, sir?
Yes. Please start with the presentation.
Good afternoon, sir. So I'll be presenting the topic knowledge, attitude, and practices related to digital eye strain among parents of children attending online classes in COVID-19 era. The authors have no financial interest to declare. So COVID-19 is caused by a highly contagious novel coronavirus. Various strategies to counter COVID-19 have led to a dramatic change in our lifestyles. Working, learning, recreational activities have moved to a virtual environment, and the prolonged use of digital devices has impacted our vision and ocular health. The purpose of our study was to analyze the CAP patterns related to digital device usage among parents and to calculate the digital eye strain prevalence and variable presentations. The study was done in a prospective manner over the course of 2 months, in which 305 parents of pediatric patients presenting to pediatric ophthalmology department were included. The inclusion criteria was parents of children attending online classes and those who were willing to participate. Children presenting with any acute conditions or not accompanied by parents were excluded from the study. The various parameters analyzed included general information, demographics, and CAP questions. CAP questions were given a score of 2 to 5 based on the responses, and the study was done after ethical approval from the IRB. So we included a total of 305 parents' responses with mean age of children being 11.7 years. Male-female ratio was almost equal. We had children from standards LKG to 12, with the most common proportion being from 6 to 10 standard. History of spectacle wear was already present in 49% of our study population. So the various reasons for device usage given were online classes was the most common, followed by WhatsApp, video games, YouTube, and Facebook. Smartphones led the way as the most common digital device being used by the children, followed distantly by laptops, tablets, smart TV, and desktop. So we found the mean knowledge score of the parents is 48.5 out of 65. Mean attitude score was 26.7 out of 35, and mean practice score was 17.8 out of 30. 89% of the parents knew the daily digital device exposure should be limited to less than equal to 4 hours, and 69% took care that the children follow the same. 81% knew the importance of correct sitting posture and screen distance, and 72% agreed that they make sure that children sit in correct posture. 87% knew the importance of frequent screen time breaks, and 75% agreed that their children take breaks correctly. So we found a close association between parents' knowledge and practice patterns. Prevalence of digital eye strain in our study was found to be 64.6%, with headache being the most common symptom, followed by eye pain and redness. Abdul Kar et al. Reported prevalence of digital eye strain as 78% in COVID-19 times. This is important in relation to the pre-COVID times, where normal prevalence was 22.3% only. The digital eye strain as an emerging public health threat was reported during the early first wave of COVID itself. So we had 54% of the parents who were working as employees and 30% in the business group. The proportion of children with and without glasses in these groups was almost equal, that was 48.7%. 9% of parents were involved in farming, and in this group only 27% of the children had history of refractive error, while 7% of the parents were doctors, and the refractive error prevalence was as high as 72%. Our results were similar to the study from the COMET group, in which children of parents from white-collar jobs were found to have a significantly higher myopia as compared to parents with blue-collar jobs. 80% of the parents showed concern about disturbed parent-child relationship due to device dependency. This was similar to another study done in 1300 adolescents. HBSC survey also revealed that increased screen time was associated with reduction in health indicators, including the quality of life and family relationships. So we know with the rapid spread of highly contagious nature of this virus, the world seems to have been shut behind the doors. E-learning has been chosen as a platform for continuing education. There is an exponential increase in screen time worldwide among children and youngsters leading the game. The present era of digitalization has raised concerns over digital eye strain and myopia pandemic. Another study revealed that eye strain was higher among students taking online classes, that was 50.6%. Strengths of our study were that this is the first study to evaluate CAP among parents related to digital eye strain. This can help us in implementing strategies to prevent digital eye strain and myopia pandemics in future. Limitations were higher incidence of DES can be probable to hospital settings, and parents could have given desirable answers. To conclude, increased screen time during these lockdowns is inevitable. We found a large knowledge gap related to correct digital device usage. There is a strong need to improvise the knowledge among parents, and the only way to prevent myopia and DES pandemic can be to improvise into more interactive counseling strategies. Thank you.
Thank you so much, Doctor, for finishing exactly before the given time. Next up, may I please invite Dr. Mohit Kumar for the presentation. Do we have Dr. Mohit Kumar over here? Okay, I don't think so, Dr. Mohit Kumar. Okay, he's here. Sir, you are on mute.
Yes, sir. Yes.
Okay, perfect. May I request you to please start screen sharing?
So, my screen is visible.
Sir, just a moment. I think it's loading.
थोड़ा सा साइड हो जाइए, थोड़ा पीछे से आपका रिफ्लेक्शन आ रहा है कैमरे की.
Yeah, so it's visible, sir. Yes, and let's begin. Thank you.
Yes. Good afternoon to all. Today I am presenting the paper presentation on topic of effect of intracameral moxifloxacin 0.5% in phacoemulsification surgery. Phacoemulsification for cataract is a standard surgery in recent times with very good results and least complications. Cornea is an important part of eye. Our aim of this study to evaluate the effect of intracameral moxifloxacin on morphology and cell density of corneal endothelium in phacoemulsification surgery. Previously, it has also been reported that the betadine instillation in the conjunctival sac just 3 minutes before surgery decreases the microbial load comparable to the use of preoperative antibiotic drop. However, it has been shown that when the two methods combined, there is an additive effect in further decreasing the microbial load. Various drugs have been used for this purpose, latest being the use of intracameral moxifloxacin 0.5%. Moxifloxacin 0.5% ophthalmic solution is supplied as a sterile isotonic solution that makes it compatible with the intraocular tissues, and moxifloxacin also self-preserved that does not contain Belgian cholium chloride and any other preservative that are toxic effects on corneal epithelium. Overall, moxifloxacin is broad spectrum of antimicrobial action, ease of availability, and lack of preservative content make it a good candidate for intracameral use in prophylactic regimens. This study was undertaken to check for its safety in corneal endothelium and endothelial cell morphology into account. Objective of our study is to compare the change in morphology of cornea, endothelial cell count, hexagonality, coefficient of variation in cell area, central corneal thickness due to use of intracameral moxifloxacin 0.5% in phacoemulsification surgery. Study design is prospective observational study. Sample size calculated by using G-Power software. Study subjects were chosen as per the inclusion and exclusion criteria. Inclusion criteria: age group is 40 to 80 years, senile cataract patient between the grading 1 to 3 cataract according to LOCS 3 classification. Exclusion criteria: patient with any other ocular pathology like ARMD, diabetic retinopathy, and ocular conditions like glaucoma and uveitis, those with other media opacities, cornea or vitreous, subject with traumatic cataract, and any other previous intraocular surgery other than the cataract. Statistical analysis were calculated by into the Microsoft Excel, and statistical analysis were performed using the statistical software SPSS version 25.0. Student t-test was used for comparing the mean values between two groups, and p-value was considered to be significant when less than 0.05. Results of our study is the mean endothelial cell count preoperatively, postoperatively day 1, postoperatively day 7, and postoperatively day 21 was compared between case and control groups using the unpaired t-test. The significant difference, there was no significant difference in mean endothelial cell count preoperatively and postoperatively between day 1, 7, and 21. The mean endothelial cell count decreased from the 2,633 to the 2,587 among case group and 2,590 to 2,551 among control group. The mean hexagonality preoperatively and postoperatively day 1, day 7, and day 20 was compared between the case and control groups using the unpaired t-test, but there is no significant difference in mean hexagonality preoperatively and postoperatively. The mean hexagonality decreased from 43.47 to 38.44 among case group and 44.20 to 39.6 among control group. The mean coefficient of variation in cell area preoperatively and postoperatively was compared between case and control group, but using the unpaired t-test, but there was no significant difference in mean coefficient of variation in cell area preoperatively and postoperatively. The mean central corneal thickness preoperatively and postoperatively compared between the case and control group using the unpaired t-test, but there was no significant difference in between the central corneal thickness preoperatively and postoperatively day 1, day 7, day 21 between the case and control group. The mean central corneal thickness is changed from 545 to 530 among case group and 547 to 529 among control group. In the present scenario, the role of intracameral antibiotics remain controversial. The large-scale retrospective analysis point toward a significant beneficial trend of using intracameral antibiotics for endophthalmitis prophylaxis, which has led to the adoption for the routine and preferred practice for many surgeons and institutions worldwide. The commercial drug preparation for intracameral use may not be universally available and not approved by drug regulatory authorities. There is a risk of toxic adverse effects by the use of intracameral antibiotics itself. In addition, there are concerns about antibiotic resistance to their widespread usage. There is a debate regarding the cost effectiveness of routine intracameral antibiotic prophylaxis. However, in our view, the risk of developing a potential and sight-threatening disease such as endophthalmitis far outweighs the economic consideration to their routine antibiotic usage. Conclusion of our study is intracameral instillation of moxifloxacin 0.5% appears to be safe and effective method to prevent post-cataract endophthalmitis. It has no significant effect on corneal endothelium, non-toxic for corneal endothelium as it's in our study. In the absence of definitive evidence against the beneficial effect of intracameral antibiotics, they may be routinely administered as a prophylaxis post-cataract surgery. Thank you.
Well, thank you so much, Dr. Mohit, for finishing it exactly before the given time. Next, may I please invite Dr. Kapil Dev C for the presentation. May I please invite Dr. Kapil Dev C for the presentation? Seems like he is not over here. Next, may I please invite Dr. Priyanshi Priya for her presentation? Dr. Priyanshi?
Yes, sir.
Yes, please unmute yourself, switch on the camera, and can we start the screen sharing? Doctor, can you please start with screen sharing?
Yes, sir.
I'll open it now.
Yes, please,
Yes, sir.
switch it to the presentation mode. Perfect. The time begins now. Thank you.
Good afternoon, teachers. My topic for pre-paper presentation is an assessment of effectivity along with pre and post clinico-pathological correlation between clinical features, conjunctival impression cytology, and tear morphology in patients of Werner keratoconjunctivitis after cyclosporin A 0.05% therapy. Werner keratoconjunctivitis. One second. Werner keratoconjunctivitis is a recurrent bilateral inflammation of the conjunctiva that tends to occur in children and young adults with a history of atopy. The disease in its full-blown stage does not respond to currently prevailing anti-allergic treatment, even though potent steroid eye drops are proven to be the most effective treatment modality used so far, but their long-term use, especially in children, can cause serious side effects. The use of cyclosporin A 0.05% eye drop due to its apoptotic effect is thus encouraged in VKC. The major objectives of our study was to determine the effect on clinical features after administration of cyclosporin as assessed by sign and symptom scores, to assess ocular surface changes evaluated by impression cytology, to determine changes in tear morphology using Ferning test, and clinico-pathological correlation. The study included children aged 3 to 16 years diagnosed as VKC on the basis of specific history, sign, and symptoms, and excluded all existing forms of conjunctival, corneal, or ocular pathology, any history of ocular surgery, topical, systemic medications, pregnant lactating females, and poor compliance. A total of 56 patients were included and graded as mild, moderate, and severe. Topical cyclosporin with lubricant eye drops were given 4 times a day, with installation of short-term course of corticosteroid therapy if required in earliest tapering pattern. Follow-up was done at 2, 4, 8, and 12 weeks, and Ferning test and impression cytology was done at baseline and 12 weeks of treatment. This was our symptom score, which included itching, watering, discharge, discomfort, and photophobia. Each allotted a score of 1, with leading to a total score of 15. The sign scores included conjunctival hyperemia, palpebral limbal papillae, Horner-Trantas dots, keratopathy, corneal neovascularization, and leading to a total sign score of 18. Tear morphology was assessed by Ferning test. Here we gave a score of 1 to the grades 1 to 4, and we assessed normal arborizing patterns and spacing between the ferns. Ocular surface changes was assessed by impression cytology. And here we assessed the surface changes on the basis of 2 major criteria, that is the goblet cell density and signs of squamous metaplasia. Signs of squamous metaplasia included loss of cohesion, change in NC ratio, and presence of keratinization. Assessment of sign and symptom score over time was done, and maximum change was found to be at 12 weeks, and both the assessment was statistically significant. Likewise, a change in tear Ferning test and impression cytology scores were also done, and these were also statistically significant. Clinico-pathological correlation was assessed by comparing change in symptom sign score, change in Ferning scores, and change in impression cytology scores, and compared individually between all of these, and these were also found to be statistically significant. These were pre-CSA therapy pictures which improved at 12 weeks. The Ferning test on the left shows needle-like patterns with spacing in between the ferns, which improved post-therapy, showing normal arborizing patterns with decreased ferning. These were the impression cytology pictures showing loss of cohesion, decreased NC ratio, and squamous cells on the left, which improved with lesser loss of cohesion, goblet cell clustering, and mucous strands on the right. Statistically significant decline in the sign and symptom scores were observed, which were similar to studies done by Keklikci, Oslam, Chatterjee, and Subedi et al. Alteration in TM morphology with subsequent improvement with CSA therapy was observed. Nebioso et al. Demonstrated similar result in his study. Alteration in density of goblet cells and squamous metaplasia changes also returned towards normalcy with CSA therapy. Aragona, Thate, and Nebioso et al. Demonstrated similar results in their studies. Improvement in symptom and sign scores observed a positive correlation with change in TFT and CIC scores with CSA therapy. 2 patients reported of mild stinging. Thus, we can conclude when the disease is resistant to classical anti-allergic treatment, cyclosporin is a safe and effective therapy for relief in these cases. It is a comparable modality of long-term treatment both during and between attacks of disease. TFT and CIC can be used as markers for disease severity and monitoring of ocular surface changes, and clinical improvement is almost directly proportional to histopathological changes. Limitations of our study was small sample size and short study period. Thank you.
May I please invite Antravedi Tejaswini, Dr. Antravedi Tejaswini to begin with the presentation?
Yes, sir.
Hello, sir.
Yes.
Sir, I'm Kapil here. Sir, I was not able to share my slides, sir. Can I do next time, sir?
We'll take you after this.
Okay, fine.
Yes, sir.
Just a second.
Yes.
Sir, I'm unable to do that. Can you give me a chance for the next presentation?
Okay, no worries, doctor. Dr. Kapil Dev, I would request you to please start with the screen sharing. Dr. Kapil?
Yes, sir. Yes, sir.
Yes, sir. Sir, please turn on your camera.
Okay, sir. Wait.
Yes. Start with the screen sharing, and
yes, sir.
We can have a timer over there. Camera is again switched off.
सर कैमरा ऑन कर लीजिए और थोड़ा साइड हो जाइए, थोड़ा सेंटर में आ जाइए.
Yes, sir. Wait, sir.
Perfect, sir.
Sir, are you hearing me?
Yes, sir. Yes, doctor. It's perfect.
Okay, sir. Sir, can I start?
Yes, doctor. You can start.
Okay, sir. Thank you. Good afternoon, judges and my colleagues. Today, my topic for paper presentation is corneal morphological changes after phacoemulsification surgery in diabetics and non-diabetic cataract patients. So first of all, let's start with the introduction. As you all know, diabetes mellitus is one of the most common chronic and morbid diseases worldwide, with India being home to more than 62 million diabetic patients. Diabetic cornea is vulnerable to many abnormalities such as corneal epithelial damage, recurrent corneal erosions, persistent epithelial defects, impaired corneal sensitivity, and delay in wound repairing. Morphological changes in diabetic cornea include changes in endothelial cell density, changes in coefficient of variation, changes in percentage of external cells, and changes in central corneal thickness. So the aim and objective of my study was to measure and compare the changes taking place in the endothelial cell density, in the central corneal thickness, in the coefficient of variation and percentage of external cells following phacoemulsification surgery in diabetic and non-diabetic cataract patients. So as I said, we have got 2 groups here. My materials and methods includes a total of 50 patients divided into 28 diabetics and 22 non-diabetics. Patients were subjected to phacoemulsification surgery by a single surgeon, and we did the corneal morphological changes was measured with the help of a top cone microscope. And the measurements were done 1 day prior to surgery, which was considered to be the baseline value, and the other was measured at 1 week, 3 months, and 6 months after surgery. My inclusion criteria included patients diagnosed with diabetics. This can either be NPDR, PDR, or with no diabetic changes in the fundus, and having cataract belonging to 35 to 60 years of age. And the other group is patients who are diagnosed with cataract but not having any history of diabetics. My exclusion criteria included patients diagnosed with pterygium, endothelial dystrophies, keratitis, keratoconus, corneal opacity, history of previous ocular surgeries, contact lens wear, history of ocular trauma, and preoperative endothelial cell density less than 1,500 cells per millimeter square. Intraoperative complications like posterior capsule rupture and nuclear stroke were also contraindicated. Now, this is just an image showing the specular microscopic count done with the instrument in the department, showing central corneal thickness, the cell density, the coefficient of variation, and hexagonality. Now, coming to the results and observation, as I said, the group was divided into two, the one diabetic group, the other non-diabetic group, and the diabetic group constituted 56% and the non-diabetic group constituted 44%. Now, coming to this chart, you can see here the central corneal thickness being measured. The blue line is the diabetic one and the red one is the non-diabetic one. The preoperative value of both the groups was somewhat similar. If you come to the first week post-operative, the central corneal thickness of the diabetic patient was high, and this is found to be statistically significant. And by the third month, both the values were similar. Coming to the endothelial cell density, you can see the diabetic group, the pre-op and the pre-op in both the groups are similar, but the diabetic group, there's a progressive decline in the endothelial cell density. Now, coming to the non-diabetic group, even though there is a decline in the endothelial cell density, it is not that significant. Now, coming to the coefficient of variation, the pre-op value in both the groups are somewhat similar. And the diabetic group, if you see, there's a progressive increase in the coefficient of
Dr. Kapil, are you done with the presentation? Dr. Kapil?
Hello, sir.
Yes. I request Dr. Anchaudi Tejaswini to please take over.
Okay, sir.
Ma'am, you have two devices logged in. That is going to create an echo. So
Okay,
I would request you to please mute one of the devices.
Okay, sir.
Yeah. Thank you. AV team timer, please. Ma'am, please start screen sharing.
Sir, can you see the presentation, sir?
No, ma'am.
We're not able to see the presentation yet.
Ma'am, share कीजिए इसके screen share कीजिए.
I am sharing the screen, sir.
No, I'm not yet.
I have actually it's coming as you are screen sharing. Okay.
Could you stop screen sharing and then start screen sharing again?
Okay, sir.
Not yet, ma'am.
Sir, it is appear to me that it is coming as you are screen sharing, so that's why I'm confused right now.
AV team, Mr. Kumar.
मैम आप जूम पर साइड में देखिए ग्रीन बटन होगा उसको शेयर कीजिए.
हाँ सर, मैंने शेयर किया है सर. इट्स कमिंग एज यू आर स्क्रीन शेयरिंग.
Yes.
उसके बाद में ऑप्शन है स्टॉप स्क्रीन शेयरिंग, इसीलिए।
ठीक है मैम।
हाँ, आ गया मैम। Could you please start with the presentation?
Okay, sir.
Could you play the presentation so that would be better? Yes, thank you. Kumar
Okay,
sir, please timer दे दीजिए.
Good afternoon, everyone. My name is Dr. Tejaswini Antarvedi. Today, my topic for the free paper is titled "To compare the refractive error correction results obtained by objective refraction and subjective refraction." Coming on to the introduction, the prevalence of refractive errors in the general population has been extensively researched. But among the general population, identification and correlation and correction among the infants and children is very important to avoid amblyopia. To analyze the accuracy of non-cycloplegic and cycloplegic automated refraction, I've used Canon AutoRef as a means of objective refraction along with retinoscopy and with binocular subjective acceptance. The cycloplegia, in maintaining the accommodation to a relaxed state, it is essential because fluctuating accommodation may confuse the retinal focus and the retinal techniques for determination of the refraction error. Hence, accommodative passivity is achieved by using two methods like fogging and cycloplegia by using topical medication. In non-cycloplegic refraction, non-cycloplegic accommodative activity is best controlled by placing the focus of the distant fixation target in front of the retina, a technique known as fogging. In cycloplegic refraction, we achieve this by reducing or eliminating the normal tonic accommodation along with producing simultaneous pupillary dilatation. Coming on to the materials and methods, this is a hospital-based prospective study. The sample size was 500 patients of 1,000 eyes, and we have conducted the study of all the people attending the ophthalmology department. This is a study to compare the means and analyze the agreement between various techniques of subjective and objective refraction along with their final binocular acceptance. Inclusion criteria. Patients with written informed consent for the study. Patients with age group between 10 to 40 were included, both and female were included, right as well as left eye was included, and visual symptoms of blurring, diminution of vision, along with asthenopic symptoms, headaches, and normal unaided distant visual acuity, which is improving on pinhole, and abnormal aided distant visual acuity in the absence of non-refractive causes of reduced visual acuity, and patients who had previous refractive corrections. And exclusion criteria included media opacities, corneal abnormalities, lenticular opacities, any anterior or posterior segment pathologies, and diminution of vision due to non-refractive causes, and those allergic to cyclopentolate. A total of 1,000 eyes, as mentioned before, 502 eyes belonging to 251 females and 498 eyes belonging to 259 males were included. The mean age was around 22.8, range varying from 10 to 40, and each subject was explained all the details of the study in the language they best understood, and a written informed consent was taken. Non-cycloplegic autorefraction, after performing visual acuity measurement with the standard Snellen chart at 6 meters, the non-cycloplegic autorefraction was done with Canon, and 3 subsecutive results were taken for the each eye, and the average is recorded under the term NCA. In cycloplegic retinoscopy, it is performed by using Heine streak retinoscope, and after assessing the degree of emmetropia based on the refractive retinoscopic fundus reflex to achieve the fogging of both eyes, and the parameter is recorded under the term NCR. Cycloplegic refractometry, after using cyclopentolate 1% eye drops, 1 drop in each eye for 10 minutes interval up to 3 times, and after which AR measurement was taken after 1 hour duration, and the result was recorded under the term CA. In cycloplegic retinoscopy, after cycloplegia, Heine retinoscope was used as a standard means of protocol. However, an additional correction factor of 0.75 diopters was compensating for induced cycloplegia was subtracted from the cycloplegic retinoscopic endpoints. The recording was under the term CR, and the patient was reviewed again after 1 day for verification for the final binocular subjective acceptance, and appropriate refractive correction was prescribed. Coming on to the observation and result, this is the scatter plot showing the correlation between the best subjective acceptance for the NCA, NCR, CA, and CR under the terms for the right eye and the left eye respectively. The visual acuity is important, is related to the size of the circle of least confusion and its axial position relative to the outer limiting membrane of the retina. And the retinoscopic findings and the subjective refraction may not be the same, but are highly correlated. The cylinder component is more reliably determined by retinoscopy, but the spherical component is more satisfiedly acceptance by subjective refraction. Retinoscopy is thus complementary to subjective refraction. Coming to the conclusion, the result of a study confirmed that retinoscopy is more reliable than automatic refraction, giving it a better starting point for non-cycloplegic refraction. The result of a study also confirmed that cycloplegic retinoscopy is more reliable and compatible to the subjective acceptance in comparison to the cycloplegic autorefraction. Finally, the cycloplegic retinoscopy is found to be far superior to cycloplegic autorefractions, non-cycloplegic retinoscopy, and non-cycloplegic autorefraction. Thank you.
Thank you so much, Doctor. Next up, we have Dr. Jyoti Kumari. Dr. Jyoti Kumari, may I request you to please turn on your camera, unmute yourself, and then start screen sharing.
Good afternoon, sir. My screens are visible?
Yes, Doctor.
It's visible.
I request the AV team to start with the timer. Doctor, I request you to please, yes, perfect. Let's begin.
Good afternoon all. Today my topic is clinical profile and surgical outcomes in patient with monocular elevation deficit. So the MED is a unilateral condition. It shows limitation in the elevation of the affected eye from any position of the gaze, and there are normal reductions in all other gazes. It can be due to inferior rectus restriction leading to the limitation of elevation, or can be due to deficient innervation of the elevator muscles that are superior rectus or inferior oblique muscle, or it can be due to combination of both restriction and elevator deficit. So this condition can be congenital or acquired. The acquired causes of MED can be sarcoidosis, syphilis, midbrain tumors, thromboembolism, arthritis, trauma, or post-surgery. The presenting feature of patients include vertical misalignment, drooping of the eyelid, abnormal head posture, diplopia, or there can be decrease in vision. So the surgical procedures described in the literature for MED depend upon the FDT procedure. If FDT is positive, forced duction test for inferior rectus muscle is positive, then IR recession, inferior rectus muscle recession, is the first choice of management. And if it is negative, then NAP procedure is the management of choice. The other described procedure in literature are modification of NAP procedure, where half width of horizontal muscle is used to superimpose on the vertical superior rectus muscle. There can be augmented NAP procedure or modified Nisida procedure, in which vertical muscles are transposed on the horizontal muscles, or there can be contralateral superior rectus recession. The clinical profile of our patients with MED was, we had total 9 patients, male were 7 and female were 2. The mean age was was 20.5. The range was 8 years to 29 years. The acquired cause of MED was present in one of our patients, and all the rest were of congenital origin. The mean pre-op vertical deviation was 23.8 prism diopter. The range was between 20 prism diopter to 55 prism diopter. The horizontal deviation was noted in 3 of our patients out of 9 patients. Pseudotosis was present in 2 patients. 5 patients had combined ptosis, and 2 patients had true ptosis. Bells were checked in all the patients before surgery. It was poor in 1 patient. And FDT for IR muscle was positive in 5 of our patients and negative in 4 patients. The surgical procedure, first surgery in all the patients was IR recession, which was around 6 to 6.5 mm with conjunctival recession, except in 1 who was subjected to modified NAPS procedure. 3 patients after first surgery, 3 patients required second surgery. First was subjected to SR recession in fellow eye to avoid fixation durace. The 2 patients underwent NAPS procedure, and 2 patients needed ptosis surgery. Pseudotosis was corrected by IR recession alone. Surgical after first surgery, amount of correction was by IR recession was achieved around 20 to 25 prism diopter. 3 patients with residual hypertropia needed second surgery to achieve orthophoric status. Final mean post-op vertical deviation in all our patients was 1.8 prism diopter, with range from 0 prism diopter to 5 prism diopter. Post-operative horizontal deviation was within 4 prism diopter. Post-op follow-up period of all our patients was from 6 months to 2 years. This is the case 1, which has 6/18 vision in left eye. MED was 25 prism diopter. There was no horizontal deviation. Ptosis is present in the primary position, and Bell's phenomena was good. This FDT was slightly positive. LR recession was done with 6.5 mm with conjunctival recession. This is after left sling surgery. The ptosis improved. This is the case 2, which shows MED in the right eye with esotropia of 16 prism diopter. Also, patient has Marcus gun phenomena. Pseudotosis was present. Bell's phenomena was fair. FDT IR was restricted. 2-stage procedure was done. Right eye IR recession was done of 6.5 mm and left eye SR recession was done of 7.5 mm. This is the post-operative image showing the correction of hypertropia. In the case 3, MED was present in the primary position, 20 prism diopter. FDT, to note that FDT was negative, still we did IR recession and the patient was orthophoric after post-surgery. So this is the data showing pre-op assessment, post-op assessment and the surgery in all our 9 patients. In conclude, I would like to conclude that although our case series 9 patients with MED, 8 patients underwent trial of IR recession, irrespective of the FDT status. Patient with residual deviation of 25 prism diopter was subjected to SR resection of the same eye or SR recession of the fellow eye, and therefore done only when the residual deviation was more than 25 prism diopter. Thank you.
Thank you so much, doctor, for finishing it on time. Next up, may I please invite Dr. Swati?
Sir, hello, sir.
Yes.
Sir, Kapil here, sir. Sir, actually, sir, my presentation got stuck in between, sir. I mean, is there a need to present it again or is it fine? Like, I think it's till discussion it went, then it got stuck.
Yes, it was stuck.
Yes, sir.
Yes, I agree, but right now we need to complete the presentations which are remaining. And after that,
Okay,
if
sir.
we have time, then only we can allot you some time.
So only 2 slides were left, sir. I mean, it's up to you.
Yes, I agree, but sorry, doctor, we have to maintain the international
Okay,
standards
fine.
of this conference. So may
Fine,
I
sir.
please invite Dr. Swati Verma?
Yes,
Dr.
sir.
Swati Verma?
I am here. Yes, sir.
Please start your screen sharing.
Okay, sir. Sir, actually, I am not able to get it. Just 1 second.
It is exactly at the bottom of the screen where you have mute and stop video. Right next to it, participants. Yes, exactly. Please open the presentation that you have.
मैम इसको ना इसको मिनिमाइज कर दीजिए.
Minimize this window and then you
Zoom.
can,
Okay. Is my presentation visible, sir?
Yes,
Yes, ma'am.
please, doctor.
Okay.
I would request you to turn on the presentation mode and begin with it.
Okay.
Can you get the timer, please?
Okay. Good afternoon to all. I am here to present my study to analyze the incidence of corneal graft rejection and various donor and recipient factors responsible for it. First of all, introduction. Despite the continuous involvement of the new surgical techniques, penetrating keratoplasty remains to be the most common form of corneal transplantation. In this hospital-based study, we have analyzed the graft rejection rate and rejection-free graft survival rate in our center, and we have also determined the preoperative risk factors and postoperative patient factors leading to the poor visual outcome after penetrating keratoplasty. We have taken patients from January 2020 to January 21. During the COVID period, in our institution, 80 keratoplasties have been performed, and among them, 50 were males and 30 were females. Mean age of the patient was 36 years. Age group was 5 to 82 years. Preoperative diagnosis of the patients include the bullous keratopathy, keratoconus, corneal dystrophies and degenerations, corneal vascularization, fungal or the bacterial keratitis. Now, various analyzed preoperative factors of the for the penetrating keratoplasty include the presence of inflammation at the time of keratoplasty. It was present in around 63% of the eyes. History of previous graft was present in 17% of the eyes. Pseudophakia was there in 15%.
Dry eye symptoms of present in 19% of the patients. Corneal vascularization involving 3 or more quadrant was there in 46% of the patient. Atopic dermatitis was present in 10% population. Technical risk factors include the graft size, which was more than 8 millimeter in 19% of the eyes. Operating time was more than 90 minutes in 48% of the cases. Surgical procedure, donor eyes were extracted aseptically and maintained in preservation media. Transportation was performed within 24 hours in most cases. Donor button punched out of endothelial size and graft diameter was around 0.5 millimeter. Graft was sutured to the recipient corneas with 10-0 nylon and were placed at 3, 6, 9, and 12 o'clock with the 16 interrupted sutures. IOL was implanted and anterior vitrectomy was performed whenever necessary. Subconjunctival injection of DEXA and Genta was given at the end of the surgery. After operation, topical treatment was given, which include the topical eye drops of antibiotics, corticosteroids, cycloplegics, and IOP lowering agents. Oral prednisolone was given at a dose of 1 milligram per kg and tapered off over months. Patient was followed up on day 1, 2, 3, then at first week, 15 days, 1 month, and 3-month interval. At every visit, patient was subjected to slit lamp examination and best corrected visual acuity, IOP, and any other complications were taken. Graft rejection was determined clinically. There have been the endothelial rejection line and anterior segment inflammation, extent of corneal vascularization have been seen. As for meta-analysis, patients were divided into 8 groups with 10-year gap intervals. Incidence of graft failure in the first 3 months post-operative period was around 7.5%. That is 6 eyes, 4 eyes with the acute episode and 2 with the chronic episode. 1 eye regained clarity after topical and systemic steroid treatment. Post-operative injury and epithelial defect was present in 3 eyes and the dry eye symptoms were present in 16% of the cases. During further follow-up of the 18 months, graft rejection was found in 12 more eyes. That is, total 18 eyes experienced graft rejection. Post-operative infection and keratitis was present in 9 eyes, which was the most important cause in 75% of the cases. Large graft size was present in 1 eye, and the recurrence of the primary disease were found in 2 eyes. After 3 months, estimated graft survival rate was around 93%. And after 6 months, 89% grafts were without any rejection. Overall estimated rate of graft survival after 18 months was around 78%, while the rejection-free graft survival rate after 18 months was around 77%. Patient in age group of 45 years to 55 and 65 years experienced the highest rate of rejection. That is, there was a young patient experienced highest rejection. No association between the sex and the surgical technique was found. Highest survival rate was with eye with keratoconus. In this study, we found that the major risk factors were for the graft survival were present, which is consistent with the result of previous reports. Post-operative medication and management also exert a great influence on survival, but its doses, route, and the course was similar in all post-operative patients, so we did not analyze this factor. Atopic dermatitis and dry eye patient need special care. Thank you.
Thank you so much, doctor, for finishing it within time. Now, next up, may I please invite Dr. Abhishek Katiyar for the presentation. Dr. Abhishek, please turn on your camera, unmute yourself, and then we can begin with the screen sharing.
Sir, can you hear me?
Yes, doctor. Yeah, you are visible, but we aren't able to see you. I would request you to please switch on the camera and then also start with the screen sharing.
Sir, my camera is not starting.
No worries. Can we start with the screen sharing?
Yes, sir.
Yes, doctor.
Am I visible?
Yes, doctor, we are good to go. AV team,
Okay.
timer.
सर स्लाइड शो कर लीजिए.
Good afternoon, sir. I'm going to present my paper on the topic analysis of prevalence and course of diabetic retinopathy and other microvascular complications in diabetic patients. Hello.
Dr. Abhishek, your timer has started. Please
Okay,
make
sir.
sure.
Diabetes mellitus is a chronic metabolic disease characterized by an increased level of plasma glucose According to Diabetic Atlas, which is the latest one, 7th edition, the worldwide prevalence of diabetes is projected at 415 million, which will rise to 642 million in the next 25 years. In India, there are nearly 69.2 million people living with diabetes mellitus, and it is predicted that number crosses 123.5 million by 2040. Furthermore, globally, around 193 million diabetic mellitus stayed undiagnosed, affecting them to the development of numerous long-term complications of untreated chronic hyperglycemia. HbA1c had been currently recommended for the diagnosis of type 2 diabetic mellitus by leading diabetes organizations and by the World Health Organization. Keeping the HbA1c level less than 6.5% is crucial for decreasing the incidence of diabetes complications. The complications can be broadly classified into microvascular and macrovascular. I am discussing about the retinopathy, neuropathy, and nephropathy in this study. The microvascular complications are an important risk factor for developing disabilities. The pathogenesis is grossly due to hyperglycemia, which leads to free radical production and inflammation and increased altered vascular permeability, leading to tissue damage. Now, objective of this study was to study the impact of microvascular complications, including diabetic retinopathy, with the duration of diabetes. Material methods. This was an observational cross-sectional study considered on 100 diabetic patients who attended the OPD, and the study duration was 1 year. Variable used to assess were history and duration of type 2 diabetes mellitus, as well as hypertension, glycosylated hemoglobin, fasting blood sugar, dilated fundus examination, diabetic neuropathy symptom score for neuropathy, and urine analysis and kidney function test for nephropathy, and lipid profile. Observation and results. The majority of the patients were females, and the majority of the patients had one in overweight, and 41% of the patients were obese, according to the body mass index. 81% of the patients were on oral hypoglycemic agents, and 16% of the patients were on insulin. Now, discussing the retinopathy, among these 100 patients, there were 39 patients in whom diabetic retinopathy was present. According to the duration of diabetes, within 5 years of the history, in those patients in which the history was 5 years of diabetes, there was no patient in whom diabetic retinopathy was present. But in 10 years, diabetic retinopathy was present in 20% of the patients. In 20 years, the diabetic retinopathy was present in 53% of the patients. And within 30 years, the diabetic retinopathy was present among the 92% of the patients. Now, this graph shows that as the years increase, the incidence of the diabetic retinopathy increase. Now, among those who in whom the diabetic retinopathy was present, the most common form, according to the DRS staging, was mild retinopathy, which was 34%, and the least common were very severe. Now, coming to the macular edema, the macular edema was present in only 40% of the patients. None of the patients with macular edema had mild diabetic retinopathy. Most of the eyes with diabetic macular edema had moderate NPDR, followed by PDR, and followed by severe NPDR. This study showed the median duration of diabetes with CSME was 12 years, with minimum duration of 4 years of diagnosis of diabetes. Coming to the dyslipidemia, dyslipidemia was also studied in this study. That 72% of the patients had total cholesterol more than 200. 71% of the patients had triglycerides above 150, which is abnormal. 25% of the patients in this study had HDL less than 40 mg per dl, and 25% of the patients had LDL less than 25%, less than 40. Now, correlation of diabetic retinopathy staging and serum cholesterol. Most of the patients in whom the cholesterol was more than 200 were in moderate NPDR, and rest in the patients who had less than 200, the majority. Hello. Hello.
Well, doctor, the time is up. Thank you so much for the presentation. Next up, we are done with this session, as we have to start the next session on time. So for the next session, May I please invite Dr. Arvind Kumar Maurya. Each speaker would be given 2 minutes for presenting their topic. And I have a list which is being posted in the chat box. So we'll try to get this done in the same format. Dr. Arvind Kumar Maurya.
Yeah, I can hear you. Yeah.
Yes, doctor. We request you to please begin with the presentation. We have 2 minutes.
Okay.
AV team, timer for 2 minutes. Thank you.
Please don't start.
Hello, Mr. Punesh.
Yes. Yes, doctor.
Yeah, are the judges there? Please make sure that judges are there. Please announce their names so that then only you can start.
So also for the next session, I would like to invite our judges, Dr. Professor Harsh Bahadur, Dr. Manisha Gupta.
Yes, I am here.
Dr. Anand Vardhan, Dr. Nutan Jain.
Yeah, I am here, Dr. Nutan Jain.
And of course, our moderator, Dr. Vipul Arora.
Shall I start?
Sir, time 2 minutes lagana.
Yes, sir. We can start. Each presenter will be given 2 minutes.
So I will be speaking on a case of recurrent posterior scleritis because of pansinusitis leading to optic neuritis. And this is the world's first such case. These were the findings. So there was headache and she was prescribed oral steroids and the episode was recurrent and there was history of runny and blocked nose. So MRI brain was normal, OCT macula showed subretinal fluid.
Hello.
And this was the examination, the finger counting in the right eye and RAPD in the right eye. Fundus disc edema was there. So on the T scan, it was T sign. So this was thickness of retinochoroid sclera complex leading to T sign suggestive of subtenon fluid. And we did the other test. So there was hyperintensity in the intercanalicular region and it was pansinusitis. And C3 complement levels were raised and age were reduced. So it was not a case of VKH and no sarcoidosis. So she was started with IV methylprednisolone pulse therapy for 5 days and followed by mycophenolate, phenolate. So the best of our knowledge, no such case of unilateral recurrent posterior scleritis has been reported till now. So low level of serum ACE disfavors the possibility of sarcoidosis and absence of skin patches leads to that it was not a case of VKH. So after ruling out the possibilities of other differentials, a diagnosis of recurrent posterior scleritis due to pansinusitis leading to recurrent optic neuritis was made. And we started the methylprednisolone and the mycophenolate, phenolate therapy. Thank you.
Thank you so much, Dr. Arvind. Next up, may I please invite Dr. Bhushan Bhuttada to take over for the presentation.
Am I audible, sir?
Yes, doctor.
Just a second.
Please start screen sharing.
Yeah. Is my screen visible, sir?
Yes, sir. No, doctor, not yet.
Is it now?
No, doctor, we are not able to.
Sir, screen share कीजिए.
Is it visible, sir?
Yes. We can see it now. Please begin.
Good afternoon, everyone. Today I'm going to present the case of surgically induced necrotizing scleritis
slide
at
show कर
graft
लीजिए.
harvest site after pterygium excision with conjunctival limbal autograft. So as we all know, surgically induced necrotizing scleritis is a rare occurrence after ocular surgeries, mainly after cataract surgery, trabeculectomy, strabismus surgery, and surgery after retinal detachment, pterygium surgery. If not timely intervened, since can cause dreadful complications like uveitis, keratitis, keratolysis, glaucoma, and vision loss. In Indian context, few such studies have been documented, but none of the studies have been reported from graft harvest site. We report a case of SINS at a graft harvest site. A 40-year-old female presented with severe pain in the right eye, which was radiating to the ipsilateral jaw and temple 2 weeks following pterygium surgery in the right eye. The patient had undergone pterygium surgery with autograft without any use of adjunctive mitomycin C. Post-operatively, she was prescribed our routine medications. On post-operative day 7, slit lamp examination showed healthy in situ graft. 2 weeks post-operatively, she developed severe pain in the operated eye. At presentation, the sclera at the site of prior graft harvest showed significant melting and exposed juvenile tissue. There was active inflammation at the site of graft harvest. Investigation, we performed dilated fundus, B scan, C ANCA, P ANCA, rheumatoid factor, and chest X-ray, but it didn't show any significant results except the WBC and ESR were borderline increased. There was no history of any systemic and clinical illnesses. Management, we started the patient with 1 gram IBMP for 3 days, followed by topical prednisolone, and after that we started with the oral prednisolone treatment, and patient showed rapid improvement in the signs and symptoms after starting the treatment. After 3 days, patient was started on systemic oral steroid and tapering dose, following which the inflammation fully subsided. In this case, our patient presented with since 2 weeks after pterygium surgery, no irradiation, mitomycin C and cauterization was kept to minimal, and surgically induced necrotism.
Dr. Bhushan, so sorry to interrupt, but the time is up. Thank you so much for the presentation. Next up, we have Dr. Kalpana S. Ingle. Doctor, may I please request you to turn on the camera, unmute yourself, and start with the presentation.
Am I audible, sir?
Yes, doctor, you're audible. Please start with the screen sharing.
Okay, sir. 1 minute. Is my screen visible, sir?
Yes, doctor, you can start.
Today I am presenting a case to report a case of spontaneous vitreous hemorrhage and isolated ocular manifestation of thrombocytopenia. Idiopathic thrombocytopenia having antibodies against own platelet cause a peripheral destruction resulting in a low platelet count and occasionally bleeding complications. So patient can develop severe flares of anemia with resultant ocular manifestations, which can often be bilateral. However, ophthalmic involvement is exceptionally rare. Hemorrhagic ophthalmic manifestation associated with ITP include vitreous hemorrhage associated with intracranial bleeding. In a Tulson type phenomenon, hemorrhage within optic tract, non-arteritic anterior ischemic optic neuropathy, and subconjunctival hemorrhage. Thrombocytopenia alone, even severe, is rarely sufficient to cause significant retinal hemorrhage. A 55-year-old male presented with 20 days history of sudden painful loss of vision, redness, and swelling in right eye. He was being treated 20 days back for same with some sort of surgery and was started on anti-glaucoma medication and steroidal antibiotic eye drop. No documentation of surgery was present with patient. As the symptoms was not subsided with medication, patient presented to us after 20 days back. Patient had no history of hypertension, diabetes, or other systemic illness. The general and systemic examination was entirely normal, including no signs of liver failure. On ocular examination in right eye showed no perception of light, lid edema, conjunctival chemosis, and subconjunctival hemorrhage, corneal haze. Extraocular movement restricted in all directions. On right eye base scan suggestive of vitreous hemorrhage with subhyaloid hemorrhage, and the patient had history of similar complaint 4 years back. Right eye FFA done 4 years back suggestive of neovascularization of disc and neovascularization elsewhere. On investigation, the platelet count was 8,000 per cubic millimeter only. Other parameters were normal. In management, the patient was put on anti-glaucoma medication, antibiotic eye drop, and intravenous antibiotic, and under keen observation. Chronic thrombocytopenia was considered as a cause of right eye subconjunctival hemorrhage.
Yes, doctor, the time is up. Thank you so much for the presentation. Next up, may I please invite Dr. Priyanka Agarwal. Doctor, I request you to please turn on the camera, unmute yourself,
Sir,
and start screen sharing. Thank you, doctor.
Sir, am I audible?
Yes, doctor, you are audible, loud and clear.
Today I am going. Good afternoon, everyone. Today I am going to present a case report on central sinus retinopathy post-COVID vaccination. CSR is defined as spontaneous serous detachment of neosensory retina in macular region, common in 20 to 50 age group. It is mostly unilateral and with male predominance. Many ocular manifestation of COVID-19 has been reported, but to the best of our knowledge, very few intraocular side effects have been reported from COVID-19 vaccination. No case of CSR has been reported from from Covishield COVID-19 vaccination yet. We present a unique case of healthy male presenting with unilateral CSR related to COVID-19 Covishield vaccination immunization. It was a 35. He was a 35-year male presented with acute onset painless diminution of vision right eye. No other significant history. 2 days before this presentation, he was administered with Covishield COVID-19 vaccination. On ocular examination, the best corrected visual acuity was less than 20/200 in right eye, and left eye was normal. RAPD grade 1 was present in left eye, in right eye, and left eye was normal. On dilated fundus examination, he had loss of foveal reflex and swollen appearance of the macula in the right eye, and left eye was normal. On OCT, right eye showed macular detachment of neosensory retina with the CFT for 48 micrometer, but with left eye normal. Cardiac opinion was normal. Eye drops nebafenec was started, and patient was followed up for 1, 2, and 3 months later. At 3-month visit, he was found to have best corrected visual acuity of 20/40, and OCT showed resolution of subretinal fluid. These are the fundus photograph and OCT photograph. Vaccination discussion. Vaccinations have been the most effective method of prevention of infectious disease, but are found to have many side effects. We present a case of unilateral CSR post-Covishield vaccination. This is the first report of first case of CSR associated with COVID-19 Covishield vaccination. Same cases have been reported with other vaccination like Pfizer and Sinopharm. So we believe it is prudent to consider the immunization as potential contributor of CSR because of temporal association with immunization symptom onset. Low incidence of CSR and classical risk factors are absent in this case. CSR Covishield vaccination.
Sorry to interrupt, but the time is over. Thank you so much.
Thank you, sir. Thank you, sir.
Next up, may I please invite Dr. Bharat Gurnani, as they have another session to attend after 2 o'clock. Dr. Bharat. Yes, doctor. Please start screen sharing.
My screen is visible, sir. I'm audible, sir. My screen is visible.
Yes, doctor. Everything is perfect.
I'll be presenting innovative use of leap motion technology for cataract surgery simulation of wet-lab training model. Coming to introduction, cataract surgery simulation provides medically accurate simulation that benefit young resident trainees to learn and understand cataract surgery. These surgical simulator facilitate trainees interactive learning and real-time feedback. A simulation is a particular set of conditions created artificially in order to study or experience something that exists in reality. Leap Motion is a company in the US which manufactures and market innovative computer hardware and sensor devices that support finger and hand gesture movement and software designed for hand tracking in virtual reality. So coming to the concept, Leap Motion is a peripheral USB device that can be mounted on a computer or on a VR head box. It has 3 infrared LEDs and 2 monochromatic cameras. These cameras and LEDs capture images and then convert into a display unit on a digital desktop. So in our innovative attempt, before attempting hand-on simulation, a video clip and a gesture-based recognition environment is provided to the user so that it helps to understand the mechanics. Initially, the user hand gesture are captured by the USB Leap Motion device. The data is captured in terms of hand and finger movement, and the corresponding orientation coordinator are communicated to the host computer. The technique also implies a game development engine, Unity, which is a fully integrated set of intuitive tools and rapid workflow to create interactive 3D and 2D content. Every action performed by a surgeon has a specific outcome on the simulator. These actions can be captured as positive, negative, neutral with respect to the user and hand and finger. So these are the various steps shown how to simulate these cataract surgery steps. For this, this technique can be employed in future for phaco horizontal chop, Little's capsular access maneuver, 4-throw pupilloplasty, and capsular tension rig. So to conclude, novice surgeon can rapidly practice procedure using this interactive surgical simulator by using Leap Motion technology. Accurate and low-cost surgical simulator for clinical training. This is a very methodical, accurate and low-cost technology, and this can be taken to next level and more complex surgical procedures like cataract, cornea, retina, and strabismus surgery. Thank you, Vanana.
Thank you so much, doctor, for finishing it prior to the given time. Next up, may I please invite Dr. Kirandeep Kaur, as she also has another session to attend.
Thank you so much, sir, for considering the request. Is my slide visible, sir?
Yes, doctor, visible. Please start.
Good afternoon. I'll be presenting the topic hesitancy and motivational factors for COVID-19 vaccination among patients attending tertiary eye care hospital. The authors have no financial disclosure. So an effective vaccination will be one which protects the individual and slows down spread of disease by generating herd immunity. A similar effect in reduced morbidity was seen post-vaccination with COVID-19. So there are several factors which might hamper the vaccination drive. A survey in the United States revealed the vaccination hesitancy to be as high as 27%. It's important to understand the reasons for acceptance and hesitancy in an attempt to end this pandemic soon. So the study was done in a cross-sectional online questionnaire method in the month of June, wherein trained study coordinators contacted patients over their phones and filled in the questionnaire. Study was done at 6 tertiary eye care hospitals in South India. Patients more than 18 years of age were included in the study, and exclusion criteria was patients with no personal mobile phone, hearing problem, presenting with emergency conditions, or systemically unwell. So we noted an improved acceptance of vaccination with the increasing age. Acceptance was better among males as compared to females, and it was better among the higher income groups. Similarly, we noted a better acceptance of vaccination with more educated patients, and it was better for patients presenting from urban areas. The most important hesitancy factor noted in our study was fear of side effects post-vaccination. So similar results have been proven in studies from Israel and Portugal. The most important motivational factor was fear of getting infected or infecting the family members. Similar results have been reported from study in United States. So we found that lower vaccination was associated with lower age groups, female gender, rural residents, lower income, and lower educational groups. The strength of our study include a larger sample size, multicentric nature, and we believe eye care patients represent the general population. To conclude, creating awareness about minor side effects and giving reassurances can allay the patient fear. We need to utilize the fear of contracting disease in third wave to drive the vaccination campaign. Particularly women, lower socioeconomic group, lower education, and rural areas need to be concentrated on. Thank you.
Thank you so much, doctor, for finishing it on exactly on time. Next up, we have Dr. Sanjini Sahai. Doctor, may I please request you to unmute yourself, turn on the camera, and then start screen sharing. Dr. Sanjini Sahai. Dr. Sanjini. Oh, she's not here. So we can call upon Dr. Pankaj Kumar Maurya. Dr. Pankaj Kumar Maurya, please unmute yourself, turn on the camera, and start screen sharing.
Yes, sir.
Yes, doctor. So
myself, Dr.
Screen sharing. Doctor, we are not able to.
Yes, sir. Yes, sir. Yes.
Share, screen share.
Sir, is it visible?
Yes, doctor. Please begin.
Sir, is it visible?
Yes, doctor. Visible, and you are also audible. Please begin.
Okay, thank you, sir. Myself, Dr. Pankaj Kumar Maurya. My title is a role of FNAC and histopathological examination to differentiate chalazion and sebaceous cell carcinoma. Purpose of study to differentiate between the recurrent chalazion and sebaceous cell carcinoma by histopathology, even in young age group patients. Introduction is chalazion is a localized chronic granulomatous inflammation, particularly affecting the mammalian glands of the eyelid. It is usually arise secondary to non-infectious obstruction of the sebaceous gland. It is always important to remember that few malignant conditions such as sebaceous cell carcinoma have already been reported masquerading as chalazion. Case history. A 32-year-old woman presented us with a well-defined non-tender swelling of the right upper lid of 5 months. She had a history of similar swelling 1 year back, and after a minor surgery, elsewhere it was resolved. Method. FNAC from the nodule was done as a screening test, and FNAC suggested as chalazion. And further, the plan of management was incision and curettage. However, during the procedure, the whole mass could not be adequately scooped out, so whole nodule was inside and sent for histopathological, which shows sebaceous cell carcinoma. These are the images of the patient, and it's a FNAC report, and it's a post-op image with a histopathological report. Result, we present the case of 32-year woman with presentation of recurrent lesion. The FNAC was done, and it suggests lesion, and further histopathological examination showed it's sebaceous cell carcinoma. Hence, the need of histopathological examination in every such case cannot be undermined. Conclusion: further investigation and histopathological examination is a must in case of younger age group with recurrent lesions. Hence, it is wiser to send a biopsy for a histopathological examination, even in benign lesion taking into account. These are the references. Thank you.
Thank you so much, Doctor. Next, may I please invite Dr. Mehak Raheja?
Hello.
Yes, please turn on the camera,
Yes,
unmute
sir.
yourself, and start with screen sharing.
Yes, sir.
After Dr. Mehak, we'll be having Dr. Garima Tiwari.
Hello.
Yes, doctor, please begin.
Yeah, is the screen visible?
Yes, doctor.
Okay. Good afternoon, everyone. I'm Dr. Mehak Raheja from HIMS, and I'll be presenting a poster on the primary congenital glaucoma, our surgical experience. As we all know, primary congenital glaucoma refers to an isolated maldevelopment of trabecular meshwork, and the patient presents with a triad of epiphora, blepharospasm, and photophobia. This is a retrospective review of patients with primary congenital glaucoma who presented to our OPD in 1 year and underwent surgery for the same. The protocol which was followed for all the patients was consent followed by history, examination, and the surgery, and the regular follow-up was done for the patients. Then talking about what we observed was there were 5 patients in the study and 8 eyes. And in this, we had the age of presentation of 1 patient as 8 months, 2 patients were 1 year of age, and the remaining 2 were 4 years of age. And out of these 5 patients, 4 were males and 1 was a female. And 3 patients had a bilateral involvement and 2 patients had a unilateral involvement. 1 patient had the history of consanguineous marriage, and the most common symptom which was present was watering, followed by increased size of the eyeball. Then 2 patients had a right eye involvement, and the IOP ranged from 20 mm Hg to 38 mm Hg. The corneal diameter was horizontal was 12 to 14 mm and vertical was 11 to 13.5 mm. On anterior segment evaluation, 1 patient had corneal edema, the rest of them had HADS dry. In fundus, the CD ratio ranged from 0.3:1 to 0.9:1. In axial length, it was increased for all the patients, and the range was from 23.60 to 27.18, and the retinoscopy was done for all the patients. In this, we can see the first patient, there's an increased corneal diameter, large eyes are present along with watering. And in the second picture, we can see the HADS triad present. And in the third picture, we can see the corneal diameter being measured preoperatively. Now, these are the surgical steps of combined trabeculotomy with trabeculectomy. And in our study, 1 eye underwent trabeculectomy, 7 eyes underwent combined trabeculectomy with trabeculotomy, and 2 eyes underwent surgical intervention. 1 after 1 month underwent bleb needling, and 1 underwent retrabeculectomy after 3 months. And talking about the discussion, the number of patients in our study are less as compared to previously.
Doctor, the time is up. Thank you so much. Next up, may I please invite Dr. Garima Tiwari?
Sir, am I audible?
Yes, doctor, you're audible. Doctor, please start with screen sharing. Yes.
Sir, is it visible?
Yes, doctor.
Good afternoon, everyone.
We'll be having Dr. Mitali Khurana.
Okay, good afternoon, everyone. Our topic is outcome of immediate management in acute chemical ocular burn. So we know it is one of the most challenging ocular emergencies to manage. It has a lot of complications like limbal stem cell deficiency, persistent epithelial defects, and a lot more. The prognosis depends on the severity of the original injury and the rapidity and the mode of treatment. In my study, we analyzed 29 eyes of 19 patients. Emergency first aid was given, a detailed ophthalmic examination was done, and a follow-up was maintained for 6 months. In this picture, we can see the right eye with grade 2 ocular chemical surface 1 and left the other eye with grade 2 ocular injury as well. In this picture, we can see a bilateral alkaline ocular injury with right eye grade 2 and left eye grade 3. Here also it is a unilateral alkaline injury. In this picture, we can see that it is a grade 4 injury and amniotic membrane was covered for the whole surface from lid margin to lid margin.
discussion, a higher percentage of alkali injury was seen specifically in males, and it was compared to other studies, it was similar. Most of the injuries were mild to moderate in my study, hence swift management in copious irrigation and topical eye drops gave a very good visual outcome. 13.6% eyes suffered complications like symblepharon and limbal stem cell deficiency, for which symblepharon release was done and SLET was performed. And simple SLET was performed in 6.8% eyes with a symptomatic relief and an increase in the visual outcome. So fortunately, most of the ocular injuries that we see were minor, and prompt and brisk continuous irrigation of the ocular surface and subsequent intensive treatment improved the symptoms. And segregation of cases requiring medical or surgical management was wisely undertaken. Thus, it is very important to identify any sequelae in severe burns, and a four-tone plan approach is advised. These are the references. Thank you so much for giving me the opportunity to present my poster. Thank you so much.
Thank you so much, Doctor, for finishing it within time. Next up, may I please invite Dr. Mithali Khurana. Dr. Mithali, please turn on the camera, unmute yourself, and then start screen sharing.
Good afternoon, everyone. Am I audible?
Yes, Doctor, you're audible.
Is my presentation visible? Good afternoon, everyone. I'm presenting a case of bilateral lateral rectus palsy as a ophthalmic presentation in pituitary macroadenoma. The patient presented with the chief complaints of sudden onset binocular diplopia in lateral gaze 6 to 2 weeks and chronic headache for 2 years, and with change in facial features in form of enlargement of nose and hands and thickening in his lips for 2 years. The patient presented with these complaints with the sudden onset diplopia in the lateral gaze 6 to 2 weeks associated with chronic headache since 2 years. He also noted enlargement of nose and hands with the thickening of his lips since 2 years. There's a history of tingling sensation in the fingers and the history of irrelevant talking for the past 2 days, which was noticed by his wife, and there was a history of snoring. There's no history of any similar complaints or galactoria, trauma, taking of eyelids, protrusion of eyelids, any ocular surgery, any systemic illness, blurring of vision, anti-tubercular treatment, excessive sweating, weight loss, weight gain, cold intolerance, any postal dizziness. On examination, the visual acuity in the right eye was 6/6 and in the left eye it was 6/9 parts, and acceptance was minus 0.75 diopter square. The pupil was normal. Extraocular movements were restricted in lateral gaze in the both eyes. Adnex and anterior segment was normal, and IOP was also normal, and visual fields were also normal. On Hirschsprung test, there was 15 degree esotropia present in left eye. On cover and cover test, there was alternate convergence squint, which was changed to left convergence squint. On diplopia chart, there was a horizontal diplopia which was increased, and on the fundus we see both eye papillaries of his hands. This is the MRI picture which is showing a heterogeneous enhanced lesion in the cellular tussicle, which was averting the cavernous sinus. This is the color fundus photograph, and the systematic examination was revealing hypogonadism, hypothyroidism, features. And the result was bilateral rectus palsy and patient got operated and its symptoms improved. And the conclusion is diplopia can be a first and unusual ophthalmic presentation in a case of pituitary macroadenoma. Thank you.
Thank you so much, Doctor. Next up, may I please invite Dr. Akarshi Jaiswal. Dr. Akarshi Jaiswal, please turn on your camera, unmute yourself,
Yes,
and
sir.
start with screen sharing.
Yes, sir. So am I audible?
Yes, Doctor, you're audible. Also, we can see the screen share. Please start with the presentation.
Okay. Good morning, everyone. Good morning, everyone. I'll be presenting my poster on study of macular thickness by OCT in uncomplicated phacoemulsification surgery. Introduction. Cataract is the leading cause of blindness and low vision worldwide, and phacoemulsification is the most commonly used method for cataract surgery. OCT is an important non-invasive imaging modality for measuring the macular thickness after cataract surgery. So the aim of the study was to evaluate the pre- and post-operative changes in the macular thickness by OCT in uncomplicated phacoemulsification surgery. The study was conducted over a period of 12 months, and it was an observational type of study in which 70 eyes were studied.
The inclusion criteria included patients above 40 years undergoing cataract surgery, and the exclusion criteria included history of any retinal pathology, history of any previous intraocular surgery or trauma, or any intraoperative complication affecting the macular thickness. So a detailed ocular and systemic history was taken, followed by visual acuity assessment and slit lamp examination. Then macular thickness was measured, followed by phacoemulsification, which was again followed by macular thickness measurement by OCT. It was done by Fourier domain OCT using EMM5 protocol. In the results, it was seen that the mean age was 59.82 and maximum number of patients were in the range of 51 to 60 years. It was seen that post-operatively, the macular thickness increased as compared to the pre-operative values. And this macular thickness was significant. The increase was significant in post-operative month 1, and the values further decreased after post-operative month 3. So the conclusion of this study was that statistically significant increase was seen in the macular thickness after 1 month of phacoemulsification surgery, and the macular thickness decreased to preoperative baseline values at 3 months of surgery. Thank you.
Thank you so much, Doctor, for finishing it exactly within time. Next up, may I please invite Dr. Shravanti. Dr. Shravanti Bhimavarapu.
Sir, am I audible?
Doctor, yes, you are audible, but the audio is very low. Volume is very low. I request you to please speak a bit louder and start with the screen sharing.
Sir, shall I share the screen, sir?
Yes, doctor. Yes, doctor.
Good afternoon. The topic is a case of Stargardt's disease in an 11-year-old female. Introduction: macular dystrophy is referred to a group of conditions that are heritable.
Ma'am, screen share नहीं हुआ अभी.
Screen share
involve visible changes in macula and mostly symmetrical. Stargardt's disease, it is most common. Prevalence 1 in 10,000 births, and also it is called as fundus flavimaculans. Mutation in ABCA4 gene. It is characteristic of accumulation of liposuction within the RPE. Presentation is typically in childhood or adolescence. Gradual impairment of the central vision, color vision, and dark adaptation. My materials are visual acuity assessment using Snellen's chart, color vision with Ishihara chart, slit lamp biomicroscopy, fundus evaluation, indirect ophthalmoscopy, and Humphrey visual field testing. Case report is 11-year-old female presented to our OPD with chief complaints of diminution of vision in both eyes since 1 year. She was apparently asymptomatic 1 year back and developed diminution of vision in both eyes. Insidious onset, gradually progressive, not associated with pain. She was born to second-degree consanguineous marriage parents. Systemic examination is normal. Ocular examination, bilateral anterior segment is normal. BCVA is 6/36. Intraocular pressure is normal in both eyes, that is 13 mmHg and 15 mmHg respectively. Posterior segments, the media is clear in both eyes and optic disc is pink in color and oval in shape with well-defined margins with CDR of 3.3:1 in both eyes. With blood vessels, AV ratio is maintained. Coming to the macula, in right eye, a well-defined circumscribed lesion of size more than 1 disc diopter with well-defined hyperpigmentation margin is present, whereas in left eye, well-defined circumscribed lesion with hyperpigmentation in the center, flex with the giving the appearance of the beaten rouge appearance. This is how the fundus on fundus picture it is seen as a beaten rouge appearance. On conclusion, my provisional diagnosis is bilateral macular dystrophy. Coming to the differential diagnosis, it is Stargardt's disease. Other DDs are cone dystrophy, macular hole. Coming to the treatment for the Stargardt's disease, counseling the patients, giving prescribing dark glasses and avoid vitamin A supplementation. And we can give isotretinoin to reduce the accumulation of A to E, and gene therapy, that is vector supplementation of ABCA4 gene, and RPE transplantation using the embryonal cell derived stem cells. Thank you.
Thank you so much, doctor, for finishing it on time. We weren't able to see the presentation, but we appreciate the spirit that you did it. Next up, may I please invite Dr. Arnab Kumar Garai for the presentation. Doctor, may I request you to please switch on the, turn on the camera, unmute yourself, and then start with screen sharing. Dr. Arnab Kumar. I think he's not over here. So next up, may I please invite Dr. Radha Mathur? Okay, he's here. He's here. Doctor, we are not able to hear you yet.
Voice is not audible.
Now it's audible. I would request you to speak a bit louder. Yeah, please start with the screen sharing.
Next कर लेते हैं.
Please start with the screen sharing. Sorry, doctor, we would have to invite you afterwards because there's a specific time which is running out. Next up, may I please invite Dr. Radha Mathur?
Yes, sir.
Yes, doctor, please start with screen sharing and turn on the camera and unmute yourself. Yes, doctor.
Sir, am I audible?
Yes, doctor.
Yes, sir.
Yes,
Good afternoon, everyone. I will be presenting a case of COVID-19 induced unilateral optic neuritis. As we know, the coronavirus has taken over the world since December 2019, causing severe respiratory damage. Ocular manifestations of COVID-19 range from mild conjunctivitis to severe optic neuropathies. Here we have aimed to report a case manifested with optic neuritis post-COVID-19 infection. A 25-year-old female homemaker by profession and a resident of Moradabad presented to us with gradually progressive painful diminution of vision in left eye since 8 to 10 days. The patient had a history of fever around 1 month back, for which she underwent RT-PCR testing and was tested positive for COVID-19 infection. The patient underwent appropriate treatment for the same, but complained of diminution of vision in the left eye 2 to 3 weeks after her diagnosis. General systemic examination revealed no abnormality, and it was followed by ocular examination, which revealed the unaided visual acuity of right eye, that is 6/6, and left eye 660. Color vision was normal. Anterior segment revealed RAPD in the left eye. Posterior segment evaluation showed mild blurring of nasal margin of the optic disc with mild elevation and hyperemia of the disc in the left eye. The right eye was normal. Visual field analysis showed a loss of inferior visual field in the left eye with right eye normal. A non-contrast MRI of brain and orbit was done but did not reveal any abnormality. So our patient with unilateral painful diminution of vision with RAPD and nasal blurring of the optic disc with disc elevation and hyperemia, along with inferior visual field loss, was diagnosed as a COVID-19 induced unilateral optic neuritis. The patient was started on intravenous methylprednisolone of 1 gram for 3 days, which was followed by oral prednisolone with a dose of 1 milligram per kg and was then tapered. To conclude, I would like to say that any patient presenting with a history of high fever or a history of COVID-19 infection should undergo a detailed systemic as well as ocular examination. Thank you.
Thank you so much, doctor, for finishing it on time. Next up, may I please invite Dr. Fiza Ahmed. Dr. Fiza Ahmed.
Yes, sir. Am I audible?
Yes, doctor. Doctor, may I please request you to start with screen sharing?
Yes, sir.
Yes, doctor.
Good afternoon, everyone. Today I will be presenting a poster on bilateral double-headed pterygia in a female patient with limited sun exposure.
Double-headed pterygia are a rare benign fibrovascular overgrowths of the nasal and temporal bulbal conjunctiva onto the cornea. The causes include ultraviolet B radiations, wind, dust, chemicals, air pollution, and hereditary factors. Ultraviolet B light is identified as the most important risk factor, which induces the expression of cytokines and growth factors in pterygial epithelial cells, and it is known to occur more commonly in males. We present a case of a 40-year female who presented to our OPD, who was a housewife, and she presented with the complaints of diminution of vision in both her eyes for the past 5 years. She usually stayed indoor, was a non-smoker, and there was no previous history of any eye surgeries in the patient, and the family history was not significant. The visual status, the best corrected visual acuity in both the eyes was 6.9 with the correction of plus 1.25 diopter spherical. Non-contact urimetry revealed an intraocular pressure of 40 millimeters of mercury in both the eyes, and Shermer's reading was 80 millimeters in the right eye and 20 millimeters in the left eye after 5 minutes, which was normal. On examination in the right eye, and on the nasal side, there was a grade 2 nasal pterygia seen. It was between the limbus and the pupillary margin, and grade 1 pterygia was seen in the temporal side of the right eye and in both the nasal and temporal sides of the left eye. Discussion, cosmetic disfigurement was not an issue in our patient, and there was no symptoms of irritation, dryness, or visually significant astigmatism. So she was prescribed glasses and lubricating eye drops, and follow-up was asked to check for the encroachment of the visual axis by the pterygia. Conclusion, pterygia, especially double-headed pterygia, is usually seen in warm climates and in individuals who work indoors and in males, but our patient was a female who usually stayed indoors and presented with this complaint. Thank you.
Thank you so much, doctor, for finishing it on time. Next up, may I please invite Dr. Ashna Agarwal. Dr. Ashna.
Good morning, sir. I'll just be sharing the screen.
Yes, doctor. Please.
Yeah, I hope it is visible, sir.
Oh, yeah.
I hope it is visible. Hello? Hello?
Not able to see the screen share, doctor.
Is it visible now?
Nope.
Just a minute, sir.
Yes, doctor, we are able to see it now. Please begin with the presentation.
Good afternoon, all. I'll be presenting my e-poster on the topic. Basically, I did a study to assess the psychological impact of COVID-19 pandemic on ophthalmologists, and my study sample were in training ophthalmologists and in practice ophthalmologists in North India during the lockdown period. Now, COVID was an unmarked territory for everybody, and especially for us ophthalmologists. So the main aim of the study was designed to see how the psychological impact was on the ophthalmologists. Now, it was done as an online survey, which is approved by the Institutional Ethics Committee through Google Forms. 150 ophthalmologists in training and in practice were enrolled, and basic demographic data, professional status, marital status, COVID-19 impact on practice, on income, their ability to meet expenses was assessed by a patient health questionnaire, PHQ-9, which basically assesses level and stages of depression. As per our observation, a total of 150 responders were seen, out of which 89 were males and the rest were females. Majority of the responders belong to an age group of 25 to 35 years, followed by 36 to 45 years, 30%, and more than 45 years were only 22%. As per our observation, now there were two basic things that we saw: the type of practice. As a PG, as an in-practice, in training ophthalmologist, most of the PGs are worried about their training because the psychological impact was basically related to not able to see enough clinical patients, and the clinical exposure was very, very limited. So in about a total of 35, most of them were worried about their training during the pandemic. In terms of financial status, 34% of them accepted that it is a difficult time for them to meet their daily expenses, while 26% said that they can barely meet their expenses amidst the pandemic. So the mean PHQ-9 score amongst the residents was 3.16, and majority of the postgraduates were worried about their training. As I said, the mean PHQ-9 score was 3.16.
We found a strong correlation of socio-demographic details with the people with depression versus people
Doctor,
without depression.
Can I request you to stop as the timer is up? Next up, may I please invite Dr. Rajdeep Kaur. Dr. Rajdeep, may I please request you to turn on the camera, unmute yourself, and then start with screen sharing. Do we have Rajdeep Kaur over here? Dr. Rajdeep Kaur? Yes, doctor. Let's begin. Yes, doctor. Start with the presentation.
Good afternoon, everyone. The topic of my case presentation is pediatric ocular myasthenia gravis. As we all know, myasthenia is an autoimmune post-synaptic neuromuscular transmission disorder that manifests as fatigable weakness, and ocular myasthenia gravis presents with weakness of extraocular muscles. It can be divided into neonatal, congenital, juvenile forms. Congenital is associated with defective signal transmission at neuromuscular junction since birth, whereas juvenile is caused by production of autoantibodies against the postsynaptic membrane. Neonatal occurs due to transplacental transfer of antibodies from a myasthenic mother. Here we have a 13-year-old male who presented with OPD with complaints of diplopia, drooping of both the eyelids, and restriction of ocular movement since 4 months. Patient gave history of fever 4 months back, which was sudden onset high grade associated with chills. COVID test came negative. After fever, patient developed diplopia and drooping of both the upper lids, which was progressive, associated with complete restriction of ocular movements in the right eye. The symptoms worsen in worsen till the night. Patient gave history of weakness of lower limbs on exertion as well. Family history and birth history was not significant. On examination, visual acuity was 6/6 partial in both eyes. Chin was lifted upwards. There was excessive forehead wrinkling, restriction of extraocular movements in all the gazes in right eye and present in left eye. Palpable fissure height was decreased. MRD was 3 mm right eye, 4 mm left eye. Pupil was normal. Slit lamp examination revealed severe bilateral ptosis in both eyes. Fundus was normal. This as a photo of ice pack test before and after. As we can see, significant improvement in the second picture. Fatigability test after there was worsening of the symptoms, and sleep test after picture reveal as if there was no abnormality present. There was normal study on contrast MRI orbit. Other investigations were done in which, to be specific, acetylcholine receptor antibodies were normal, but hydrophonium test was positive. The patient was not managed.
Doctor, the time is up.
Was
Thank you so much. Next up, may I please invite Dr. Puneet Devi. Dr.
Yes,
Puneet,
sir.
I request you to please turn on your camera, unmute yourself, and start with screen sharing. Dr. Puneet?
Yes, sir. Am I audible?
Yes. Yes, doctor. Please begin.
Good afternoon, everyone. I would be presenting a rare association of Sturge-Weber syndrome with neurofibromatosis type 1. Sturge-Weber syndrome is included in group of phacomatoses. It is characterized by facial portwine stain with choroidal hemangiomas, and the most frequent ocular comorbidity is glaucoma. Sturge-Weber neurofibromatosis, on other hand, is multisystem disorder with tumor predisposition syndrome. It is associated with characteristic ocular manifestations such as optic pathway gliomas, lesion nodules. Thus, ophthalmologist plays a significant role in diagnosis and treatment of NF1 patients. My case was a 50 years old female which came to the ophthalmology OPD with chief complaint of gradual paleness, progressive blurring of vision in both eyes. On journal examination, portwine stain on right side of the forehead and right upper eyelid, sparing conjunctiva was seen. Axillary and inguinal region showed freckling on both sides. There was two neurofibromas was present, one at back of the left mid thigh and second at the forehead over portwine stain, which she got removed at the age of 15 years. One caphule macule more than 15 mm was present at the lower back. Polysyndactyly of left toes was present. On ocular examination, her intraocular pressure was 17.3 millimeter of mercury. On slit lamp examination, iris showed lesion nodules and with nuclear sclerosis grade 2. Fundus and MRI showed no abnormal findings. This was a diagnostic criteria which we used for neurofibromatosis type 1,
and for Sturge-Weber syndrome. According to the diagnostic criteria proposed, patient fulfills the criteria for both NF1 and Sturge-Weber type 2. In the presence of Sturge-Weber syndrome, possibility of existence of other neurocutaneous syndrome should be considered, and thorough examination should be done as it helps in management, explaining prognosis, and for genetic counseling. Thank you.
Thank you so much, doctor, for finishing it exactly within time. Next up, may I please invite Dr. Munish Dhawan. Dr. Munish Dhawan, I request you to please turn on your camera, unmute yourself, and then start with screen sharing. Dr. Munish, do we have you over here? Okay, moving ahead, we have Dr. Ashika Luthra.
Yes, sir.
Yeah. Dr. Anshika, please turn on your camera, unmute yourself, start with screen sharing. Thank you.
Thank you, sir. Okay, good afternoon, everyone. I'm presenting a case on the vacillating course of tubercular serpaginoid choroiditis. So the patient was an 18-year-old male who presented with chief complaints of gradual progressive diminution of vision in left eye for the past 6 months, right eye for the past 2 weeks, along with the scotoma in the right eye for 2 weeks. His uncorrected visual acuity was 6/9 and 6/12 in both eyes. Our intraocular pressure was within normal limits. There was no past history, ocular or systemic, that was of significance. In the vitreous, we could appreciate 2+ and 3+ cells respectively in the right and left eye. There was vitreous haze. The disc was largely within normal limits. AV ratio was also within normal limits. In the right eye, we could see classic hypopigmented lesions, fluffy subretinal peripapillary lesions with ambiguous margins, and there were also some lesions present in the inferotemporal quadrant. There was cuffing of peripheral retinal vessels suggestive of vasculitis. In the left eye, we see multiple lesions in various stages of activity and healing. Central grayish-white pigmented lesions with well-defined irregular margins suggestive of healed chorioretinal scars with adjacent creamy placoid subretinal lesions showing activity at the periphery. On FFA, we observed a stipple pattern with predominant hyperautofluorescent lesions showing sharp and fuzzy borders representing healing and healed lesions respectively. Montauk's test was positive with an induration of 2.5 into 2.5 centimeters, and quantiferon TB gold was also positive. This helped us in establishing a final diagnosis of active tubercular multifocal serpaginoid choroiditis in the right eye with retinal vasculitis, and in the left eye, an acute and chronic picture of the same. Patient was started on oral steroids, topical NSAIDs, and referred to pulmonologist to start appropriate ATT. At 1 month, we can see the vision improve to 6/6 part and 6/9. In the right eye, we can see superficial retinal hemorrhages with venous cuffing suggestive of an inflammatory BRVO. In the left eye, we appreciate progression of active lesions towards healing as they evolved into grayish lesions with irregular, well-defined margins. At 2 months, we can see that the BRVO is resolving with superficial hemorrhages encroaching the fovea and cotton wool spots over the inferior arcade here. And both eyes showed expansive grayish-white pigmented lesions and scarring indicating healed choroiditis. In conclusion, it's an uncommon recurring inflammatory disorder characterized by serpiginous or geographic pattern, and tuberculosis, sarcoidosis, syphilis should be considered. Thank you.
Next up, may I please invite Dr. Ruchika Patnaik. Dr.
Good
Ruchika
afternoon.
Patnaik.
Yes.
Yes.
Good afternoon, everyone.
Good afternoon, Dr. Ruchika. Let's begin with the screen sharing.
Okay. Good afternoon, everyone. This is the case of a 33-year-old female who presented for refractive surgery. There was no significant past ocular or systemic history in this patient. Her corneal topography was within normal limits. There were no red flags, and her pachymetry was also more than 500 microns. OCT of the cornea was also pristine, and the epithelial thickness in both the eyes was around 55 microns on an average, and her refractive error in both the eyes was around 2.5 diopters. So based on this, a femtoLASIK was planned. Everything went smoothly. Laser ablation also went off fine, but during flap repositioning, sloughing of the epithelium was noted in both the eyes. So I placed a bandage contact lens on table. Next day, her epithelial defect had healed and her visual acuity was 6/6 in both the eyes. So the bandage contact lens was removed. However, on subsequent 2 visits at week 1 and 3, she showed a progressive diminution of vision, left eye more than the right, and her autoref also showed a progressive regression in the refractive error. So I decided to place a bandage contact lens. And at 3 weeks, this was her picture. The slit lamp examination showed epithelial haze along with dot-like lesions suggestive of intraepithelial cysts. So at 4 weeks, there was a further drop in vision, 612 in the right eye and 636 in the left eye, with increasing edema and breakdown in the left eye. This was also confirmed on OCT. So I decided to remove the bandage contact lens and add hypersol to her post-op regimen. And to my relief, 1 week later, her edema had completely resolved, her cornea cleared up, and her visual acuity was restored to 6/6 in both the eyes. And this was also confirmed on OCT of the cornea. Epithelial basement membrane dystrophy, also known as mapped out fingerprint dystrophy, is the most common kind with a prevalence of around 5 to 18%. It's usually bilateral, characterized by underdeveloped hemidesmosomes and loose epithelial attachments, which results in recurrent erosions. However, not all the cases are clinically very obvious and therefore need a more thorough pre-op evaluation on retroillumination and fluorescein staining. Intraop epithelial sloughing can be the first sign of silent cases of EBMD, which are managed with hyperosmotics and PTK, and they need to be watched carefully for complications like DLK, microfolds, and epithelial ingrowth. Thank you.
Thank you so much, doctor. Next up, may I please invite Dr. Gunjan Tomar?
Yes, sir. Sir, am I audible?
Yes, doctor, you are audible.
Sir, is my screen shared? Is it visible?
Not yet, doctor. Doctor, the screen is not yet visible.
Is it visible now?
Let's share the screen.
Yes.
It is visible.
Yes, we can start with the presentation, doctor.
Good evening, everyone. Today I'll be presenting a rare case of Schneider's corneal dystrophy. Schneider's corneal dystrophy is an autosomal dominant eye disease characterized by an abnormal deposition of cholesterol and phospholipids in the cornea, and the resulting bilateral corneal opacification is progressive. Approximately 50% of SCD patients have corneal crystalline deposits, which represent cholesterol crystals. 2/3 of affected individuals are hypercholesterolemic. Unaffected individual in SCD pedigree may also demonstrate hypercholesterolemia. Thus, it has been postulated that the corneal disease results from a local metabolic defect of cholesterol processing or transport in the cornea. Because only 50% affected patients have corneal crystals, the International Committee of Classification of Corneal Dystrophy recently changed the name of this dystrophy from Schneider crystalline corneal dystrophy to Schneider's corneal dystrophy. Diagnosis of affected individuals without crystalline deposit is often delayed, and these individuals have frequently misdiagnosed. The differential diagnosis of the SCD patient include other diseases with crystalline deposits such as cystinosis, tyrosinemia, BT's crystalline dystrophy, etc. Case report: a 42-year-old male patient presented to our ophthalmology OPD with complaint of bilateral gradual progressive diminution of vision in both the eyes. It has progressed in the last 2 years. Diminution of vision was associated with glare. No history of other ocular complaint and other systemic illness in the past. On examination, visual acuity was 6/12 in both the eyes. Anterior segment slit lamp examination revealed bilateral corneal haze with subepithelial and anterior stromal crystalline opacity. Anterior chamber and iris showed no signs of inflammation. Intraocular pressure was 17.3 mm of Hg in both the eyes.
Doctor, are we done with the presentation?
Lamp examination, you can see the subepithelial haze.
Okay, so we are done with the time. Thank you so much, doctor. Next up, we have Dr. Pallavi Sharma. Dr. Pallavi Sharma, may I please request you to unmute yourself, switch on your camera, and then start with screen sharing. Do we have Dr. Pallavi Sharma over here? Perfect. Doctor, we are still not able to hear you. Could you please unmute yourself?
Am I audible, sir?
Yes, doctor. Yes, you are audible now.
Are my slides visible, sir?
Yes, doctor, visible. I request you to please start sharing, start the presentation.
Camera on kar लीजिए.
A case with a rare case report of cavernous sinus metastasis in a patient with a primary breast malignancy. Patient presented to us with a complaint of diminution of vision and headache for 1.5 months. Diminution of vision was, double vision with headache for 1.5 months. Double vision was insidious in onset, gradually progressive, binocular, more at distance than near, continuous throughout the day with no diurnal variation, which was associated with headache. She had no, she doesn't have any other ocular complaint. She was having a past history. She was a known case of grade 2 invasive ductal carcinoma of left breast, for which she had undergone left breast lumpectomy outside in Feb 2021. On ocular examination, right eye was within the normal limits. In left eye, vision was 6/9, which was unaided, and on aided vision was 6/6 with 0.5 diopter spherical lens. IOP was normal and pupillary reaction was normal size, normal reaction. On Hirschberg test, she was orthophoric at near and 15-degree esotropia was noted in left eye at distance. On cover and cover test, findings were left eye esotropia. Both eye were taking fixation alternatively. And on uncovering right eye, secondary deviation was seen, which was more than primary. Prism bar cover test findings were suggestive of concomitant esotropia. On ocular motility examination in left eye, there was a restriction in abduction in left eye. And anterior and posterior segment examination were within the normal limits. This is a diplopia charting showing, which was also suggestive of uncrossed binocular diplopia, which was increasing in left gaze. There's a clinical photograph of patient showing 9 gaze position. There is limitation of abduction on left corresponding to left abducen nerve palsy. She was investigated for mammography, which showed, which was confirmatory for neoplastic lesion in breast. CECT was thorax and abdomen was done suggestive of multiple mets. The histopathology examination of left breast lump was suggestive of malignancy, and it was HER2/neu positive. It showed HER2/neu positive status. This is CMRI brain on orbit showing enhancing lesion along lateral wall of left cavernous sinus and petrous apex. The result was she was diagnosed with secondary metastasis to cavernous sinus from CA breast, which resulted in 6th nerve palsy. She was advised for alternate patching. It should be kept in mind that diplopia can be the first presenting complaint in metastasis. Thank you.
Sir?
Yes, doctor. Thank you so much for finishing it on time. Next up, may I please invite Dr. Amrita Bajaj?
Yes.
Yes, doctor. May I please request you to please start the screen sharing, and AV team, please start with the timer. Let's begin.
Can you see the screen?
Yes, doctor. We are able to see the screen.
Yes. So my topic is polishing the bulge in the bumps. So the introduction is that keratoconus is a progressive ectatic corneal disorder which results in biomechanical weakening by progressive stromal thinning causing irregular astigmatism and visual impairment. Corneal cross-linking was introduced by Wallensek in 2003. Prior to its introduction, many eyes progressed to the complications, and it managed to get end-stage keratoconus, but the efficacy of corneal cross-linking has been managed to hold the progression of ectasia. However, there was no improvement in the visual quality, but recently we have other devices which can actually aid the visual quality. So presently, many attempts have been made to combine standard PRK with CXL, but standard PRK does not suit for keratoconus. On the other hand, if we do a limited laser ablation, then we can actually find an effective method to improve the functional visual quality. So now we have a topo-guided PRK with cross-linking, but we have two types of things like a simultaneous or the sequential. So we found out that the simultaneous topography-guided PRK and CXL helps us improvement in the quality of vision. Then also we have two approaches like sequential and simultaneous, and then we have a topo-guided 50 microns topo-guided ablation that we can have. So we have a 22-year male in which we diagnosed right eye to be keratoconus and left eye to be FFKC, and in these were the epithelial maps. And this is the screen that we have for a topo-guided cross-linking in the right eye. So and now we did the procedure as managed, that we put a bandage contact lens at the end, and these are the differential subtraction actually make out a difference between the right eye and the left eye, that we reduced the steepening of the cornea. These were post of 1 month results, and finally we came up with an improvement in the visual quality at 1 month. And in the right eye, 624 to 612 visual acuity was improved. At best corrected was 6.6. Progressive flattening in the case and decreased acceptance. So simultaneously, topoguidal limited ablation of PRK and accelerated CXL has given excellent results in keratoconus progression, giving better biomechanical stability and outcomes with improvement of quality of vision. Thank you.
Thank you so much, doctor, for finishing it exactly on time. Next up, may I please invite Dr. Utkarsh Mishra. Doctor, I request you to please switch on your camera, unmute yourself, and then start with screen sharing. Dr. Utkarsh Mishra. Seems like Dr. Utkarsh is not over here. Next, may I please invite Dr. Aditi Jhunjhunwala.
Yes, I'm here. Can you hear me?
Yes, doctor. You're audible, loud and clear. Please start with screen sharing.
Yeah. Is my screen visible now?
Yes, doctor, visible.
Just give me a sec. Okay. Good afternoon, everyone. This is Aditi Jhunjhunwala, and today I will be presenting clinical course diagnosis and management of bilateral COVID-associated conjunctivitis, a case report. COVID-19 on rare occasion is found to be associated with ocular manifestations like conjunctivitis. It was first described by Li Wenliang, who got it from an asymptomatic glaucoma patient, and ocular mode of transmission is suggested by some. Ocular spread is by droplets and direct contact with mucous membranes. For entry into the cell, the virus uses ACE2 receptors, which are also found in conjunctiva and cornea. Although the pathophysiology is not completely understood, a three-stage model was proposed: viral replication, immune reaction, followed by tissue destruction. Our patient is a 29-year-old male who presented to us with chief complaints of redness of eye, foreign body sensation, watery discharge, and pain in both eyes for the last 10 days. Patient was COVID positive a few days back, and these symptoms started while he was COVID positive. On day 5 after the first COVID-19, he noticed redness in his left eye along with foreign body sensation, which progressed to involve right eye the next day. It was also associated with watery discharge and pain in both the eyes. He visited us once he was RT-PCR negative and ocular symptoms persisted. On slit examination, bilateral mild eyelid edema with grade 2 conjunctival injection in left eye and grade 1 conjunctival injection in right eye was present. Follicles were present on both superior and inferior palpebral conjunctiva. Rest of the ocular examination was within normal limit. Patient was started on antibiotic moxifloxacin and lubricant and showed improvement, but came back to us after 5 days with increased severity. Conjunctival swab was sent for RT-PCR culture and sensitivity, but came back negative for all the organisms. Patient was then started on topical and oral steroid, after which he showed a stable improvement. This is a pic showing the patient at the time of presentation and 1 week after starting the steroid treatment. Final diagnosis was made as bilateral COVID-associated conjunctivitis, which is conjunctivitis is the most common ocular manifestation of COVID-19 and is caused directly due to virus or is immune mediated. It is also COVID-19 is also found to be associated with cytokine dysregulation and subsequent immune reaction, which justifies the use of steroid. Similar cases were reported by Guamis and others, Syntheta K and others, Nayak and others, Amnesty M and Saldusi M and others. So in conclusion, COVID-19 has shown to have ocular involvement, mainly conjunctivitis, which is known to be self-limiting, but on rare occasion is progressive and steroid treatment is needed. Thank you.
Doctor, thank you so much. The time is up. Next up, may I please invite Dr. Jyoti Rawat. Dr. Jyoti, please switch on your camera, unmute yourself, and start with screen sharing. Dr. Jyoti Rawat. Seems like she is not over here. So may I please invite Dr. Gitanjali Sud. Dr. Gitanjali Sud. It seems that she isn't also here. So may I please invite Dr. Alisha Patel. Is Dr. Alisha Patel over here? Yes. Doctor, I request you to please start screen sharing. Perfect. Let's begin.
Please unmute कीजिए.
Have you unmuted yourself, doctor?
आपको वॉइस नहीं आ रही है.
By any chance, are you using any kind of earphones? No, doctor, not yet. Please unmute yourself. No, doctor, not audible at all. Okay, we can solve this technicality in some time and get back to you. Next, can we invite Dr. Sunita Bisht? Dr. Patel, we'll get back to you. Dr. Sunita Bisht? She's not aware. Okay, may I please invite Dr. Pooja Ben Patel? Dr. Pooja Ben Patel, please. Not here. Dr. Shivali Yadav?
Yes, sir. Yes, sir.
Yes, Dr. Shivali Yadav, please start with screen sharing.
Yes, sir.
Turn on your camera and let's begin with the presentation.
Yes, sir.
Till then, I would request Dr. Alisha Patel to please check into the technicalities. If you want, you can log in from one more device, might be a cell phone, and give the audio from there. Dr. Shivali Yadav, please begin with the presentation.
Yes, sir. Sir, am I audible?
Yes, doctor.
And my screen is visible?
Yes, doctor.
Okay. So my topic is anterior segment optical coherence tomography assessment of pterygium management with conjunctival limbal autograft transplantation. So pterygium is a fibrovascular conjunctival growth upon cornea due to repetitive limbal stem cell irritation neovascularization. 9.5 to 13% is their prevalence. 6.7 in 20 to 39 years, 13.5 in 40 to 59 years, 25.3 in 60 to 79 years. CLAT is the ideal treatment modality, and ASOCT is an excellent investigating modality for assessment of pterygium. So aims and objectives of our study was to measure preoperatively pterygium thickness and postoperatively keratectomy thickness by ASOCT, and to measure postoperative CLAT thickness after pterygium surgery. So this study was conducted in HIMSS over a period of 12 months. Study design was observational follow-up. Sample size was 40 eyes. Inclusion criteria was all cases with primary pterygium who were followed up till 3 months. Exclusion criteria were prior conjunctival and scleral surgery, recurrent pterygium, pseudopterygium, limbal stem cell deficiency. So the mean age of our population was 48.06 years. Males were 19, 46%. Females were 21, 54%. So we have divided our study population according to age in 4 groups. 20 to 39 was group 1, 40 to 59 was group 2, 60 to 79 was group 3, and 80 to 99 was group 4. Main surgical indications were foreign body sensation, watering and congestion, redness and congestion, visual disturbances, restricted extraocular movements, astigmatic and cosmesis. And the desired favorable outcomes were cosmesis, full free lens extraocular movements, corrected astigmatic and clear visual access. So pre-operative thickness of group wise is shown at apex limits and maximum thickness, and post-operative thickness group wise is shown at POD1, 1 week, 1 month, and 3 months. Similarly, at limbal area, and CLAT thickness is shown group wise for POD1, 1 week, 1 month, and 3 months. So we can see that there is a subsequent healing of keratectomy area over a period of 3 months, and there is a subsequent decrease of CLAT thickness over a period of 3 months. So the conclusion of our study is that keratectomy area heals completely over a period of 3 months, and CLAT thickness decreases subsequently over a period of 3 months. Thank you so much.
Thank you so much, doctor, for finishing it exactly within the time allotted. Next up, may I please invite Dr. Shreya Angrish?
Yes, sir.
Yes, doctor, may I please request you to switch on your camera, unmute yourself, and start with screen sharing.
Yes, sir. So is my screen visible, sir?
Yes, the screen is visible, doctor. Let's begin.
Yes, sir. Good afternoon, all. This is Dr. Shreya Angrish, and today I'll be talking about the visual assessment in mentally challenged child in general ophthalmologist practice. So visual assessment of a child is as it is a daunting task, and all the more so in a mentally challenged child. Hence, there's a need for simple techniques for vision assessment at a general ophthalmologist practice. So vision assessment in preverbal children are usually done by a variety of tests like Bruckner, checking fixation and follow response, preferential looking, and optokinetic drum test and visually equipped responses. And in 3 to 5 years, we tend to use Lee symbols and HOTV tests. But the problem with such tests is that usually instruments like optokinetic drums and visually evoked responses are not available everywhere practically. And visually evoked response testing are reliable only when done after 6 months of age. So there's another level of another method of doing vision testing, that is Hoyt's level, which does functional evaluation of vision, which was developed by C.S. Hoyt in an attempt to study children with cortical visual impairment. It was also used for follow-up vision assessment. Hoyt described level 1, where the child could only perceive light, level 2 as occasional fixation on large objects, level 3 as on fixation on small objects, level 4 as reliable fixation on small objects, level 5 with reliable visual acuity, and level 6 where the child had completely normal vision. The advantages of using Hoyt level as a vision assessment is that it is very practical, easy to apply. There is no need of special equipments and can be used very easily by any general ophthalmologist for follow-up visual assessment as well. So for comprehensive ophthalmic evaluation in a mentally challenged child, we can use Hoyt's level for doing the vision assessment, followed by complete refraction and dilated fundus evaluation. So the conclusion is, with the ever-growing incidence of CVI and mental disability and the unavailability of special equipments everywhere, we are in desperate need of easy method of visual acuity assessment, which can be employed by all the ophthalmologists anywhere and at any time to evaluate mentally challenged child. Thank you.
Thank you so much, Doctor, for finishing it exactly within the given time. Next up, may I please invite Dr. Ashneet Sandhu.
Hello.
Yes, Doctor.
Yes.
Dr. Ashneet?
Yes, sir.
Yes. Doctor, may I please request you to turn on your camera and start with screen sharing. Okay, let's begin with the presentation.
Good afternoon, everyone. I'll be doing a case report on timely explantation of glaucoma drainage device preventing evisceration. So GDDs are usually done in refractile glaucomas. So a 67-year-old one-eyed male presented with diminution of vision in the left eye for 4 months. He was a known diabetic hypertensive for 25 years. He had a past history of trabeculectomy in 2017 and a retinal detachment surgery in the left eye in 2019. His presenting visual acuity was finger counting 2 meters, and his IOP at presentation was 46 millimeters of mercury, and he was on 5 anti-glaucoma medications. The conjunctiva showed a non-functional bleb in the superior quadrant, with the fundus in the left eye had a CD ratio of 0.9 with a total cupping. PDR changes were present with old peripheral laser mark. So the patient underwent an uneventful left eye glaucoma device drainage surgery with scleral patch graft on 30th of August. On post-op day 1, the cornea was clear, the tube was seen in the anterior chamber, and the IOP was 10 millimeters of mercury. On post-op day 6, it was noted that on the left eye, there was a pinhead-sized corneal infiltrate present at the 2 o'clock position, and corneal scrapings came out to be positive for gram-positive cocaine pairs. The antibiotic dose was increased. Further, on post-op day 8, it was seen that there was an increase in the size of the infiltrates with hypopyon present, although the B scan was normal. Because of the worsening of the signs, the GDD explantation was done along with the scleral patch graft removal, and branch septate fungal hypho was seen in the patch graft, for which natamate and natamycin and voriconazole 200 mg was started. Later on, post-op day 16, it was noted that scleral necrosis was seen from 1 to 3 o'clock hours, and because of that, a multi-layered amniotic membrane transplantation was done along with corneal scrapings, which again showed a fungal septate hyphae. Because of the AMT, which was done on post-op day 22, clearing of the corneal infiltrates from the nasal quadrant was noted with a decrease in hypopyon, although the vision did not improve. Later on, after 1 month, the B scan showed an RD detachment was seen, and along with that, patient was also started on tablet ketoconazole, although no intervention was taken. Post 6 months and 1 year, no active infection with thysis bulbi was noted. The previous studies have also shown that in cases of endophthalmitis, there can be extrusion of the explant is done, and normally evisceration or enucleation of the eyes have been done. So it is very important to assess the status of the eye, especially to know the intraocular device implantation to see the early signs of infection, and also to, in this case, to expand the GDD and scleral patch removal helped us in salvaging the globe.
Thank you so much, Doctor, for finishing it on time. May I please invite Dr. Pooja Patel? Dr. Pooja Patel.
Hello.
Yes, doctor.
Yes, sir. Am I audible?
Yes, doctor.
Yes, thank you.
Please start with the presentation.
Yes, sir, please.
Yes, doctor.
Yes, today's my case poster is on the case of the optic neuritis associated with the multiple sclerosis.
We are not able to see the presentation. Can you start with screen sharing?
Yes, I had started. Screen share is started. Okay, fine. Now, is it visible? Now, the optic neuritis is a presenting feature in up to 20% of the multiple sclerosis patient, and it occurs as a 50% of the patient at the same point during their lifetime. The two most common symptoms are the vision loss and the eye pain. The optic neuroedema is also seen in the 1/3 of the multiple sclerosis patient, and the 2/3 of the patient have a normal optic nerve appearance that is known as a retrobulbar optic neuritis. In the gadolinium enhanced MRI is the investigation of choice to diagnose it. So my aim is to assess the visual prognosis of diminution of vision after the treatment with the IV methylprednisolone and the plasmapheresis in the case of optic neuritis that is associated with the multiple sclerosis. The methodology includes the pre and post treatment base corrected visual acuity, ocular movement and position, the intraocular pressure, and the slit lamp and the fundus examination. The also indirect ophthalmoscopy examination, optical coherence tomography, and the visual field assessment by the perimetry. Also, I have admitted the patient and done the routine blood investigations, and also I did perform the MRI, brain plus orbit with a gadolinium enhancement, and it is a 26-year-old Hindu male patient that come to our institute with a chief complaint of gradual painful vision loss in the right eye that followed by the left eye. Over the 10 days, the pain was increased with ocular movement, and there was no past history of any ocular trauma, surgery, or the systemic illness. The best corrected visual acuity in the right eye was a counting finger 1 feet, and in the left eye is a 6'9". The color vision in the right eye is abnormal, and the left eye was normal. The ocular movement and the position was normal. This is a MRI brain plus orbit of the patient, which shows the small subtle hyperintense lesion over the right optic nerve, and also in the periventricular area and the right frontal lobe. This is the fundus picture of pre and post treatment, which does not show any optic disc edema that shows that patient have a retrobulbar optic neuritis. The treatment treated my patient with
we would like you to stop right over here. Can we please invite Dr. Alisha Patel for the presentation? Yes, doctor.
Yes.
Please start with screen sharing.
Yes, good afternoon. I'm presenting an unusual case of ocular trauma. The aim of my study is to study the outcome of blunt ocular trauma leading to retinal tears. Blunt ocular trauma is a significant source of ocular morbidity worldwide, and the vision-threatening consequences include angle recession, damage of internal structures of the eye, which can cause glaucoma, hyphema, retinal detachments. Methodology is I have documented the patient in terms of these miscorrected visual acuity, ocular movements and position, fundus photography, and ocular coherence tomography, both on presentation and on follow-up before and after treatment. A 15-year-old Muslim female residing in Rajasthan came to our institute on an outpatient basis with the chief complaint of sudden diminution of vision post-injury to the left eye with a wound stick 5 days before the day of presentation. The patient presented with a tense periorbital edema, ecchymosis of the left upper lid, eccentrically proptosed left eye with restricted ocular movements. The patient gave a visual acuity of appreciable hand movements, normal perception of light with 40% projection of rays with an abnormal color vision and a relative afferent papillary defect in the left eye. The intraocular pressure was normal and the right eye was perfectly normal. This is a fundus picture showing a large macular tear with frayed margins in the inferior vascular arcade with subretinal edema and the subretinal edema extending up to the disc. The OCT findings include a huge retinal tear separating the ILM from the rest of the layers of the retina with a collection of subretinal fluid in the macular region. MRI findings are suggestive of contusion and edema of the retrobulbar fat and the left optic nerve with mild proptosis of the left eyeball. We have given a peribulbar triamcinolone acetate injection in the infralateral quadrant on presentation and oral steroids in tapering doses. Over weeks, proptosis and ocular movements were improved with no improvement in the visual acuity. Poor visual prognosis was explained and the patient was then referred to a higher center for an expert retina opinion. The patient compliance was poor and the patient was lost to follow-up. Blunt ocular trauma typically causes retinal breaks in the region of ora serrata and the peripheral retina. The rarity of the posterior pole tears is presumably due to a lower strain on this region. And the strain of vitreous adhesion
Doctor, thank you so much. The time is up.
Thank you.
Thank you. Is there anyone who hasn't presented at all?
Yeah, I am there. Number 13, Dr. Arnab.
Just a moment. Number 13.
13,
Dr.
yes,
Arnab.
Dr. Arnab.
Yes, doctor, can we start with the presentation? Please?
Yeah, am I audible now?
Yes, doctor, you're audible now. And
Okay.
I would request you to start with the slide share.
Is my screen visible?
Yes. No, not yet, doctor.
Not yet. Okay.
Is there anyone who has not?
Is my screen visible now?
Yes, doctor. If there is anyone who has not presented at all, please message me. Please message me. Sir, Dr. Arnab, please start with the presentation.
Yeah, so good afternoon, everyone. Today I shall be presenting a rare case of intraorbital and extraorbital arteriovenous malformation in an infant. So AV malformations are congenital lesions resulting due to failure of differentiation of the embryonic vascular network. Intraorbital AVMs are rare, and such cases pose both diagnostic and treatment challenges to ophthalmologists. So our case was a 2-month-old infant who presented to us with chief history of a swelling in the left upper side of the face since birth, which was associated with protrusion of the left eyeball on crying and exertion and gradually increasing in size with time. The eyeball was grossly normal with no pupillary abnormalities, anterior segment or posterior segment changes. CEMRI brain and orbit revealed a multiseptated and multi-compartmental slow flow vascular malformation likely to be an AV malformation with internal hemorrhagic areas extending in the intraconal as well as extraconal compartments of the left orbit. After obtaining all other relevant pre-operative investigations, the child was planned for surgical debulking of the AV malformation. Initially, a debulking surgery was done involving debulking of the left temporal and upper cheek lesion, along with dural defect of reconstruction in the temporal region. The patient underwent intraoperative cardiac arrest and was successfully resuscitated. Histopathology examination suggested features which were compatible with AV malformation. In view of exposure keratopathy due to significant proptosis, multiple foci of residual intra and extraorbital AVM, and aesthetically poor outcome, partial exenteration of the left orbital with reconstruction of the defects with local flap was done as a second procedure. During the second sitting too, the patient underwent intraoperative cardiac arrest and was successfully resuscitated. After 18 months of follow-up, the patient's outcome is satisfactory without any evidence of recurrence. Now, the primary treatment for orbital AVMs is surgical excision with or without preoperative embolization. Our case was unusual in various aspects like very early presentation, rapid progression, and large size of the lesion with multiple site involvement. Thus, the case was challenging with 2 episodes of intraoperative cardiac arrest of the infant, but was managed successfully with multidisciplinary team. So in conclusion, I would like to say that the multidisciplinary treating teams provide optimal outcomes in such cases. However, vision and eye cannot be salvaged in all cases. Thank you.
Thank you so much, doctor. Now, the fact that we have everyone who has presented their slides. Judges? Judges?
Yes, I am Dr. Harsh. Hello.
Yes, Dr. Harsh,
Can you hear me?
there are a few requests. One of our participants had a technical issue.
Okay.
They were not able to complete their presentation. The participant's name is Dr. Gunjan Tomar, and they wanted to present their last slide. So shall we allow them?
Yeah, if you it can.
Okay.
Thank you,
so
sir. Thank you,
may
sir.
I request Dr. Gunjan Tomar
Yes,
to
sir.
please start with the slide share?
Yes, sir. So, am I screen visible?
Yes, doctor.
Without wasting any more time, I'll start with the examination. My case was of a rare case of Snyder's corneal dystrophy.
1 minute.
Yeah.
Yes.
Okay. On examination, visual acuity was 612 in both the eyes. There was bilateral corneal haze with subepithelial and anterior stromal crystalline opacities. On slit lamp examination, in both the eyes, we can see subepithelial haze and anterior stromal crystalline opacities. Anterior segment OCT confirmed the finding in the presence of subepithelial and anterior stromal crystalline depositions. Blood investigations revealed hyperlipidemia and high serum cholesterol. Rest of the parameters were within normal limits. In conclusion, Snyder's corneal dystrophy is a rare but has different presentation and may actually be misdiagnosed. The clinical signs change as the patient ages, causing a decrease in vision. The association between high serum cholesterol and high low-density lipoprotein with anterior stromal crystalline corneal deposits have been established. Anterior segment OCT confirms subepithelial deposits. Ophthalmology should keep in mind SCD and its associated systemic findings that need to be evaluated and managed properly. Management, they can be excimer keratectomy, deep anterior lamellar keratoplasty, penetrating keratoplasty. Thank you.
Thank you so much, doctor.
Thank
Just
you,
a
sir.
reminder, do we have Dr. Sanjini Sahai, Dr. Munish Dhawan, Dr. Utkarsh Mishra, Dr. Jyoti Rawat, Dr. Gitanjali Sud, or Dr. Sunita Bisht. These doctors weren't present for the last session. So do we have any of them over here? No. Thank you so much for coordinating with us. The session was supposed to end exactly at 3 o'clock. It's 3:03. And thank you so much for coordinating. Do we have a word from the judges?
Hello, can you hear
Yes.
me? I'm Dr. Harsh speaking.
Yes, doctor.
Yes.
Okay. Okay. I want to just comment that some of the candidates, they are from my institute, so it is not fair that I should be judging this session. So I request the fellow judges that they should do the job. This is a request from my side, because about 5 students, they are from my department. So I request the other judges to do the job. Thank you so much.
Thank you so much, Dr. Harsh. Well, to conclude the session, we had Professor Harsh Bahadur, Dr. Manisha Gupta, Dr. Anand Vardhan, and Dr. Nutan Jain for this session. Our moderator was Dr. Vipul Arora. And here we conclude the session. Thank you so much, everyone.
Thank you.
Next session starts at 3:30. Till then, let's have a short break. A gentle reminder, our next session starts exactly at 3:30, which is Dr. MC Luthra Gold Medal Award Final. Our judges for this session would be Dr. BK Oli, Dr. Jaideep Datta, Dr. Amit Tarafdar, Dr. Rajendra Prasad, Dr. Ashi Khurana, and Dr. Saurabh Chaudhary. Our moderator would be Dr. Saurabh Luthra, and we go live exactly in the next 4 minutes. Also, our speakers would be given exactly 10 minutes for each presentation, and then 2 minutes would be for the buffer time that we would require to start screen sharing and other details. So please make a note that you finish up the presentation in 10 minutes. I'm your MOC Purnesh Paliwala from Team Nikhil Khatri and Grover AV Visuals. Do we have a moderator, Dr. Saurabh Luthra over here? Yes. Dr. Saurabh, I would just like to discuss one thing, that I do not have the name of the finalists. So the winners of first session, second session, third session, fourth session, and fifth session. So I would like you to take over and invite the speakers for this session.
Okay, sure. Thanks. 1 second. So can we start the session now?
Yes, doctor, we can start.
Okay.
Are all the judges there? Dr. Saurabh?
Yes, sir. So I'm just going to ask them. Yes, sir. So I'm just opening up this session details.
Dr. Oli is there with me.
Okay.
Dr. Oli is there. Dr. Jaideep, I am there.
Yes, sir.
Check for the other judges.
Sir, Dr. Oli is in the attendees. I am a panelist.
So he's a panelist. He's there with me. He's sitting with me.
Okay.
Okay. So Dr. Amit Tarafdar. Dr. Amit Tarafdar, sir, are you there? And Dr. Rajendra Prasad, sir?
No, sir, both aren't present over here.
Okay. And Dr. Ashi Khurana, ma'am?
She's also not over here.
Dr. Saurabh Chaudhary?
No, not yet.
So, Datta sir, should we wait for them or should we just start with the...
How do we start with only 2 judges? What about the other judges then?
Yes, sir. So, I'll call Dr. Vinod Arora, but he's presenting, the session 2 minutes to win. So,
Okay, we can take some time over here as I have got the list of the presenters who would be presenting in this session. Thank you so much, Dr. Shweta Parak, for the list.
In the meantime, sir, Dr. Datta sir, in the meantime, can I show a film I'm supposed to show for Dr. MC to introduce Dr. MC Luthra?
Yes, please do.
Okay, sir. So I'll share my screen and I'll just open that. 1 second. Can you see my screen?
There is nothing on the screen at the moment.
Yeah, it's a black screen. Can you see?
Yeah.
Okay. So as we all know that the free paper gold medal session is named after Dr. MC Luthra. So this is just a tribute. We lost him this year in April, and I'm just playing this as a tribute to him.
Dr. J. Dutta. टोटल ये आपका
We wish to carry on and develop even better services from time to time. That is our objective.
Okay, so may I just ask again if Dr. Amit Tarafdar sir is there? Dr. Ashi Khurana ma'am? Dr. Rajendra Prasad sir? Dr. Saurabh Chaudhary? So Datta sir, how should we go about it? Should we start or?
Sir, these are the winners of different papers, right?
Yes, but this is the competition for the gold medal. So this is a gold medal session. So we need judges. I mean,
Okay.
Okay, Dr. Tarafdar has joined. So Dr. Datta sir, if Dr. Tarafdar sir has joined and you are three of you now, can we start the session?
I'm promoting Dr. Tarafdar to a panelist so that he can come over here and he can speak to every one of us.
Okay.
आपने डॉक्टर तरफदार को खोलना पड़ेगा, फिर ये बंद करना पड़ेगा.
Yes, Dr. Amit Tarafdar is over here.
Okay, welcome Dr. Tarafdar sir. And we are going to start the session. So there are 5, winners from the 5 free paper sessions. So each presenter has to present the same presentation which was done in the preliminary round, and it is for 5 minutes, sir. So can we start the? Sir, do you have the?
Are we sure that it is for 5 minutes? Because we have 1 hour. That is till 4:30 for 5 presenters.
Yeah.
So are we taking 5 minutes plus 5 minutes question answers?
Gaurav?
Yes.
Sir,
Yes, sir.
audible to you?
Yes, sir. Yes, I can hear you, sir.
I want to convey one thing to Dr. Amit Tarafdar.
Yes, sir.
That we are taking baseline of 50 marks.
Okay.
Baseline of 50 marks.
50, na sir? 50.
50.
50. So the total will be marked out of 50, sir.
Out of 100.
Out of 100.
100. Okay. Okay.
To the first contestant, we'll give 50.
I didn't get that, sir.
Beg your pardon?
So I didn't understand the baseline 50, sir. I didn't get the what you're saying.
We'll give baseline to the first speaker 50. So if the other speaker or the 4 speakers are better, then we'll go downside. Is it right or not?
So Dr. Tarafdar sir, did you understand what Dr. Oli sir is saying? Sir, you are muted. Sir, you are muted, sir.
Sir, I will request.
Yes. Can you hear me?
Sir, there are 2 devices logged in. So I would request please log out from one device or mute.
Dr. Tarafdar sir,
one device.
Maybe you have a delegate, login. So you are logged in through the delegate link and also through the, the panelist link, sir.
Amit, can you listen to me?
Dr. Tarafdar sir, can you unmute now?
Yeah. Can you hear me now?
सर आपका 2 डिवाइस ऑन है, एक को बंद कर लीजिए सर.
सर दोनों में से एक डिवाइस आपको ऑफ रखना पड़ेगा.
So maybe we can ask him if he can't get it. We can ask him to leave and then join. So now it's better.
So now could you try to unmute yourself?
Dr. Tarafdar.
He is muted. I can see in the screen he is muted.
Yeah.
Now can you?
Dr.
Yes, can you hear me?
It's amazing.
Yes, it's much better, sir.
Yes, sir.
Dr. Datta, is it okay? We can start, sir.
I think we should start.
Dr. Taravdar sir, what Dr. Oli was saying is that like we can start with the minimum marks of 50 out of 100, and then we can kind of give the marks accordingly to the 5 presenters. So the minimum marks we start at 50 out of 100, and then mark all of the people. Yes. So
and the time of each presentation, Saurabh, is it 10 minutes or 5 minutes?
So the presentation time I was told by Dr. Vinod Arora sir was 5 minutes, sir. And then we can have like questions from the judges. And then once the questions, like 1 or 2 or 3 questions, and then we can proceed to the next presentation, sir.
Okay,
sir.
right.
Mr. Rakesh sir.
So can
Rakesh sir, पहले sir, doctor, just a minute. Rakesh sir, पहले 5 minutes का timer, उसके बाद 3 minutes का timer.
Perfect.
ठीक है sir.
So yeah, so welcome all to the Dr. MC Luthra Gold Medal session, and now I would request the first free paper session winner, Dr. Shweta Parekh, to share her presentation.
Am I audible, sir?
Yes.
Okay, I'll just share my screen. Can you see my presentation?
Great.
Are my slides visible?
Yes.
Go ahead.
Okay. Good afternoon, everybody. Thank you to UKSOS for this opportunity to present this interesting case. A 57-year-old female first presented to us 11 years ago with a diminution of vision in both eyes and low-grade vitritis in the right eye, which responded to treatment with steroids. MAN2 test was positive at that time. And 3 months later, she presented with disc optic neuritis in the left eye, which responded to treatment with IVMP and oral prednisolone. Subsequently, she had 2 more episodes of bilateral low-grade vitritis in both eyes in the following year, and they responded well to treatment with oral steroids. Repeat uveitis panel each time was not contributory, and she improved to 6/9 vision in the left eye after cataract surgery under steroid cover. She was lost to follow-up for 7 years and only returned in the beginning of this year with low-grade vitritis, again bilaterally. Media was hazy in the right eye. Left eye showed extensive RPE alteration at the posterior pole with subretinal fluid. In the swept source OCT, we can see she had epiretinal membrane in both eyes, subretinal fluid and hyperreflective dots in the subretinal fluid in the right eye. And in the left eye below, you can see there is hyperreflective subretinal material between the RPE and the Brooks membrane. So Brooks membrane is completely intact here. The fundus autofluorescence confirmed the presence of a leopard spot pattern more prominent in the left eye. And this was seen very clearly in the FFA, more prominent in the left eye. MRI brain was within normal limits, and a CSF analysis and a bone marrow preparation showed no evidence of atypical cells or lymphoma infiltration. PET-CT revealed some hypermetabolic lymph nodes, which on biopsy showed only reactive lymphadenitis and no evidence of lymphoproliferative disease. She underwent a diagnostic vitrectomy, which showed atypical lymphoid cells, which were negative for B cell markers and positive for T cell markers, and which features suggestive of a lymphoma. These are the histopathology slides, and a diagnosis of bilateral primary PBRL of T cell origin with only ocular involvement was made. She was then started on a regimen of 25 injections per eye of intravitreal methotrexate. So far, she has received 19 in the right eye and 20 in the left eye, and she has experienced only corneal epitheliopathy and transient IOP rise, which have responded well to topical medications. She was in remission until June 2021, as we can see, as shown by this OCT, with the resolution of SRF and sub-RP infiltration and resolution of the leopard spot pattern as well. And however, at her latest visit, we can see that there has been some recurrence of the SRF and subretinal hyperreflective material. So primary intraocular lymphoma is of 2 types. Intraocular lymphoma is of 2 types, primary and secondary, and most commonly primary vitreoretinal lymphoma is seen. Around 60 to 90% of PVRLs involve the brain subsequently, while 15 to 20% of patients with PCSNL will develop PVRL later. More than 95% are of the diffuse large B-cell non-Hodgkin's type, and PVRL of the T-cell origin are extremely rare. And clinically, it is not possible to differentiate between the two, but we should be on the lookout for vitritis in the form of vitreous sheets, aurora borealis pattern, string of pearl pattern, or subretinal hyperreflective infiltrate between the RP and Brooks, and the leopard spot pattern on FFA and autofluorescence. Vitrectomy can be confirmatory. Histopathology is the gold standard. Low vitrector cut rate should be used. Steroids should be stopped 2 weeks prior to the vitrectomy. The diagnosis is quite challenging because of high rate of false negative vitreous biopsies. Some genetic mutations are now confirmatory. In the treatment regimens, we can opt for locally EBRT or intravitreal methotrexate or intravitreal rituximab. And systemic options again include whole brain radiation therapy and chemotherapy. So basically, characteristic OCT findings that we need to look for are subretinal hyperreflective infiltrates in the form of nodules, bands, clumps, or sheets. So the diagnosis of PVRL is quite challenging as the features are non-specific and masquerade as chronic uveitis or vitritis, and diagnosis is often delayed due to lympholytic effect of steroid therapy. It is important to look for biomarkers on imaging such as hyperreflective subretinal infiltrates, subarachnoid deposits, clumps of vitreous cells, and the leopard spot appearance. Thank you for the patient hearing.
Thank you so much, doctor. That was precise on time. To the judges, do we have any questions?
Yeah. What was the clinical diagnosis when she first presented to you, and what investigations did you carry out before starting steroid treatment?
Sir, initially it was known that she was a case of recurrent chronic panuveitis relapsing in both eyes, and only looking at the OCT picture and the clinical diagnosis, wet ARMD was on the differential diagnosis list. And before starting, we did not start her on steroids right away, because after looking at the FFA and FAF picture and the leopard spot appearance, we thought we were quite suspicious of a lymphoma, and therefore we did not start any topical or oral steroids before her biopsy. And only after her biopsy, we have started on intravitreal methotrexate.
But you said that you had given her steroids in the first instance?
Right. So that was 10 years ago when she only presented with low-grade vitritis. At that time, yes.
At that time, when she first presented to you with a low-grade vitritis, what was the clinical diagnosis and what investigations were carried out then?
So CBC, ESR, chest X-ray, MAN2 test.
So all that was normal?
Yes, sir. All that was normal except for MAN2 test that was 25 mm positive at that time. But she had no evidence of systemic tuberculosis, and she was evaluated for that by the pulmonologist also.
So you gave her oral steroids?
Yes, sir.
And she responded to oral steroids?
Yes, sir.
The swelling reduced and the visual acuity improved?
Yes, sir. Very
so you
long
presumed it to be you presumed it to be a non-specific inflammatory reaction?
Yes, sir. Initially, it was just low-grade vitritis. That is what, and no imaging, typical imaging features. And over the span of this, maybe during the period that she was not treated with steroids, because of the lympholytic effect of steroids, maybe it responds. It is known that PVRL responds to short-term steroid therapy. And then...
So clinically, when did you suspect that she may have been having a lymphoma?
When she came back after 7 years, when we saw the OCT and this hyperdense, reflective infiltrate between the RP and the Brooks, which was not and the typical FAF and FFA pattern.
Right.
That is when we, yes, sir.
Right. Thank you. Dr. Saurabh, you would like to mention anything?
No, sir.
Because before we go on to anything else, I think we have a time constraint, so I think we should move on to the next presenter.
Okay. Right. So with the,
thank you.
The judges are okay, can I invite the next speaker? Yes. So I would request Dr. Anjali Rana to please present her free paper.
Okay, sir. Sir, I'll be sharing my screen.
This is what I mean. You better know and the better. First.
The second speaker.
Dr. Anjali Rana, can you please share your screen?
Dr. Anjali?
We can go to the third speaker then in that case.
Yes, Dr. Amrita Vidushi Bajaj, could you please share your screen and your presentation?
Yes, I'll do that.
There are possibilities that Dr. Anjali is having some kind of technical issues, so we can ask her to share the screen afterwards.
Yes, sure. Thank you. So please share your screen, Dr. Amrita.
Is my screen visible?
Yes, please go on.
Is it on a slideshow now?
Yes, please go ahead. You're all good.
Okay. Good evening, everyone. My topic for the paper presentation is smiling through the frowns. So we all know that small incision lenticle extraction is a newer laser refractive procedure which forms a small peripheral corneal incision for the refractive lenticle extraction. It avoids any flap creation and provides a better biomechanical stability. Also, the technique involves docking along with a femtosecond laser application followed by a lenticle dissection and the refractive lenticle extraction. So SMILE, as we know, is a more predictable, has better earlier visual rehabilitation for the patients, uses lesser suction, lesser incidence of dry eye, minimizes any flap-related complications, causes lesser biomechanical weakening of the cornea, and lesser higher-order aberrations are generated. But however, an anxious patient with a difficult ocular anatomy and lack of cyclotorsion control can lead to unforeseen challenges during the surgery. These challenges can be either machine-related or patient-related or surgeon-related. The possible scenarios faced by the surgeon can be difficulty in the docking, suction loss, appearance of dark spots, cap tear, difficult dissection, and wrong plane of dissection, and which can further lead to retained lenticule. The causes of all of this can be anxious patients who can make sudden eye rotation movements who poorly follow our instructions, and a wet conjunctiva or a strong Bell's phenomenon. So let us see some challenges encountered during the SMILE surgery. So this is the first case. In this, something has been trapped while docking and the surgeon has quite not noticed that. So when this laser has started, that is when it becomes more clearer that the eyelash has been entrapped into the docking system. Next, when we go on to, so this is an anxious patient and the surgeon has been constantly guiding the patient to not make any further eye movements, but yet we can see that the eye movements are actually made by the patient. So this can lead to the ablation being stopped and other complications further. This is a third case. Till now, everything seems to be going absolutely all right. Everything is just on point and the laser has been moving. But just when we wait for the laser to finish, that is when we notice that the patient has started making eye movements. Even after counseling, that is when we notice that the patient has still been making a little eye movements, and they can be during a side cut, he's made a sudden movement. So this can lead to inappropriate side cut that's been made. Next, in this particular thing, we can actually see the fluid being coming along the docking ring, but see inferiorly, the conjunctiva is all bulking inside. So this is a very drastic thing, and the surgeon should have actually stopped. And in this, we can actually see the side cut did not really happen. This is the next case. In the laser has started, and we can already see a couple of dark spots everywhere, and yet we are waiting for the laser to finish. But see, again, even after the laser has finished, we can find out the dark spots. So we have to be really aware of the fact that after this, when we start the dissection for this particular patient, in the same exact plane where the dark spots would have appeared, the laser ablation would not have completed itself, considering the fact that the difficulty in the dissection would have happened there. So we should always be cautious whenever we see dark spots, but we were lucky enough that our dissection came out to be smooth and consistent, and the lenticle extraction was fine. Lenticle extraction. This is the next case. In this, we're actually trying to, the surgeon is very cautious about the planes that he's being following. So initially in SMILE, it is difficult to find out the planes. So the surgeon is quite slow and meticulous with the approach and slowing down and trying to find the right plane because he should not hit the wrong plane and the lenticle should not tear off. So that is why, but once we are slow and we find the exact plane, that is when the surgery can be really uneventful and the lenticle can be extracted quite well. This is a borrowed video I would like to share. In this, while the lenticle is being extracted, we can actually see a cap tear. So the cap is being torn more and more. So we should really be cautious about the instrumentations for us. And if in case we encounter a cap tear, then we should actually stop and put the place it again and do a lenticle dissection properly. And after we are done with it, we can actually place a BCL for the same day and we can open it next day and remove the BCL the next day. So what can all of this lead to? This is has a risk of abortion of the procedure, has a rougher dissection plane, wrong plane of dissection, and difficult lenticle separation can be there. Potentially poor visual outcomes, and therefore a dissatisfied patient at the end of a refractive procedure. So SMILE has significant advantages over femtoLASIK, and patients opting for SMILE have increased. Almost 60% of our patients now walk in to actually have a SMILE and not a LASIK operation. Gives the surgeons more peace because there are no flap-related complications, so the surgeons are more relieved. It is very important to counsel the patient and leading the patient with every step so that we have a better patient cooperation. A good patient should be selected initially, and familiarity of the machine has to be done. So this helps the surgeon guide his patients better with more conviction for better available treatments. So how to keep smiling, initial learning curve has to be addressed, meticulous approach to the learning techniques. There are no shortcuts, and the learning from mistakes. Every challenge that we face is an opportunity so that we can make it a better SMILE surgery for the next time. I would like to conclude with a good patient selection, better preparedness for the challenges, helps cruise through to achieve more predictable outcomes in SMILE surgery. Thank you so much.
Thank you, Dr. Amrita, and the judges for comments and questions.
I would like to ask how many SMILE surgery we have done.
I can't hear you, so sorry.
How many SMILE surgery you have done independently?
Sir, I haven't done any. I think these are all Dr. Gaurav Luthra's cases that we've been focusing on, and we're trying to see that what challenges we can actually have, and with every passing surgery, what more can we learn with them.
So I like start is understood it is a mistake. And what you do to lock the machine with the eye movement.
Sorry, sir, can you please repeat it? It's actually very low. Sorry. Hello?
Hello.
Hello. Yes, I can hear you.
You do counseling in case of patient doesn't move the eye.
So whenever we start the docking procedure, first of all, most of the time we are actually counseling the patient about the whole procedure. And once we start, so we keep talking to the patient, because while we dock at that time, it's still fine. But after the docking, the patient shouldn't move their eyes. So that is when we have to counsel them that after 10 seconds, the green light that they are supposed to focus on becomes a little more blur. And after the blurring of the light, they could still focus on the right plane that they're already focusing on, not move for another 10 seconds. So while we talk to the patient and tell them to not move their eyes all this while, and it is just about to be over. And besides, we count along with them till 20. So it gives them a little more better, I think, understanding of the procedure and more cooperativeness for us for the next 20 seconds for the laser ablation that we are doing then.
So last question, does the machine lock to the pupil so that movement don't create any problem?
No, sir, it does not. I mean, the pupil has to fixate because it is a corneal suction. So we have to make the patient, because it is not like a femtoLASIK that it is a higher suction that we are applying. So we are supposed to make the patient look straight. So even gentle movements, if they make sudden movements, then actually the suction can be lost in these cases. But yet, I think all the cases that I have shown you over here were pretty good enough to not lose the suction that time when the procedure was happening.
Dr. Amit Rabdan, any question? Thank you. You are mute, sir.
Thank you so much.
To the next presentation.
Thank you.
Amrita is ready with her slides. Dr. Amrita.
Was Dr. Amrita. We have Dr. Anjali Rana, Dr. Shreya Maheshwari, and Dr. Jasleen Singh.
Yeah, so sorry, Dr. Anjali, can you share your screen?
Yes, sir. I'll be sharing.
Please share your screen.
Yes, sir, please.
Anjali, अब आई है. अब Anjali.
So if there are any technical issues, please do tell us, because then we can move to the next presenter and come back to you, Dr. Anjali.
Sir, actually, it's taking some time for sharing. Whenever I share it, it gets logged out auto.
So I think we can move to the fourth presenter and come back to you, Dr. Anjali.
Yes,
is that
we can move to Dr. Shreya Maheshwari.
Yeah, so the next presenter is Dr. Shreya Maheshwari. Please share your screen, Dr. Shreya.
Yes, sir. So is my screen visible, sir?
Yes. Please, you're ready to go. Go ahead.
Good afternoon, everybody.
Anything, 5 minutes timer.
Yes, sir. Good afternoon, everybody. Good afternoon, esteemed judges and other panelists. So I will be presenting an interesting case that left us into confusion that what actually the diagnosis was. So it was an 82-year-old female who presented to us in August 2020. This was the time of the COVID first wave. She complained of left eye diminution of vision, which was associated with redness and mild pain for last 20 days. On examination, the initial finding which we found was that her best corrected visual acuity in left eye was 624 parts. And on her fundus examination, we found this lesion which had orange speckles. So on your left, you will find the normal fundus image, and on your right, there is the infrared image that you can see. So now the question was, it's an 82-year-old lady, so what all investigation should we put her through? So we had an autofluorescence that we got done, and we found on the hypofluorescent background the speckled hyperfluorescence. And then we put her to OCT, and in this, as you can see, there is a lumpy bumpy RPE and the choroidal elevation that you can see, and the subretinal fluid that is also visible. We actually wanted to do a B scan, but she felt it's a contact investigation, so she never agreed to it. But she finally agreed to an angiography and ICGA. And in this, these are the early phase pictures where we see the hypofluorescence in FFA and hypocyanescent areas in ICGA. And in the late phases, we saw the speckled pinpoint leakages in the fluorescent angiography and still the hyperfluorescent images on ICGA. So our initial diagnosis, because of pain and congestion, we came it to be posterior scleritis. We investigated her for RA factor, ACE levels, and quantiferon TB gold. All came negative. So we considered it to be a non-infective inflammatory disease and started her on oral steroids. On the follow-up, we were astonished to see that the SRF had reduced down, so we thought our diagnosis was right. But when we examined her more and we did the scans in the radial lines, we found that this was just shifting of fluid that we see in exudative RD and not the regression actually. So again, the question was, what are we missing? And we started thinking about the differential diagnosis of choroids metastasis, choroidal melanoma. But again, we didn't have any history of previous cancer. So we tried to probe her for history again, and then we came to know that she had infiltrating ductal carcinoma 3 years back, for which she had underwent modified radical mastectomy, and she was on memopen for last 3 years. We sent her to oncologists, and after CT thorax and abdomen, choroidal mets was finally kept as diagnosis, and patient was started on pelbociclib and letrozole tablets. And on follow-up, initially, as you can see in the last picture, the choroidal elevation had gone down, her vision had improved to 6 parts, and SRF had regressed. So as our diagnosis, we were in dilemma about initially posterior scleritis and then melanoma versus metastasis. So as you can see in the B scan pictures, the A image show the melanoma, which is a dense cellular mass, and it's more like a mushroom appearance, while the B picture is a metastatic thing, and the height to base ratio is lesser in choroidal metastasis. Choroidal metastasis is the most common intraocular malignancy, which we find if uvea is involved, then 88 to 89% is the choroid, and breast metastasis is in 40 to 53% of the cases. The main reasons are the abundant supply of posterior choroid by the posterior ciliary arteries. Then it has a good metastatic efficiency index, and the wound oncogene wound healing model is also one of the pathophysiology. So these are the different pictures of different cancers which have metastasized to choroid. So as we can see, the B1, it's seen in the breast carcinoma. The A image is seen in the lung carcinoma. The E is seen in the carcinoid tumors, and the F is in the thyroid. So each type of cancer has a peculiar color, which you can see and identify. The various investigations we can do are B-scan, OCT, angiographies, MRI, and tumor biopsy. So these are the OCT images that we see. The red arrow shows the speckled dots, hyperreflective dots in the subretinal fluid. These are actually the lipofuscin particles and the dead photoreceptors that we see. Then we see a concave appearance on the convex appearance on the retina. So these are the typical OCT findings which we see in the choroidal mets. And these are the angiographic findings which are similar to our case. So various treatment that we can give are the immune and hormone therapy, otherwise the radiotherapies or the gamma knife, proton beam therapy. We can even go with transpupillary and photodynamic therapy, and at last we can even give intravitreal Avastin. That also works well. So the two drugs that we had used were pelbociclib, which acts on cyclin D1, D2, as you can see in the inset, and inhibits the G1 phase, and letrozole, which are the non-aromatase inhibitors and inhibits the estrogen receptors. Thank you. So the conclusion is that history is very important, and any patient with the history of carcinoma should be screened with ECO. Thank you.
Thank you, Dr. Shrey. Judges, please.
Dr. Taraftar, would you like to ask something? How many years after the diagnosis of malignancy did this presentation come in?
So 1/3 of the there are articles where people have
this patient.
So after 3 years of her initial malignancy, for which she was cancer free, she underwent modified radical mastectomy and
with chemotherapy.
Pardon, sir?
With chemotherapy.
Yes, sir. She was on memofen, sir. She was on memofen, and initially she had received the chemotherapy and modified radical mastectomy, and she was kept on the continuation therapy with the memofen, and she didn't have any other symptom in her body unless and until she came for an eye checkup, and then after the CT scans, it was realized that the metastasis was extensive, which we could see in the thorax and abdomen.
At other places also she had a metastasis.
Yes, sir. The thorax and abdomen were involved, sir.
And she did not reveal about her malignancy on the first visit.
No, sir. Actually, I guess probably because it was COVID times. So we were fast tracking the OPD, and she was 82-year-old. She was very paranoid visiting the hospital. She just wanted to rush through, like come and go back fast. And her main complaint was that slight diminution of vision is there. So because of that, the fast tracking of the OPD, we asked also, but she didn't reveal about her cancer histories at that time.
The past history of malignancy was not revealed by the patient.
Yes, sir.
Right. Thank you so much.
Thank you, sir.
Thank you, Dr. Shrey. And I would now request Dr. Anjali Rana to, share her screen.
Okay, sir.
No, are you ready? Can you share your screen? Because we are running short of time because we have 2 presentations left.
Dr. Anjali, please let me help you. Let me help guide you. Is there anything that we are looking forward to? Are we able to share the screen or not?
Any problem that you're having, Dr. Anjali?
So please give me 2 minutes time. It's just logging out automatically. Na? Matlab, I'm not getting time to get logged in. So just please wait for 2 minutes. It will share.
Okay, we will wait for
Okay, sir. So please.
Dr. Datta, sir? Dr. Datta, sir?
Yeah.
Sir, I actually at 4:15 I have to go to another Vitreoretinal Society of India session. Would it be okay for me to, is it okay?
Yeah, we just have 2 speakers left.
Yes, sir. So after, if Dr. Anjali can present, then we can have Dr. Jasleen Singh following that. Otherwise, we can request Dr. Jasleen Singh to share and then have Dr. Anjali present.
We can do that. Why not?
Okay, sir. So I will take your permission because I will be I have to go to the VRSI session, sir, at 4:15.
Yeah, please. Yeah, please do. We'll carry on.
Okay, sir. Thank you so much.
Is Dr. Tarafdar still connected or not? I haven't heard from him.
He's right
here.
Yeah, he's there. He's there.
Okay, right. Thank you, Dr. Tarafdar.
Thank you, Dr. Taradar, sir. Thank you, sir. And thank you, Dr. Oli. Thank you, Dr. Oli, sir.
Thank you, Saurabh.
Okay.
Dr. Jasleen Kaur, do we have you here? Dr. Jasleen Kaur? Jasleen Singh. Sorry. I think.
Sir, it's not connecting. Sir, can you? It will just take me 5 to 10 minutes to reconnect it.
Dr. Anjali, I would request you to please log out and then log in. It might just reset itself and start.
Okay, sir, I'll just take 5 to 10 minutes, sir. I'll try again.
Yes, doctor.
Okay, sir. Thank you.
Do we have Dr. Jasleen Singh over here? So, Dr. Jaideep and Dr. Amit,
yes.
We do not have Dr. Jasleen Singh over here, and we are waiting for Dr. Anjali Rana as she is going to reconnect.
Okay. So we'll wait for Dr. Jasleen if she can join in.
Yes, sir. We can wait for Dr. Jasleen and Dr. Anjali. Till then, if we have any kind of questions for the 3 presenters that took place, the 3 presentations that took
Dr.
place.
Tarafdar, would you like to ask something? You can ask.
Dr. Shweta, Dr. Shrey, and Dr. Amrita, please go ahead. Dr. Amit, do we have any questions for the past 3 presenters?
No, I don't have any questions. Thank you.
Right. Thank you.
Okay. Dr. Jaideep, do we have any questions?
No, we've already asked. Thank you.
Okay. Thank you, sir. We'll just wait for a few minutes. Dr. Anjali Rana.
Has she also gone away?
Yes, sir. I suggested her to log in from another device or just
Okay.
restart her device. So I think she'll log in now, and we
Dr.
might
Jasleen
have
is gone.
one more presentation because we are not able to find Dr. Jasleen Singh. So possibly she's not present over here for the presentation. But we have time till 4:20. If before 4:20 Dr. Anjali Rana arrives, we can ask her to present. We can wait till 4:22, but post 4:22 we'll have to disqualify her.
Oh, that would be sad.
Yes, sir.
Hello.
Yes, doctor.
What are we doing now?
So we are waiting for more 2 minutes for
Okay.
Dr. Anjali Rana, and then if we cannot find her in the meeting and she's not able to present, so I think it's up to you to decide if she is eligible to share her presentation after 2 minutes or not.
Is there another session after this?
No, doctor, this is the last session at Hall Gangotri.
We can wait for another 5-10 minutes and give them.
Only 5 minutes.
Sure, doctor.
We'll wait for 5 minutes.
Yes, doctor, as you said.
This session is an important session.
We have Dr. Anjali Rana over here with us. Dr. Anjali, I hope we are able to share the screen?
Yes, sir.
Dr. Anjali, can I ask you to unmute yourself?
Hello, sir.
Yes, Dr. Anjali.
Yes, sir. I'll just share my screen again.
Yes, doctor.
Okay, great. Nice to see you, Amit, drinking coffee.
Dr. Anjali, have you tried sharing your screen? Dr. Anjali? She dropped out of the meeting again. To the participants over here, Dr. Shweta, Dr. Shrey, Dr. Amrita, do we have Dr. Anjali's number?
No, I think the organizing committee made calls to everybody.
Okay.
And Jasleen Singh's number, even that you don't have?
No, sir. I think organizing committee is the one who has them. They've been coordinating with them, sir.
Okay, okay, thank
No
you.
worries. Thank you so much, doctor. Dr. Anjali Rana, yes, we
Yes,
are
sir.
able to hear your voice also, and the presentation is visible. We'll start the timer in the next couple of seconds.
Okay,
Please.
sir.
Welcome, Anjali. So we have been waiting for you for a long time now.
I'm sorry, sir. So there was some technical issue. I couldn't log in.
No problem. No problems. Keep your cool and present.
So can I start?
Yes.
So good afternoon, everyone. I'll be discussing a interesting case of monostotic orbital fibrous dysplasia, which led to proptosis in an 11-year-old child. So, the 11-year-old male who was a resident of Sambal district of Uttar Pradesh, he presented to us with the chief complaints of outward bulging of right eye, which was first noticed by his mother. He had this complaint for 1 year. Now, this proptosis or outward bulging of his right eye was insidious in onset. It was painless and progressive in nature, and it was associated with limitation in his up-gaze movement. He consulted some local hospital, but he was referred to our institute for further treatment. There was no history of any decreased vision, double vision, trauma, any recurrent cold or cough, any loss of smell, any weight loss, any similar swellings in other parts of the body, any complaints of headache, vomiting, seizures, any focal neurological deficit, or any personality changes. So on examination, we found out that the right eye had unaided visual acuity of around 6 and 6 parts. We did cycloplegic refraction for the patient, and we found out that he had an acceptance of -0.5 diopter spherical. His head posture was maintained and his facial contour was symmetrical. The pupillary reaction of right eye was absolutely normal with normal size and normal reaction. The extraocular movements we saw was restricted in up gaze with -1 and -2. The anterior segment was within normal limits, and the posterior segment was also within normal limits with healthy disc and retina on. We further did some color vision testing for him, which was within normal limits. Contrast sensitivity was done by Perry-Robson chart, which was also normal. On Herter's exophthalmometry, we found out that the right eye was proptosed to a degree of around 22 mm total as compared to the normal left eye, which was 14 mm, which was at a base diameter of 98 mm. For doing the local examination, we found out that the proptosis was non-axial, it was non-tender, non-retropulsive, non-pulsatile, and it did not increase in size by Valsalva or cuffing. So we went on further with some basic blood investigations, and we found out that his complete blood count, LFT and KFT, were completely normal. We further did with some USG-B scans, and we found out that the posterior segment and the intraconal compartment was also normal. We asked the child to get some non-contrast CT scan done, and in the CT scan took us to some diagnosis. We found out that there was some lytic expensile lesion, which is shown by the red arrow in the first diagram. It involved the orbital part of the frontal bone, and it was bulging into the superomedial part of the right orbit. There was a ground glass matrix, which is shown by some yellow arrow in the second diagram, and this bulging was associated, it was compressing the right superior rectus, superior oblique, and it was lying just near to the medial rectus. So the CT scan, the radiologist gave us a diagnosis of fibrous dysplasia. In order to rule out any invasion of brain parenchyma or any optic nerve involvement, though there was no any clinical signs present in the patient, just to rule out, we ordered some contrast enhanced MRI, and we found out that the swelling got enhanced and it did not had any further invasions. So we started with some surgical intervention because it was an appropriate choice for our young 11-year-old child. It was done by the neurosurgery department of our institute, and they did some right pterional craniotomy for the patient. They took out the lesion and they decompressed it. They sent the tissue for histopath, and they found out that the features were suggestive of fibrous dysplasia only. It has some osseous and fibrous cells as shown by the black arrow. So post-operatively, we followed the patient. We found out that the patient was perfectly normal with full-on GCS. The visual acuity was as usual, as before 6/6. The pupillary reaction was normal. The extraocular movement of right eye has decreased restriction now in up gaze. The anterior segment was also normal. Posterior segment before was also normal. Color vision contrast sensitivity was normal. And the interesting thing was that the proptosis got reduced in the right eye from 22 mm before to 16 mm now, at the base diameter of 98 mm. So this is the post-operative 9-gaze photograph of the child. As you can see, there is slight restriction in the up gaze. The rest cases seems to be normal. So finally concluding it, I conclude that fibrous dysplasia is a rare cause, though a rare cause of gradual painless proptosis in young children, but it should be kept in the bucket list, keeping in mind that that timely and multidisciplinary approach is needed for the patient so that their vision can be salvaged. Prophylactic decompression is still a controversial topic in fibrous dysplasia, but it was the right choice for our patient since he was only 11-year-old, and we could consider it keeping in mind his lifelong visual, we could prevent his disability. So there were also some medical treatments that are also available, but like bisphosphonates and tocilizumab, but their long-term use in children is still needs some further research. So we prefer the surgical approach better. Thank you so much. Thank you so much for your patience. I had some technical issue. I'm very sorry.
Yeah, thank you so much. Dr. Anjali, there was no diplopia on up gaze?
No, sir, the child did not complain of any diplopia or double vision.
Did you examine for diplopia and up gaze?
Yes, sir, we examined, but the child did not complain it.
And on cover test, were there any findings on up gaze?
No, sir.
Did you get a thyroid test done before going in for CT?
Yes, sir. We did the thyroid test. They were also normal.
So you mentioned the thyroid reports there?
No, sir. I haven't mentioned it, but they were normal only.
Okay, right. Thank you.
Thank you so much, sir.
Judges, do we have any other questions from Dr. Anjali Rana?
Dr. Amit?
No, I think it's enough. No, this I think it's good enough.
Yes.
I think we can give our judgment, and Vinod is there. I think I can see Vinod.
Well,
So we
that
have
is
to give it to him individually on his personal WhatsApp.
Yeah.
Dr. Amit?
Yeah, Vinod is there. He's going to comment, I think.
Yeah.
Vinod, you unmute yourself.
So that means only 4 candidates were there. Dr. Jasleen has not come.
Dr. Jasleen has not come.
Yeah.
Right.
So we finish off the session then? Dr. Amit?
Yeah, I think so. Vinod,
Okay,
any
right.
comment?
Looks all right.
Vinod is there, I think.
I haven't seen this session. I was busy in another session.
Dr. Vinod, one candidate has not come, Dr. Jasleen.
I tried to contact him, send him a message also, on mail also, but probably didn't get the message.
So we carry on with the 4 candidates and finish off the session?
Yes, you have to do.
That is amazing. Thank you so much, Dr. Amit Tarifdar and Dr. Jaideep Datta.
Right,
Also,
thank you,
Dr. Saurav Luthra, who has left for another session, but it was great having you over here. And we are really thankful that you help us coordinate and complete this session at Hall Gangotri on time. Thank you so much once again. I am your MOC Purnish Paliwala from Team Nikhil Khetri and Grover Audio Visuals, signing off for today. Thank you so much.
Right. Thank you so much. Thank you, everybody. Thank you.
Dr. Jaideep.
Thank you so much, ladies and gentlemen. You can leave the meeting accordingly. Thank you.
Thank you.
Rakesh sir.
Ramesh sir.
Ramesh sir. Done sir. Okay. Good night.
गुड नाइट. खत्म हो गया ना, बंद कर दो ना.
जी सर, बंद मत कीजिए, बट यहाँ के सब सेशंस खत्म हो चुके हैं जो आपने साइंटिफिक प्रोग्राम में दिया था. सो बस और कुछ है नहीं अभी.
सेशन एंड करो ना, मतलब कि वेबिनार खत्म हो गया ना, अब तो नहीं है ना.
एक बार आप सर से बात कर लीजिए.
ओके ओके, नो प्रॉब्लम.
आपके हिसाब से देख लेना.
ओके ओके
ओके. थैंक यू सर. अगर कुछ इम्पोर्टेंट रहेगा तो प्लीज मुझे कॉल कर दीजिए.
ओके ओके.
तब तक मैं लॉग आउट कर रहा हूँ.
ओके
ओके. थैंक यू सर.
थैंक यू.